Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. How are you today? I hope the ladies and gentlemen, the all committee, the all participants, and all of us are always healthy and happy. Today we will continue this seminar with speakers who are no less great than yesterday. For that, I represent the committee. Hope that all participants will be able to take part in this session well. And of course, it can be useful for the development of knowledge in us. Before the conference starts, I would like to say that this event was held because of the good cooperation of various parties. For that, on behalf of the committee, we would like to thanks to all those who have supported the success of this event, such as the academic community of the Gorontalo Health Polytechnic, the all sponsors, Midwifery Alumni Association, and the Indonesia Midwife Association branch of the Health Polytechnic Gorontalo. Okay, this is the moment you have been waiting for it. I have received a notification from the committee that the conference will start with the speakers Patricia Alens, PhD at the LDN from Virginia State University, USA, with the topic Nutrition Status and Diet Management in the Prevention of Hypertension in Pregnancy. And the moderator this session is Mrs. Rahma Dewi Agustini, SST, MCAP. So, Mrs. Rahma, it's your time.
Okay, thank you very much, Mr. MC, Mr. Fahmi Soaiba. By the way, I'm still Mrs. I'm still Miss, ya, not Mrs. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to the second day of the third international conference on Midwifery and Health Science 2023, focusing on the theme of health transformation to prevent hypertension in pregnancy. It is an honor to have all of you here today, gathered to discuss and explore innovative strategies in the field of midwifery and health sciences. It is with great pleasure that I, Rahma Dewi Agustini, will be your moderator for this session. So, pregnancy is a crucial period in woman's life, and hypertension during pregnancy can have serious implications for both the mother and also the fetus. Hence, it is vital for us to comprehend the relationship between nutritional status, dietary patterns, and also the hypertension in pregnancy. And Gorontalo Health Polytechnic, especially midwifery department, wants to give a positive contribution to reducing the number of hypertension in pregnancy through nutrition through this conference. And for that, we have a speaker who already is with us. We have Dr. Patricia Lins, who already joined in the Zoom meeting. And I would like to greet Dr. Patricia Lins first. Hello, Dr. Patricia.
Hi. Are you able to hear me?
Okay, good night. I think it is night in USA, right?
Yes. Yes, it is.
Okay, today Dr. Lins will sharing her valuable insight and the topic of nutrition status and diet management in the prevention hypertension in pregnancy. Her presentation will provide us with a comprehensive understanding of the crucial link between the nutrition and the prevention of hypertension in pregnant women. Through evidence-based practices and innovative approaches, she will highlight the significance of the well-balanced and its impact on the maternal health outcomes. I'm going to do our presentation for about next 2 hours, and Dr. Lins will talk for around 100 minutes. And after Dr. Lins has presented her topics, we will have a discussion for about 20 minutes. Okay, before Dr. Lynch deliver her material, I'm going to read her profile. Committee, please share the curriculum vitae of Dr. Lynch. So, Dr. Patricia Lynch, PhD, RD, LDN, have a very amusing educational background. She holds a PhD nutrition in University of Nebraska, Lincoln. After completing her magister in food and nutritional science in North Carolina, Agriculture and Technical State University, Greensboro, and after completing her bachelor in home economics, especially in dietetics, North Carolina A&T State University, Greensboro, North Carolina. She is a membership of several organizations and also community. Maybe there are Academic Nutrition and Dietetics, Virginia Academy and Nutrition and Dietetics, Society for Nutrition, Education and Behavior, National Kidney Foundation, American Society for Parenteral and Maternal Nutrition, and many more. And next, maybe. Committee. And then she is a registered dietitian and licensed dietitian or LDN. She had several experience professional. And the recent one is present associate professor or director or dietetic program dietetics in FCS Department, Virginia State University, Petersburg. And also from 2015 until 2016, become a clinical renal dietitian, Fresenius Medical Care of North America, Nash and Wake counties, and many more. And next. And she gets so many grants submitted, and the the most five reasons as a principal investigator in Guilford County for COVID-19 Hunger Relief Grant, and also COPI and collaborative program in nutrition, agriculture, and environment, and then learning and community outreach, COPI in social media, promoting healthy lifestyle, reducing childhood obesity with Faulkner, and many more. I'm sorry, I think because of the limitation of the time, I cannot read all of the curriculum vitae of the Dr. Patricia. And then next. Okay, I think this is Dr. Lynch, a very exceptionally remarkable. Hilang ya jaringan gue ya, gue kelempar. I'm sorry, Dr. Lynch, maybe I have some technical issue with my Zoom meeting. So that was a very exceptionally remarkable curriculum vitae of Dr. Lynch. So now, without further ado, I would invite Dr. Patricia Lynch to share her expertise and invaluable knowledge. Let us give her a warm welcome and our utmost attention. So, Dr. Patricia Lynch, the screen is yours. Thank you.
Thank you. Rama, are you able to see my screen?
Hello, Dr. Lynch.
Are you able to see my screen?
Okay, I think we cannot hear your voice clearly. Maybe could you please to increase your voice, Dr. Lynch?
What about now? Is it any better? So, should I begin? Are you able to hear me now?
I'm sorry, Dr. Lynch. We cannot hear your voice clearly here.
Oh, wow. Do you want me to stop and come back? Are you able to hear me now?
Yeah, it's better.
Okay. Are you sharing the screen or am I using my PowerPoint? Are you using the PowerPoint that you have? So are you able to hear me, Rama?
Hello, Dr. Lynch.
Hi, are you able to hear me?
Yeah, but it's not really clear here, Dr. Lynch.
Okay, I'm going to go out and then come back in. We're having a really bad weather here, and I
Okay.
don't know if it's back to you.
Yes, yes. We will wait for you.
Okay. Are you able to hear me now?
Uh, yeah, we can hear your beautiful voice, Dr. Lynch.
Thank you. Okay, so are you going to share the PowerPoints or you want me to? Will you share my PowerPoint?
Yes, please. Should I share your material, Dr. Lynch?
Please, I don't have the ability to share my screen. I'm disabled.
Uh,
Okay, so Rama, I'm going to get started.
yes,
So
please.
today, thank you. First of all, I'd like to say thanks for the invitation. Such a pleasure to sort of come back to visit. So I want to talk a little bit about the nutrition status and diet management and the prevention of hypertension during pregnancy. It is a big deal. The statistics of the number of women and infants that are part of morbidity and mortality is just outstanding. Too much we're losing. So I want to talk a little bit about what is the impact of nutrition on this whole scenario. And I also want to look at the process more than the intricacies. Because I think during the whole conference, people have spoken with you about the statistics of preeclampsia and of hypertension in pregnancy. So I want to look at mostly directly how does nutrition impact this whole process? And what do we do as healthcare providers to make sure that our clients understand what we're doing? Next. Okay, the exact pathophysiology of pregnancy-induced hypertension, which, you know, we've got hypertension, we've got preeclampsia and eclampsia. So the exact pathophysiology really is still unknown, but we do know that there are definite relationships between trace elements and preeclampsia and between diet and hypertension. Next.
I'm sorry, Dr. Lins, I have a technical issue with my Zoom meeting.
Okay,
I will share it for you again.
thank you. Okay, thank you. So the objective today, or the agenda, we're going to look at the nutrition care process. How does that work, when we're dealing with hypertensive issues with the mother? We look at assessment, diagnosis, medical therapy, and then what other issues like follow-up or monitoring. Um, I want to summarize the nutrition for a successful pregnancy. Then I'll explain some of the dietary approaches to stop hypertension, the DASH diet, and how we use that in medical nutrition therapy to treat hypertension. And then we want to look at some anti-inflammatory diet, because as a benefit in treating hypertension and other considerations for chronic and acute diseases. Advocate utilizing the team for collaborating in promoting the best practices for women that are going through pregnancy, especially concerning type pregnancies, those that we anticipate having some type of issues. And then a brief summary. Next. So we're going to get into the nutrition care process. Next. Okay, so for the first thing we do in terms of nutrition assessment for hypertension, one of the things that we really look very closely at is dietary patterns and factors that are associated with hypertension. I want to know what is the patient eating, what is their food frequency history, where are they purchasing their foods, how do they cook, all the things that might have some effect on their patterns of eating. And then we also look at nutrition-related histories. You know, are there alcohol abuse, or how much are they drinking, or how much multivitamins might they be taking? Is there a history of recommendations for fiber intake, or too little calcium or potassium or sodium? And then, of course, we take anthropometric measures. We're looking at height and weight and some circumferences. And then we look at nutrition-focused physical examination, where we look at the nails, the teeth, the eyes, the mucous membrane, the hair follicle, and this just skin tissue. You know, even look at the eyes, just to make sure that what we see relates to nutrient or nutrient deficiency or not. And then, of course, the patients will always have biochemical or labs done, so we take a look at those biochemical indices and see how they relate to what's going on. And then, of course, physical activity. Although we're not physical activity experts, we still want to know a little bit about assessing their physical activity level, because there may be some relationship to a recommendation to changing weight, or losing weight or increasing weight, or some weight issue factor, or just immobility. Next. So for people with hypertensive conditions, the nutrition diagnosis that we get or we make proposed to the patients are different than those diagnoses that are made by the medical profession. So ours may look at things like excessive energy intake, physical inactivity, overweight or obesity, excessive sodium intake, inadequate calcium or fiber, magnesium or potassium. And we see this once we look at the labs or do a 24-hour recall. And then we also look at the knowledge. You know, there may be a food and nutrition related knowledge deficit, may be part of the issue. Maybe the patient doesn't know that they're eating too much salt, or maybe they don't know that they're not eating enough calcium. Next. So the goal of the medical nutrition therapist is going to be, if they're not getting enough activity, we want to increase their physical activity in a way that's appropriate for the mother, and it's not being contraindicated by the physicians. We also, if the parent is smoking, we want to make sure that they're not smoking while they're pregnant. We know that smoking has a lot to do with increasing not just hypertension, but also a negative impact on the mother and the child in terms of preeclampsia. We also want to look at weight or weight loss if that's something that's indicated. And then the other issue is there an opportunity to lower the sodium intake? And do they know what's high in sodium as far as their diet and diet pattern is concerned? And if there is any alcohol consumption, does the mother know how much alcohol is maximum, in terms of making sure it's not impacting the infant or the fetus at that stage? And if they're not drinking, that's a wonderful thing. If they are, we want to reduce whatever it is that they're drinking. And then we want to recommend combinations of the DASH diet plus low sodium. Next. So nutrition intervention would be the next thing. So we tend to develop a nutrition care plan, looking at the patient, and of course, as we talked about yesterday with Dr. Dade, we are interested in the mother, and because that's the person that we can communicate with. So we are developing a plan for this mother that's based on their hypertensive history. And they want to take a comprehensive approach. You know, we're looking at all angles, all types of things that might impact her success in delivery. And then we create a dietary plan, which in this case we're talking about the DASH eating plans with recommendations. And of course, we encourage physical activity as long as it's not prohibited. And then we follow up with monthly therapeutic encounters. And that's probably for the first year. We like to treat that patient or see that patient every month. And as the patient may come in to see the physician, they will also see a dietitian. And then after a year, then we tend to look at quarterly um, monitoring encounters. And a lot of this I'm saying relates to the fact that we are preparing the mother prior to becoming the mother. We want to make sure that all the recommendations for nutrition is in place prior to even getting pregnancy. We know that if the mother is healthier in terms of her nutritional health, then her outcomes are better. Next. So what entails what nutrition for successful pregnancy outcomes? So we're going to take a look at those. A well-balanced diet, rich in essential nutrients, supports the mother's her need for energy. We know that if she's eating well, she doesn't have to worry about feeling tired and low energy all the time. It's going to maintain a healthy weight if she's eating well. A reduction in the likelihood of pregnancy complications, for example, not just hypertension, but also gestational diabetes and preeclampsia. It promotes the breastfeeding success. It also promotes postpartum recovery. You know, if she's in a good nutritional state, then recovery tissues and all those things that once a woman has a baby, her body is really taken through a lot of different metabolic changes, and it requires good nutritional support to bring her back to, let's call it, normality after delivery. Long-term health, as we would like for her to get, because if she's not in good health during, before, during, and after the pregnancy, then we're talking about impact of chronic diseases or some kind of chronic condition that may be with her for a lifetime rather than just through pregnancy. Next. So there are 6 essential nutrients, and obviously we're not saying that these are the only things that are needed for this woman. These are just some things that during the pregnancy or before the pregnancy, we want to make sure that we've taken a look at, not just the dietitian, but the team has taken a look at this woman. First of all, is her folic acid is crucial for proper development of the baby's neural tube, and this needs to be in place before the first trimester, because that's when the neural tube begins its development. It plays an important role in the formation of red blood cells, and it helps prevent certain types of anemia for the mother and as well for the fetus at that point. So folic acid, good sources will be your green leafy vegetables and fortified cereals and beans and peas and citrus fruits. And we go through this with the mother to make sure that she knows. She may not know what folic acid is, but we want her to know where do you find folic acid and what types of foods to eat. Next. And the second nutrient is going to be iron. It is essential for the production of hemoglobin, which carries oxygen to the baby and also prevents the mother from having anemia. It supports the growth and development of the placenta and the baby's organs. So foods that are rich in iron are going to be lean meats, poultry, fish, beans, and fortified cereals, and dark leafy green vegetables. Next. And then calcium. We hear a lot about calcium. We're going to hear even more a little later on about calcium. But calcium is necessary for the development of the baby's bones and teeth and muscles. It helps maintain the mother's bone health and prevent loss of calcium during her pregnancy. And women don't know if they lack calcium in their diets, they will find that their teeth will become loosened. I mean, their bones are going to be brittle. So it's really important that during this time while she's carrying this fetus that she's in good health, because the baby, the fetus, is going to siphon some of those nutrients that she has for its own survival. So good sources of calcium include dairy products, fortified plant-based milks, tofu, green leafy vegetables, and almonds. Next. And then we're looking at omega-3 fatty acids, DHA, docosahexaenoic acid, and it supports the development of the brain and eye development for the fetus. They also contribute to the prevention and promote healthy cognitive development. So sources are going to be fatty fish, salmons and sardines, and then chia seeds or flax seeds or walnuts. Vitamin D is absolutely crucial for the absorption of calcium and the development of the baby's bones and teeth. It also supports the mother's immune function and helps prevent complications, just like we're talking about preeclampsia and gestational diabetes. So vitamin D is going to be pretty important. Sunlight exposure is one of the best ways to get vitamin D. Fortified dairy products, egg yolks, fatty fish, and they're also good sources. Individuals with dark skins will have a little harder time with vitamin D in terms of sunlight exposure. You just may need to be getting a little longer sunlight exposure than lighter skin individuals. Next. So iodine is necessary for the production of the thyroid hormones, which are vital for the baby's brain development. Adequate iodine intake during pregnancy helps prevent cognitive and developmental issues in the fetus. So good sources are going to be iodized salt, seafood, dairy products, and seaweed. Next. Okay, we're going to look at practical management strategies as we talk with our pregnant mothers or pregnant women. We want to provide recommendations that they can regard nutrition in terms of being a prevention to hypertension. So we want to do this early. We suggest sample meal plans or dietary plans that promote optimal nutrition and reduce the risk of developing hypertension. Next. So lifestyle changes that have the most influence on blood pressure are going to be exercise. We know that exercise is extremely vital, whether you're pregnant or not. I mean, physical activity before pregnancy is going to be key to making sure that the mother's in good health. Stress reduction. We want to make sure that all those things that cause stress in this mother, and we're talking about social and mental type of stress, we want to make sure that she has some way to relieve that. If she doesn't know, then as a team, it's our job to help her find someone or some group or some practice that she can join or some ideas for her to do at home to reduce that stress. Healthy weight. We want her to maintain a healthy weight. Everybody's talking about weigh this amount and that amount and be this thin and that thin. We are interested in a mother having a healthy weight. Once that baby is delivered, she's going to lose weight rapidly. I mean, because part of the weight is going to be from just the fetal tissues. So we want to make sure that she has enough weight to support not just herself, but the delivery. And we want her to have a healthy diet. And what does that look like? We're talking about a diet that's high in vegetables and fruit and low in saturated fat and low in sodium. We want to reduce the sodium. We want to reduce the alcohol if that's part of the diet. Next. So we want to emphasize a balanced diet. You know, we don't want to eat the same thing every day. I know here in the U.S., sometimes I've had clients that they consider that part of their balanced diet might be something, for example, if I eat hash browns in the U.S. they do hash brown potatoes. So if I eat hash browns for breakfast, you know, with my sausage or whatever I eat, then at lunchtime I may have a hamburger or something with French fries. And then at dinner, you know, I may have something and then a baked potato with something else. So this is not a balanced diet because you don't need to be eating potatoes for 3 meals. You know, want to create not just a balance but also some variety in that diet. Want to increase potassium-rich foods, which means for the most part those green and those foods that are very colorful. We want to promote adequate calcium and magnesium, monitor weight gain, encourage regular physical activity. And it doesn't have to be that you're lifting weights and doing marathons. We can do moderate brisk types of walking as long as it doesn't impact the health of the mother or the fetus. Next. So now we want to look at the DASH diet, the dietary approaches to hypertension. So this diet was actually created some time ago, and the plan recommends eating vegetables, fruits, and whole grains. It also includes fat-free or low-fat dairy products, fish and poultry, beans and nuts, and vegetable oils. It limits foods that are high in saturated fats, such as fatty meats, such as full-fat milk, such as coconut oil and palm oil. It also limits sugar-sweetened beverages and sweets, concentrated sweet products. Next. So the DASH diet really was done in 1997. I mean, that seems like a long time ago for some of you. Some of you probably weren't even born then. But the DASH diet was one of the first really comprehensive studies that looked at adults and looked at how to stop hypertension or high blood pressure. So there were 459 adults in this study, and they compared 3 diets. Each contained 3,000 milligrams of sodium a day. One of them was the typical American diet, which probably is more than 3,000 milligrams of sodium today. And the typical, the second diet in the study was the typical American diet plus more fruits and vegetables. And then the third was the DASH diet. Next. And so the study provided all the foods and all the beverages for the participants. So this is sort of unusual in a lot of studies, but it became landmark because it controlled for a lot of things that as a dietitian or as people that are doing research, when we ask people to eat certain things, truly we don't know if they're doing that. So, but in this case, they provided the food, so there was no reason for us to suspect that the information is not accurate. So after 8 weeks, participants consumed more fruits and vegetables plus a typical American diet, or those on DASH diet had a lower blood pressure than those who followed the American diet alone. However, the participants on the DASH diet had the greatest effect of lowering their blood pressure. And that was key. That's what we wanted to prove. And then later, next, the next extension to this DASH diet was the DASH sodium trial, because people didn't believe that the DASH sodium actually did all of that for blood pressure. Even there's still studies out there that are trying to prove that sodium doesn't have a whole lot to do with lowering blood pressure. And I even read one recently that, obviously was contradicting this one, but this study looked at 412 adults who followed either a typical American diet or they followed the DASH diet. The study again provided all the foods and beverages to the participant for 1 month. Now, this one wasn't quite as long as the other study, but their daily sodium intakes were either high at 3,300 milligrams, which was similar to at that time, the current U.S. daily sodium intake, which is about 3,600 milligrams, at 2,300 milligrams was the second one. And then there was a low intake of 1,500 milligrams of sodium. Yes. So on this trial, the DASH sodium trial, reducing daily sodium lowered blood pressure for participants on either diet. If we reduce the sodium, it lowered blood pressure for participants on either diet. However, the DASH diet plus the low sodium 1,500 milligram lowered the blood pressure more than the typical American diet at all three daily sodium levels. So blood pressure decreased with each reduction of sodium. Next. Reducing sodium intake and following the DASH diet is more beneficial for lowering blood pressure than following the DASH diet alone or reducing the sodium alone. So the benefits of a reduced sodium and DASH diet were observed in those with and without hypertension. It was seen in men and it was seen in women, regardless of race or ethnicity. Next. And then in I think this was 2017, they did this optimal macronutrient intake trial for heart health. This was called the OmniHeart study, and it included 164 adults who had systolic blood pressure readings ranging from 120 to 159 millimeters of mercury, and the diastolic pressure ranging from 80 to 99. The study compared 3 diets, each containing 2,300 milligrams of sodium per day. Yes. So the DASH diet alone was used. The DASH diet, and then substituting 10% of the daily calories of protein, of carbohydrates, with protein, with about half from plant-based proteins. And then the DASH diet substituting 10% of the total calories of carbohydrates with unsaturated fat, mostly monounsaturated. Next. The study provided all the foods and beverages to the participants, as we have seen in the other ones, and they followed each diet for 6 weeks, with a 2 to 4 week period between each diet during which they ate their own food. So the OmniHeart diet found that either variations of the DASH diet by partially substituting carbs with either protein or unsaturated fat for 10% of the calories reduced blood pressure and improved the lipid levels more than the original DASH diet. Next. So now let's take a look at the anti-inflammatory diet. So one thing we do know is next. We do know that chronic inflammation is characterized by oxidative stress, and we talked a little bit with Dr. Dave about the pro-inflammatory cytokines and things that line the walls of the vessels. So these factors together play an important role in raising the blood pressure during pregnancy. So some of those things that increase inflammation and oxidative stress include frequent intake of red processed meat, frequent consumption of high sugar beverages, high visceral body fat around the waist, physical inactivity, and smoking. So those that decrease oxidative stress includes what we're promoting here in the DASH diet, regular intake of colorful fruits and vegetables, fish, nuts, olive oil, dried beans and peas, whole grains, adequate intake of water, and physical activity. Next. The anti-inflammatory diet looks at whole foods, plant-based diet with minimal processed foods, a variety of fruits and vegetables, a diet that's low in saturated fat and omega-6, devoid of trans fat, animal fat, high in monounsaturated fats such as those found in olive oil, low in refined carbohydrates and sucrose, and high in whole grains. So the anti-inflammatory diet includes lean protein sources such as chicken and fish. It limits eggs, red meat, butter, and other full-fat dairy products. It includes spices such as ginger, curry, turmeric, rosemary, because they have anti-inflammatory properties. It includes good sources of phytochemicals or phytonutrients that are found in fruits and vegetables of all colors, such as berries and fruits and leafy green vegetables. It also includes cruciferous vegetables such as cabbages and broccoli, Brussels sprouts, and soy foods, tea, and dark plain chocolate in moderation. So dietary recommendations for other conditions dealing with hypertensive. So we look at chronic conditions, which is a little bit different than pregnancy-induced hypertension, because this was prior to onset of pregnancy. So it predates the pregnancy. So the MNT for that, we are saying the DASH diet and regular aerobic activities and exercise if without complications, reduction in excessive sodium, calcium supplementation for low calcium intakes, and on the pharmaceutical side of things, antihypertensive medication until breastfeeding starts, and then of course it has to be modified. And then gestational hypertension, this is the optimal periconceptual nutrition that focuses on folate. We're looking at sodium, calcium, potassium, iron, copper, and zinc intakes. 1 in 10 women that are gestational, hypertensive, and obese may develop preeclampsia. Paternal factors, and I think we discussed a little bit yesterday, are seen, or at least a study or so has shown that it may involve the father. Some paternal factors include advanced age, obesity in the father, a family history of early onset of cardiovascular disease, a history of following preeclamptic pregnancy, or being born into a preeclampsia pregnancy himself. So some risk factors for preeclampsia, because at this time we really don't know. We truly don't know for sure. There are a lot of theories, and because the mother's body goes through a whole lot of metabolic changes, we don't really know. We know a lot of things. We don't know for sure the exact things, because it is a multifaceted type of condition that we don't know what it causes it. We don't know what we can do to prevent it. But for as much as we possibly can, we know that diet puts a woman in a better place to, let's say, weather the storm. So some of the risk factors for preeclampsia, we know if we can change the risk factors early enough, then we promote better and healthier pregnancy. And those risk factors include, and on the left side of it, we've got things that are related to nutrition. And then on the right side, you see different conditions, extremely high blood triglyceride levels, poor vitamin D status, as well as poor calcium status, consuming pro-inflammatory foods, consuming those pro-oxidative stress-related foods, obesity where there's central body fat, or being underweight. If the mother's extremely underweight, her risk for preeclampsia is just as high. If this is a first pregnancy, if she's hypertensive already or chronic hypertension runs in the family, or has a history of preeclampsia, if she's insulin resistant, she's diabetic, has renal disease, or a multi-fetal pregnancy, she's carrying twins or triplets, or heaven forbid quadruplets, if she's greater than or 35 years of old, which seems to be the place where most risk happens. And race and ethnicity also plays a part in what we see as risk factors. In the United States, the risk factors for race and ethnicity happen to be if the person is African American or Native American, they have a higher risk factor than the American whites. And then obstructive sleep apnea is also a risk factor. Next. Nutritional recommendations for intervention. So what can we do? We know that many of our patients come and they, regardless of what recommendations we make, a lot of times there are other things that influence whether they can consume the things that we're recommended. And so when we look at the recommendations, we also make sure that we have a team to assist families in getting the food that they need if that's an issue. So we're saying consume colorful vegetables and fruits. And sometimes it depends on where those colorful vegetables and fruits may be more expensive than those drab colored things or those packaged products. But we want to encourage this colorful intake of fruits and vegetables so they don't have to think about, is there enough minerals in it, if there's enough vitamin A in it or vitamin C. We encourage that colorful scheme for vegetables and fruits. Include frequent sources of fiber, such as dried beans and peas and whole grain breads and cereal. Replace the sugar-sweetened beverages with water. A lot of people don't like the taste of water, and a lot of companies are offering these flavored water with sodium and lots of sugar in it. So we still need to make sure that women know how to read labels, even though the water looks like it's fine, it's better than drinking a cola because the cola is dark color or whatever. But we have to make sure that we are not putting additional sodium or sugars into our bodies. And now we're coming out with something called mineral water and all these other types of water. So it is going to be important for pregnant women to make sure they read the labels to make sure they're not getting too much of something or too little of something that they shouldn't have. Use low-fat dairy products instead of full-fat dairy products. Use vegetable oils such as olive oil or avocado oil instead of animal fats like butter and lard and that type. Select poultry and fish and seafood, when you can, over processed meats and over red meat. Next. Advocating for a team approach to a successful preconception and prenatal nutrition. So the collaboration that involves that team, we're talking about a team of dietitians and midwives and medical doctors and nurses and social workers and other practitioners that are providing that comprehensive care for the pregnant women. It's really important that we are on a team and we share information. And I think the patient may not always know the benefits of what we do to assist them in their absence. For example, I have patients that may come in and the physician generally spends less time in America with the patient than other caretakers. So when the doctor asks a patient something, the patient may be more brief with the physician than he would be with the nurse. Or even in my case, I have patients that will tell me if they have a history of, let's say, of chemical dependency or a history of alcohol consumption, even though the physician may have asked because they may be looking at writing prescriptions that mean that you shouldn't have these types of things. And they may, and I'm not saying that they deliberately didn't tell them, they could have forgotten or whatever, but a lot of information that comes to us as dietitians or to us as nurses or midwives or social workers, it's important for us to collaborate because the patient doesn't always feel so ingratiating to tell everybody their story for whatever reason. It could be a cultural thing or it could be a social thing, but everybody doesn't feel that they should open or can open to every practitioner that they have because we don't know what backgrounds they come from and what's going on in their world. So many of them will not tell you everything. And so that's why it's really important for us as caretakers to make sure that we're getting information from them that can be shared with the whole team because we all have the same goal is to make the best maternal outcome as possible. And that's that team approach. Next. Okay, in summary, the risk of hypertension during pregnancy may be influenced by the mother's lifestyle and her food and nutrition choices before and during pregnancy. The DASH diet has been shown to be a safe and reliable treatment for women in preventing and treating hypertension. Because I think if we can treat hypertension prior to pregnancy, we may be okay in terms of preeclampsia for a lot of the women. Not saying that that will solve all of the problems, but I think a large percentage of people are not looking at what they're consuming. The anti-inflammatory food diet can be helpful in preventing inflammation, which we also know can lead to hypertension and other chronic conditions that have important dietary considerations. So collaboration with the interprofessional team can promote very successful pregnancy outcomes for the mother. I mean, communication is sort of key. Next.
Terima kasih Dr. Lins for very enlightening material. Okay, wait. Okay, thank you, Dr. Patricia Lins, for your very enlightening presentation on nutrition status and diet management in prevention of hypertension in pregnancy. So we have gained so much valuable insight into the crucial role of nutrition in maternal health and prevention of hypertension during pregnancy. I take some notes from your material, Dr. Lins, and some of them hits me so hard personally. such as we have to have a good lifestyle and doing exercise or increase the physical activity, and then lessen the consuming of sweet beverage. Actually, it's not not easy personally for me. Okay, I think we have so many questions in the chat box, Dr. Lynch. So we are going to the Q&A or question and answer session. I think we still didn't have a participant who raised their hand, so we are going to the question in the chat box. Maybe Kamati can share. Oh yeah, we have someone who raised her hand. We will start from Miss Nanda Wahyudi. Please, Kamati, to pin Nanda Wahyudi and also us to unmute so Miss Nanda can ask directly to Dr. Lynch.
Nanda, I think you're on mute. We can't hear you.
Okay, Miss Nanda, you can ask directly to Dr. Lynch. Please unmute your speaker.
Thank you very much, Miss Rahma. Good morning, Miss Lynch. I'm so interested with your presentation. I want to ask you some question. First, Miss Lynch, you said that we must consumption food contains folic acid, calcium, iron, omega-3, vitamin B, and iodine for prevent preeclampsia. And that micronutrient contained in our daily food. But now Indonesian people always eat food that contain that micronutrient. But why? Now Indonesian people still have preeclampsia in pregnancy. Why? Why still? Why? Yeah.
Well, as I mentioned now, even though nutrition plays an extremely high factor, there are other things that play a role in preeclampsia as well. So some of those other factors that we talked about, it could be a lot of other things, not just what you're consuming from your particular meal. And then sometimes we don't really know what's always in the meal. And if you're at home preparing your meal, then you probably have a good idea of what you're eating. But I don't know here whether there is a large group of people that eat away from home or not. Because sometimes when you eat away from home, you don't really know what's going in your meal necessarily. You hope you know, but many times, at least in America, if I were to go out for meals, most of the time the meals are a little bit more saltier than I would make my meals at home because it's tastier. Sodium is a flavor enhancer. And some of the other foods may be sweeter, especially, let's say, for example, a pound cake. A pound cake that I may make at home may not be very sweet, but if I went to a restaurant to have a slice of pound cake, it's going to be very sweet because they want me to come back or they want the children to eat this sweet product. And then they will put whipped cream and sweet cherries and a lot of other things that's even sweet on top of it. So a lot of it, it is about our behaviors, and it's also about the food that we eat, even food that we unknowingly know what we're eating. So, and then vitamin D is a big it's a big issue too. Now I know here in Indonesia, I don't know if you guys do vitamin D supplementation or not, but vitamin D, you do vitamin D supplements. So vitamin D is it's always a low intake, and a low intake of calcium. So
Yes, thank you, Miss. I wanna ask you about the supplement. How your opinion? Do Indonesian people must consumption that fortification, folic acid, calcium, iron, omega, vitamin D, and iodine for prevent preeclampsia? Do we have consumption that uh, fortification micronutrition like in the form like tablet or pill like that from not from the food we have in daily life.
it is always, from my opinion, to have your nutrients from your food, from your whole foods. Supplements are merely that. It is a supplement to your food because you weren't able to get all that you needed. Um, and I think people like to do over-the-counter stuff for women that are thinking about having children or pregnant. I don't mind that so much as long as some physician has done your labs and said, you're a little low on this or you're a little low on that. And then you know that you have a place to go and fix. But just taking stuff because you want to probably is probably not a good idea because we don't necessarily know what toxicity levels might be if you're trying to, have a fetal a fetus inside. So I think it's important not to say not to, but to make sure that if this is an addition to your meal, which is a supplement, then that's fine as long as you have a reason to supplement. Because I think young people, there's no reason that you can't eat typically enough food to have what you need. I think sometimes seniors tend to have other types of issues with absorption, malabsorption, or they have issues with teeth or sometimes excretion or something like that. They may have more issues in requiring more supplementation than young people. But during pregnancy, it does require more supplementation than you're probably able to eat. So that's why, here we do the prenatal supplements, make sure that the women have those during their pregnancy.
How about your opinion? If we want to consumption supplement when we before we get married, how do you how your opinions?
To
We
consume a
must
supplement
or not? We must consumption supplement or not?
before you get married,
Yes.
I mean, you're presuming that um, you have some kind of deficiency or malnourished or something like that, then yeah, because you want to make sure before you're pregnant that you're in good condition. So yeah, I mean, I would promote supplements prior to pregnancy, but that's saying that you have to know where you are, whether you are low on this or low on that, to make sure. Yeah.
Okay. May I uh, next question?
Uh, maybe we can move the next participant. Is it okay, Miss Nanda?
I wanna ask one question.
Okay,
Last question.
okay. One more question.
Okay. Thank you, Miss Rahma. Miss Lin, I wanna ask you, can food contains a lot of oil, coconut milk, and sugar can increase the risk of preeclampsia because Indonesian people consume consumption a lot of oil, sugar or glucose, and coconut milk, and we believe that food can increase our blood pressure. How about your opinion?
Um, if this food is high in saturate and if it's high in sugars, Um, yeah, there's a chance that it probably could, you know, if you're talking about saturated. Uh, but some of this, now, like I said, it is not just about about nutrients and food. Some of this rests on family history and other kinds of things. You know, if you know that your parents have high blood pressure, then you know that you should be doing something different to make sure that you don't have high blood pressure before you start conceiving. You know, and it's not, it's easier enough for us to check high blood pressure because, you know, at least here in the U.S., there is a blood pressure cuff in almost all the pharmaceutical, in the what do you call it, the pharmacies. You know, if you go to a sort of like a Walmart, or if you go to a place to pick up medicine, there's always a blood pressure cuff. You can go check it, you know, and it does. You don't have to go to the doctor or something like that. And of course, the university too. You know, you can go to the university and they'll do free blood pressure checks to make sure you're okay. But you at least need to know, you know, where you are. You got to have a baseline to start making assumptions about where you're going to go. You can't go someplace if you don't know where you are right now. It's kind of like going someplace, but where you going to go? You don't know where you are. So I would recommend, you know, knowing that baseline on whatever nutrient you're trying to increase, you know, to do that. Yeah. But see, the issue with sugar and some of those other things, you're not necessarily looking at preeclampsia more than you're looking at oxidative stress, or the more you're looking at pro-inflammatory stuff, or the weight gain and stuff that those other things may have impact. You know, I'm not saying the sugar by itself, but the sugar by itself can cause you to gain more weight, and gaining more weight can cause you to have issues with preeclampsia.
Okay, that we can consumption that food, but in the limited level.
Hmm. That's
Yes.
right.
Okay. Okay, thank you, Miss Lynch. Terima kasih.
Well,
Kamsahamnida.
Kamsahamnida. Thank you, Miss Nanda, for question, especially for your question about the supplementation before we get married. Okay, and actually in Gorontalo itself, we cannot live, we cannot live without oil, because oil is our life. Okay, and then we are going to the next participant who raised her hand. We have Mrs. Nancy. Ibu Nancy, are you with us? Okay, please come to pin Miss Nancy, so Ibu Nancy can ask directly to Dr. Lynch.
yeah. Hi, Nancy.
Is it clear?
What's your question,
Thank
Nancy?
you, Miss. Okay, thank you. I have a question. I've ever read that one of to prevent hypertension in pregnant women is to eat bananas, because bananas contains potassium. Maybe you can explain why is potassium can prevent hypertension. Thank you.
You're welcome. Yeah, potassium is one of those minerals that that has significant control of not just blood pressure, but the conduct of the heart, and in bananas or other types of foods. So yeah, it would, especially if you are deficient. So yeah.
Okay.
Dari potassium itu, potassium itu.
Okay, maybe next question. Uh, what kind of banana, maybe?
What
Or
kind of?
all of banana? The
You said
kind
what
of
type?
banana? The
Um,
type of
type
banana.
of banana. Um, right now, I'm thinking that all bananas contain a certain amount of potassium. I don't know in your country, because you guys have a lot of different types of fruit. In the
Oh,
U.S., yeah, one or two types of bananas are usually, in terms of genetically, they are about the same in terms of the nutrient content. Now the size may be different. The larger bananas, obviously you're going to have a larger content of the same types of nutrients. So, and a lot of it has to do with where, I'm sure where they're grown, what soil and all that kind of stuff. So I don't know the content of the different. I can't recommend a type of banana, whether it's one of the little bananas or the giant bananas. I think and I don't know the names of them, but some of them obviously are a lot sweeter, so you're looking at something other than potassium. You're also looking at a high level of fructose. So it depends on whether you want something that's really really sweet or one that's more fiber and a little more starchy than sweeter. So
okay. Next, maybe you can apa? You can explain kind of food has contain potassium. You can
uh,
mention of foods
besides your
has
bananas, um, leafy vegetables. And you will find some potassium in meats and nuts
okay.
and grains. Yeah.
Okay. Thank you, Miss Patricia. Thank you, Miss Rahma. That's
Okay,
all.
you're welcome, Miss Natansi. I think uh, all of kind the bananas is good as long as it's not fried banana, right? Okay.
Oh, that's
Uh,
forget. Yeah. Um,
I have some question. This is comes from myself to Dr. Lins. You mentioned that we need some six essential nutrient during pregnancy: folic acid, and then iron, calcium, omega-3, vitamin D, and iodine. And then, if we want to take a supplement in such as folic acid or iron, the indication we can examine it easily or cheap, such as to examine our hemoglobin level. But for the vitamin D level itself, I think to examine our level of vitamin D, it's expensive. And then the question is it okay if I take the supplementation such as iron and then folic acid or vitamin D in daily basis?
well, for you, vitamin D is probably good on a daily basis. I mean, because most of our garb is, you're covering your body, so you don't get exposed a lot to the sunlight. Um, and I don't know what your diet is, but we're talking about some meat products and dairy products and stuff like that. But there are labs, obviously, just like you said, they're going to be expensive. But if you know, we don't always have to do laboratory work and wait for the results. But we also know that if we do a nutrition intake assessment, that also lets you know how much of these nutrients you're consuming. And usually it's pretty parallel to what's in your bloodstream unless there's some other issue going on. So yeah, you don't always have to have let's say an expensive lab or some kind of test. You could certainly supplement knowing what your intake is already.
Yeah, yeah. Because I ever followed the seminar from the doctor that vitamin D can prolong our telomere. So it is very good for our health. So, and then I have an anemia for a long time, and then I don't know my level of vitamin D. So I ever decide to take a supplement vitamin D in daily basis. But some of my friends told me that uh, actually the exposure of a sunlight is enough for us. So this is is it back impact to take a vitamin D supplementation in daily basis, Dr. Lins?
Well, I don't think people typically get enough vitamin D. You
Yeah.
know, women. I don't think we get enough vitamin D.
Yeah.
And then if you're thinking about getting pregnant, part of that is going to be, do you have enough vitamin D and calcium to ensure that your bones are not going to be lost, during pregnancy? Because the fetus is going to take a lot of your calcium away, and vitamin D is going to help, build calcium. One thing that I do know is I've had patients that find that they lose their teeth or they get real loose during pregnancy and they don't understand why. That's because they didn't have enough, vitamin D during, prior to pregnancy. And it really, I mean, you can lose your teeth. I mean, as simple as it sounds, it's almost like, not really, I'm not going to lose my teeth. I'm just having a baby. Yeah, but the baby is going to take what you have to support them, and you can't control what the fetus is pulling from your reserve. So, yeah.
Yeah, that is very scary for me, so I will continue my supplementation, especially in vitamin D. I don't want to lose my teeth when I get pregnant. Okay, I think we have so many questions in chat box. Maybe committee can help me to share the question. Okay, the first one, we have a question from Nurfa Ida. For pregnant women who have a story of taking antidepressant, will there be a contribution to increasing the risk of hypertension during pregnancy? Are there any tips for increasing the nutritional value of ultra-processed food so they can still be consumed by pregnant women? Dr. Lins, please.
Um, let's see. Okay, so for the ultra processed foods, that would be, I mean, you want to stay away from processed food as much as you can because processed foods are going to have um, some of the risk factors that we are trying to avoid, and in terms of the antidepressant, it depends on what you're taking and whether or not there's any drug nutrient interaction. And your doctor will tell you that, because some of those things may interact with some nutrients that you don't want to lose before you're pregnant. So that would be one that you need to talk with your physician about. But there are medications, depends on what they are. They have a history of interacting with something. You don't know what that is. So, but if you're taking something for your general well-being and your mental health, it's something that you're not going to want to take light. You're going to want to make sure that you can continue with your treatment, but do it in a way that the physician knows so that it doesn't interact with either your nutrients or with your fetus. And in terms of the ultra processed foods, so so what is your concern about those? Because processing any food is less nutritious than eating that food whole when you can. So talk to me about the ultra processing.
Okay, maybe ultra processed is a meal that is cooked and then we cook it in the morning and then afternoon we cook it again.
Oh, I see.
Yeah, yeah. And then tomorrow, because there is the rest of this meal, we cook it again.
Okay. Well, that's I guess you can look at that as being over processed, but in terms of changing it, are you not making any additions to it or changing the let's say, for example, if you cooked it the first time and it, if you're making a sauce or whatever and you've got some spices there. So the second time around, are you adding more, let's say, sodium or coconut milk or some of these other things to make it ultra processed? Or you just warming it? I mean, because if you're just warming food up, I mean, you can look at that as ultra processed, but if you're just heating it for the next meal, then that's no different. I mean, that's not necessarily ultra processed more than when you're looking at corporations that package foods that are more ultra processed, you know. Um,
Okay, I'm sorry, I have mistaken. So I just confirm with the someone who give this question, Dr. Lynch. So the meaning of ultra processed foods in this question is like coconut milk in packaging, that in the retail, or ultra milk pasteurisasi milk.
yeah. Um, Pasteurizing milk is, the ultra process of pasteurizing milk. You're okay on milk pasteurization, because that's one of the things as a pregnant woman, you're going to want to drink milk that's been pasteurized. You can't drink milk that hasn't been, because now you run the risk of a foodborne illness or bacteria infecting the womb and just different things dealing with disease that while you're pregnant you don't want to incur.
Okay, thank you so much for the answer of this question, Dr. Lynch. Maybe we will continue the next question.
Okay.
Yes, it comes from Wahyuni Priyanti. I think she is a student of Poltekkes Gorontalo. So the question is, economically, not all pregnant mothers have the chance to get the same nutrient. Then what about pregnant women who already have hypertension, who can follow a healthy diet by adjusting their economic adequacy? Is there any response to this?
So I think that a lot of our food choices, I know in America, and I saw it during COVID, where we had people that really couldn't afford fruits and vegetables, because they just didn't have the money. And a lot of people had lost their jobs and there wasn't work during COVID because nobody was going to work and they weren't leaving their home. So one of my volunteer jobs was that I worked with the farmers to bring foods to some of those women, that couldn't afford the food because economically that's an issue. So it doesn't change the fact that we have some issues long term dealing with economics that is beyond that home. So there has to be something in the community, a community resource that that helps. I know what we do when I talk about the team, on the team is a social worker or a community sponsoring agency. So a lot of times when we meet with our patient, our pregnant mothers or those mothers to be, and they let us know that economically I can't afford to buy this type of food, for my family right now. So then we go out into the community and trying to find resources for them, So and obviously you can adjust the diet if you're talking about buying something that's always fresh and going to the market to get that. Generally, the fresh foods probably are a little bit more expensive than the canned product. I'm not real sure, or the frozen product. So in that sense, you could adjust your choices. If you can get something that's canned, that's low sodium, and look for water pack rather than a brine or salt pack product, that may be better and healthier if your choice is not to be able to go to get the freshest thing on the market, you know.
Okay, thank you, Dr.
But
Lynch, for,
you're welcome.
yeah. Is there any addition, Dr. Lynch?
No, I was going to ask you, does that, and see, because it's kind of hard to, you know, we're in two different places, so sometimes what you may have access to is different than what other cultures may have access to. But it doesn't change the fact what creates the healthiest outcome doesn't always mean that that's what we are able to do at the time, you know. So we look for alternatives. So part of those alternatives is looking for how do we find this type of food with the same amount of nutrients in it in a different place, in a different form. Is a canned product so much less nutritious than a product that's fresh or frozen? So we look at those as alternatives. And if we're in a place where we call it food desert or food insecurity exists, then we look for places where we can go and pick up food or have food sent to places where people can have access to, you know, without a cost, without it being burdensome. But part of that means that you have to have a system in your community in place too that shares, you know, or whether it's a family type thing or whether it's in some cities it becomes a community center or some place where you can go and get food, you know. So
Yeah, I think this problem is not only the task of the government, but also we as a society, we can help each other to fulfill the need of food, especially for the pregnant woman. Yeah, thank you, Dr. Lynch. Maybe we will go to the end of the last question. Actually, we have so many questions, Dr. Lynch, but we have the limitation of the time. So we will go to the last question from Nur Safriani Mayang from the Gorontalo Health Polytechnic. I have read that consuming citrus fruits can cause babies to have a yellow color. Whereas what I know, oranges are a good source of fiber and vitamin C for pregnant women to consume, especially in reducing complaint of constipation in trimester 3. What do you think about things?
well, oranges tend to have more vitamin C than I would say carotene, which is vitamin A. The thing that tends to cause the color, the change in colors, you know. But, you know, obviously some people do from eating stuff like, I would say like more like carrots, you know, or even maybe sweet potatoes or something like that. But it's not so detrimental, you know. So, and you're talking about in children, or you're talking about in the adult?
Yeah, I think that orange fruit can make the baby yellow is such a myth. Is that right, Dr. Lynch?
Orange fruit?
Orange fruit can make the baby yellow.
I mean, it's a temporary skin tone, maybe. You know, like I said, carrots is the only thing that I know, not necessarily other fruits. But I'm not sure of all your fruits here, but I know carrots. I've seen that in children before, but it's not it's not concerning. I put it like that, because it goes away. It doesn't, you know. They have to be eating a really, really lot of carrots for a long, long time for that to happen. And I think because you're eating a variety of different fruits and vegetables, I can't imagine eating that much that the baby's gonna turn yellow.
Okay, thank you, Dr. Lynch. So I think we are in the end of this session. Thank you very much, ladies and gentlemen. With that, we have come to the end of the question and answer session with Dr. Patricia Lins. We would like to express our sincere appreciation to Dr. Lins for her enlightening presentation and for graciously sharing her expertise with us today. Also, we also extend our gratitude to all the participants who actively engaged in this session, posing insightful questions and contributing to this enriching discussion. Okay, before that, I would like to give you a certificate of appreciation, Dr. Lins. Please kindly receive it, even though through Zoom meeting. Thank you very much. I know you are very kind and very dedicated to this conference. You are really helpful. Thank you so much. We really hope to meet you again, maybe in USA, maybe someday. Amin. Thank you so much, Dr.
Maybe
Lin.
I'll come
And
back.
once
I'll
again,
come
thank
back
you,
to go and follow.
all of you, for being part of this third International Conference of Health Sciences. We wish you success and fruitful discussion to the upcoming session. Once again, thank you so much. Terima kasih. Sarangnya kamsahamnida Dr. Lins. Bye-bye. Mana Fahmi? Mana Fahmi? Fahmi.
Okay, thank you, Mrs. Patricia and Mrs. Rahma Dewi Agustini. So, let's continue with the next seminar sessions with very great speakers, of course. But before we start, once again, I want to remind to the all participants to come on us if anyone is still confused, because when else can we all ask great sorts. Then we hope to be sure to be even more artistic. Thank you all. And the last, then we enter the presentation from the next research speakers. Mrs. Ai Tanimizu from the WHO Regional Office for Southeast Asia, Seattle, India, with the topic whose support to strengthening midwifery in the Southeast Asian region, and who will be the moderator, Mr. Muhammad Arif Ismail. So, Mr. Muhammad Arif, it's your time.
Yeah. Right. It's too close. A very good morning to ladies and gentlemen. Welcome back to the third International Conference on Midwifery and Health Sciences 2023. My name is Arif, your moderator, and we shall proceed to the next plenary session. And just before we get into the presentation, allow me to briefly introduce you to our speaker in this session, Ms. Ai Tanimizu. I hope I pronounced your name correctly. Yeah, so Ms. Ai Tanimizu is currently working in the World Health Organization Regional Office for Southeast Asia as Technical Officer, Nursing and Midwifery. Ms. Ai has previously worked for nursing and midwifery development in a range of countries: Canada, Kuwait, Bangladesh, and Qatar. In her roles in Canada, Kuwait, and Qatar, she was involved in projects to increase nurses' expertise in disease-based cancer nursing, mentoring specialized oncology nursing, developing nursing policies and procedures, and strengthening specialized cancer clinical services. In her time at WHO Country Office for Bangladesh, she worked with the Ministry of Health and Family Welfare's Directorate General of Nursing and Midwifery and the Bangladesh Nursing and Midwifery Council to strengthen nursing administration, education, and services. Allow me to inform you, Ms. Ai, that you'll be given maximum 90 minutes for the presentation, followed with a 20-minute session. Right, ladies and gentlemen, I would like to invite Ms. Ai Tanimizu to deliver her presentation about World Health Organization support to strengthening midwifery in Southeast Asia region. Over to you, Ms. Ai.
Thank you very much for the warm welcome, and thank you, Mr. Mohammed Arif. I know my name is not, my first name is easy, you just pronounce it I, but I know with the last name, Tanimizu, it can be difficult. But it's such a pleasure to be here with you with the third International Conferences on Midwifery and Health Sciences 2023. And just last week, actually, I was in Indonesia. There was a big midwifery conference in Bali. Yeah, so I was in Indonesia, and it's just such a pleasure that I feel like I've never left because I'm part of this conference today. So thank you very much again for the welcome. So good morning, everybody, and especially to the Director General of Health Workforce, Ms. Ibu Arianti Anaya, the Director of Politekes Kemenkes Gorontalo, Mr. Mohammed Anas Anasiru, the committee members of this third International Conference on Midwifery and Health Sciences 2023, distinguished plenary speakers, and other participants from all over Indonesia and the world. So good morning, my name is Ai Tanimizu. I am the Technical Officer for Nursing and Midwifery at the WHO Southeast Asia Regional Office. We are located in New Delhi, India. So I'm gonna share my screen and let's see if this works out. Okay, so I'm sharing my screen, so I cannot see anybody now, but I trust that you can see the screen.
That works.
Okay, great. So I cannot, since I cannot see anybody else, I'll just be speaking, and then hopefully we can do the Q&A. But really, today's discussion is on what support the WHO Southeast Asia Regional Office has been providing to strengthening midwifery in the region. So to give you some background information, the WHO is an independent specialized agency of the United Nations. It was established on 7th April 1948 and it is our goal to ensure the highest attainable level of health for all people. So we have the headquarters. We work in 3 levels of the organization. So we have the HQ, which is the headquarters located in Geneva, Switzerland. The lady you see here is our Chief Nurse and Midwifery Officer, Dr. Amelia. So she sits in HQ. And then we have the 6 regional offices, one of them being the Southeast Asia region, again, located in New Delhi. Our neighbors are Western Pacific region, located in Manila, for example. We also have 150 plus country offices, one of them being in Indonesia, in Jakarta. So this is the way WHO works. Again, currently I sit in the regional office looking after 11 countries of Southeast Asia region. So what we are trying to do is really achieve the sustainable development goals that all the leaders of the world have agreed on, that by 2030, we want to achieve these 17 SDGs. Well, where does midwifery fit? You know, the main one that we're hitting is really the SDG 3 on good health and well-being, and ensuring healthy lives and promoting well-being for all at all ages. We really, you know, we're trying to reduce maternal, newborn, and child mortality, which is one of the key targets of achieving the SDGs. And what's the core of it? So we strongly believe that universal health coverage, or UHC, is the core of achieving this SDG goal 3. UHC means that all individuals and communities, regardless of where they are, you know, regardless of, you know, where they are in Indonesia, even in the hilly areas, or, you know, in the far out, rural areas, or in the smaller island, wherever they are, can receive that quality health services when someone is in need, and without suffering financial hardship. We know way too many cases where people are struggling because when they access health services, they're actually, you know, maybe not able to provide food for the family because they've used their funds that are available for health services, right? So we want to make sure that we, people that are accessing these quality health services are able to receive it when in need by a dedicated, passionate, motivated health worker without suffering any financial hardship. So again, what does this mean? Again, it will include the full spectrum of essential quality health service, from health promotion to prevention, treatment, rehabilitation, and palliative care. This is what we mean by universal health coverage. Some people think that we're actually talking about, for example, insurance, but having universal health insurance is only a component of UHC, or of universal health coverage. So we need to focus on having access, increasing access to health services, increasing quality of services to improve health, and that care does not cause financial hardship, and putting primary health care as the cornerstone. Really, the center of this should be primary health care. This is where we want to put our efforts and investments. How do we measure this? We measure it by outcome and output. So it's by improved access to quality essential health services, and really countries able to strengthen their health workforce. So this is from a health workforce department perspective. So how do we estimate the health workforce requirement in order to reach universal health coverage? So we actually look at the SDG tracer indicator. So what types of services do we really need to ensure that our communities can receive, versus how many health workers are there available in the country? So globally, currently, with the most current calculation, we still have a shortage of 10 million health workers needed to achieve and sustain UHC by 2030. So that's a huge number that we still have a shortage. And we also know that this number was pre-COVID. So we actually need to do new calculations, because COVID has really exacerbated health systems. And we know that some health workers unfortunately, you know, succumbed to the disease, or they wanted to leave the workforce. So therefore, we need to do another calculation to really see what the current shortage is. when we think about health workers and health workforce for universal health coverage, we break it up into this health labor market framework. The health labor market framework is really, if you think about it, how do we produce a health worker, and how do we make sure that our health workers are working at full capacity and are motivated and can provide quality services? Well, it really all starts from education, right? So at the left, you can see that we have our, students in high school. When they go out of high school, we want to make sure that we can, that they go for further studies, whether it's for health or other fields, right? They get to choose. And then after they do go through health education institutions, then they graduate, they get the licensing, then we have this pool of qualified health workers. Where after we get the pool of qualified health workers, some are employed, some are unemployed. We also know some are out of the labor force, and also others may migrate to other countries. So we do have this pool of qualified health workers. Let's say there are 100 graduates from one institution. Now, how many of those are actually getting absorbed by the healthcare sector? How many are going into the public sector? How many are going into the private sector? How many are actually out of labor workforce? Maybe they want to work, but they don't have any positions yet, which is the unemployed. Out of labor force might be, those that may have decided to expand their family, for example, and decided that they want to focus more on their personal life rather than having a career and contributing to the healthcare sector. Anyway, so after we have the pool of qualified health workers, some go into the healthcare sector. Some might even go to other sectors, right? Like you might be in education. You might be going into law school, like after being qualified as a health worker. Anyways, this is really the labor market dynamics that we see. And then, after they go into the health sector, we do have the pool of these health workforce that are equipped to deliver quality health services, which in turn is where we want to achieve, which is universal health coverage with safe, effective, person-centered health services. So this is how we really break it apart, and thinking of what policies are needed to implement in order to achieve UHC. Some of these policies that I'm talking about, you can see on the bottom here. So, for education, it might be, are there any policies on infrastructure or material, on enrollment of students? Are we going to try to get, the top students from high school to go into the health sector, or do we want to expand that to different, pool? It might be, for example, in some countries to get into nursing or midwifery, they might have to finish 10 years of education, or in some countries it's 12 years of education, prior to getting into these institutions. And then selecting these students. So who's going to get in? What types of teachers are we going to have? So these are I'm just giving you an example of what policies we think about when we think about strengthening the health workforce for universal health coverage. Oh, why am I going to that? Sorry. Yep. And so recently, there have been global activities calling for more investments in nursing, midwifery, and the health workforce. So in 2020, the World Health Assembly designated the year as the International Year of the Nurse and the Midwife. I'm not sure if you were all aware, but 2020 was the dedicated year for the nurse and the midwife. But we all know what happened in 2020. All of us were affected, and we couldn't really bring in much, actions, activities, or investments, or just really these high-level policy discussions that we really wanted, because all countries were struggling with COVID. And then in 2020 was also the year that the first ever State of the World's Nursing Report was released in 2020. And then in 2021, it was designated as an International Year of the Health and Care Workers, with the theme of protect, invest together. No surprise why, the World Health Assembly chose that theme, because we realized that we need to protect our health workers who protect the community. and we need more investments in order to do it. And we need to do this all together. 2021 was also the year where the State of the World's Midwifery Report was released, and this was the third ever SOMI report. And really, this is a no-brainer for this, for the participants here, but there is no health without health workforce, right? And so with midwifery specifically, we know that there are over 50 outcomes that can be improved by midwifery. So, not just looking at mortality being reduced, like the maternal, neonatal, or stillbirth mortality, we also know that it actually increases, psychosocial outcomes. So increase in satisfaction with pain relief, feeling of control in birth. We know that there's reduced anxiety in labor, reduced postpartum depression. We also know that there's less intervention use. We know that with pregnancies and childbirth nowadays, there's way more medical interventions than we need to. But we know that by really improving midwifery and implementing midwifery interventions, we can increase the spontaneous vaginal birth, and we can reduce other medical models and unnecessary medical interventions. We also reduce, or we know as a whole, we can improve public health in terms of increasing breastfeeding initiation, duration, birth spacing, contraceptive use, because midwives provide the whole spectrum of sexual reproductive health services, right? So we do know that there are over 50 outcomes, again, by investing in midwifery. And these are the new modeled estimates and how much deaths are averted with delivering midwifery interventions. So again, if you look on the left, for example, by achieving universal coverage of midwife-delivered interventions by 2035, we can avert 67% of maternal deaths. 67% can be averted, which is really saving 4.3 million lives by the year 2035. And if we have a less ambitious 25 increase in coverage of midwife-delivered interventions every 5 years, we can still avert 41% of maternal deaths, which is really saving 2.2 million lives by 2035. And then even a modest 10% increase of universal coverage of midwife-delivered interventions can avert 22% of maternal deaths. So you can see we're not saying that, if a country is short of midwives, that of course what we want to do is we want to make sure that the country has enough midwives so that it can provide the services for everybody that are in need. But we also know that it's very difficult for a country to just go from, let's say, 10% midwives to all of a sudden 100% coverage. So this is why this number speaks in volumes, because we know that even these modest increases can save a lot of lives by 2035. So globally, we do have the Global Strategic Directions for Nursing and Midwifery 2021 to 2025. This was passed as a resolution. This was adopted as a resolution in the World Health Assembly in 2021, in the 74th World Health Assembly. And there are 4 main areas or 4 global strategic directions that we are focusing on strengthening nursing and midwifery cadres. So we want to look at education, jobs, leadership, and service delivery. So these are the 4 buckets that really came out of the consultation globally on which areas to strengthen. For education, we want to make sure that our graduates are matching or surpassing the health system demand and have the requisite knowledge, competencies, attitudes to meet the national health priorities. In terms of jobs, we need to increase availability of health workers by sustainably creating nursing and midwifery jobs. We need to make sure to effectively recruit and retain the midwives and nurses and ethically manage international mobility and migration. In terms of leadership, we also know that we need stronger nursing and midwifery leadership. And so the strategic direction is to increase the proportion and authority of midwives and nurses in senior health and academic positions. and continually develop the next generation of nursing and midwifery leaders. For service delivery, we want to ensure that midwives and nurses work to the full extent of their education and training in safe and supportive service delivery environments. So we'll be talking more about what CRO has been doing to increase all these 4 pillars, but that will come later. Also, we do have this resource. This is a joint project by WHO, ICM, UNICEF, and UNFPA on strengthening quality midwifery education for UHC 2030. This is basically the 7-step action plan. I'm not sure some of you may have heard, but this is the 7-step action plan to strengthen quality midwifery education. We realized over and over that we're supporting the countries to strengthen education, but we learned from experience that we can't just focus on strengthening faculty and standards and curricula, for example, and just focusing on educating the students. We have the 7-step action plan, which starts with, if we want stronger or strengthening in midwifery education, we need to strengthen the leadership and policy first. So we actually need to we need to assess what types of leadership exists and what policy exists. We need to gather data and evidence. This is sometimes the hardest part as well, because we're not really able to have good data of midwifery workforce, or maybe any other health workforce, depending on the country. We need to build public engagement and advocacy, and then really focus on preparing educational institutions for education. So, steps 4, 5, 6 is more really the core work of strengthening education. And then step 7, really importantly, is to monitor, evaluate, review, and adjusting. We've learned from experience, that we need to follow these 7-step action plan in order to strengthen and sustain quality midwifery education. Again, I was discussing earlier, and I know that this is not the group that I need to really focus too much on this part, but this is from the SOMI report, that, there's a need for a wide range of sexual, reproductive, maternal, neonatal, adolescent health interventions across the life course. And actually, midwives can do a lot. They can contribute to a lot of these SRMNH interventions. So midwives, in some countries, midwives are seen that they are the attendants for birth. But we know that fully educated and regulated midwives can meet 90% of this need from, again, SRMNH intervention across the life course of sexual reproductive health, antenatal care, childbirth, of course, and to postnatal care and adolescent health and development. And some headline or some, focus that we learned from the SOMI report is that midwives can provide about 90% of these care needed, but they actually account for less than 10% of the global SRMNH workforce. The world needs 900,000 more midwives. And by 2030, the midwife shortage will be smaller, about 750, but still a major number that we need to meet. And most of these improvements will be in middle income countries and not in the low income countries, which is alarming, because this is where we need most of these interventions, because this is where we see in the low income countries where maternal, neonatal, stillbirth mortalities are higher. So just a summary of the background is that, we know that SRMNH is an essential component of the SDGs, and better services requires investment in the health workforce, and that midwives can play a pivotal role within this health workforce. So really, where are we now in midwifery, in the region? So when I talk about the Southeast Asia region, we cover 11 countries, as you see the flags here. We are a smaller region compared to other regions in terms of numbers of country, but population-wise, we house a quarter of the world's population. So that's massive, right? A quarter of the world's population lives in these 11 countries. I always say we are small but mighty, and Indonesia is one of the countries, one of our member states of the WHO Southeast Asia region. In CRO, or in the Regional Office for Southeast Asia, there are flagship priority areas that your health ministers and your health leaders have chosen. This is from the prioritization process that we've conducted with the Ministries of Health, and they have informed us at WHO that these are the 8 areas that as a region we should be focusing on. Strengthening midwifery falls under flagship priority 3 and 4. Flagship priority 3 is the unfinished MDG agenda on ending preventable maternal newborn child health deaths with a focus on neonatal death, and SDG 4 on achieving universal health coverage with focus on human resources for health or health workforce and essential medicines. And actually, we are currently in the middle of this decade of strengthening human resources for health in Southeast Asia region, 2015 to 2024. So, we only have 2 more years, this year and next year, to complete this decade of strengthening health workforce in the region. So what progress have we made in the region? When we look at maternal newborn health indicators, the region has actually achieved higher mortality reduction compared to the world during the last decade. So you can see the blue are the global indicators. For NMR is the neonatal mortality rate, MMR being the maternal mortality rate. You can see that we've had a significant reduction compared to we've had the most contribution to the global reduction. And then in stillbirths as well, you can see how much our region has contributed. And we are the one region that has had really significant progress in terms of better maternal newborn health indicator. However, it doesn't mean that, we pat ourselves on the back, we're good. No, because we still see a lot of women and babies dying, despite all this progress that we've been making. So currently, 7 countries are below the upper limit of the maternal mortality rate, and 4 countries, Bangladesh, Myanmar, Nepal, Timor-Leste, are on the track to achieve SDG target, the 2030 target. 5 countries have already achieved the SDG targets for neonatal mortality rate. Indonesia is one of the countries that have achieved the SDG target for neonatal mortality rate, and 4 are on track to achieve it by 2030. And 6 countries have already achieved the national ENAT target on stillbirth rate. So here you can see all the green that you see are the countries that have achieved the SDG global target for NMR or under 5 mortality rate. Yellow is expected to achieve country maternal mortality rate target or neonatal mortality rate. And then red is really these countries or these indicators where we have to increase our efforts to achieve country maternal mortality rates or the NMR or the under 5 mortality rate by 2030. So you can see, yes, we've done a lot and we've made really great progress. However, we still have a lot more to do. And this is what I wanted to show you in this slide. We are also in the middle of transitioning to midwifery models of care in the region. So some countries in the region have had the nurse midwife model where it was one profession. So this is where there's no distinct occupational group of midwives, as you can see on the left. So a lot of our countries have actually, we have not had any distinct occupational group, but some countries are transitioning to midwifery models of care. So as you can see in the middle, these are the countries that are really trying to move to having a distinct occupational group of midwives, and that's in process right now. So in India, for example, we have the nurse practitioners in midwifery program compared to, as you can see on the left, which is India's general nurse midwife model. Or in Nepal, we have the bachelor midwifery compared to Nepal of nurses with SBA or skilled birth attendant training. In Bangladesh, we have the registered midwives who have completed 3-year direct entry midwifery compared to the nurse midwife diploma model that Bangladesh has. And then you can see on the very right is Indonesia, Timor, and Sri Lanka, which is these countries have a distinct occupational group of midwives, sometimes being able to provide midwife-led continuity of care. And the colors that you see here, blue is the midwives that meet the ICM competencies, and then the orange or the brown circles actually present midwifery education that does not meet ICM competencies. So this is how we see, and currently this is where we are at really as a region on transition to midwifery models of care in the WHOCR. Actually, last week when I informed you that I was in Bali, I was able to go to one of the Puskesmas and actually receive one of the I met few midwives and was able to receive antenatal care service by a midwife. And I know that midwives also go for outreach, for example, community outreach in Indonesia. I think, again, within the region, Indonesia has been really advanced in terms of midwifery models of care, and being able to practice, within their scope as a midwife. So what does the transition look like? When we talk about transitioning to midwifery models of care, it is a dedicated professional cadre of midwifery. That's what we want, who can provide women-centered care and can provide continuity of care, promoting the normal physiological birth, and being able to provide health promotion and education, are collaborating with other health workers and the health workers team, and has proper referral systems. So really integrated into the health systems, and they're integrated into the community, and are involved in advocacy as well. So how do we achieve it? This is the work in progress. Again, this is something that at the global level we are thinking of, and we have some recommendations to support countries that want to transition to midwifery models of care. So we currently see 5 buckets. How are we going to achieve it? We want to achieve it by strengthening the midwife. And this is really looking at leadership, education, training, and regulation and legislation. Looking at health systems is really the workforce planning and management, and strengthening primary health care, because we want to, again, make sure that they're integrated into the current health systems, and that there's proper referral system, and that they're collaborating with other health workers. In terms of policies and regulation, we need to ensure that there's data and evidence. And regulation really here means like regulation of the private sector and other professions. We need to work with women, families, and communities, building public engagement and advocacy. I mean, in some countries where, this distinct occupation of midwifery is new, we need to really work with the women and families and community to increase awareness, and also increase uptake of their service. And then how do we do all this? We need to ensure that we're monitoring and evaluating. So this is the 5th bucket. And again, if I speak to maybe in a year, this might change, because this is a work in progress, and we do have experts that are discussing this right now currently at the global level on really how are we going to support midwifery, transitioning to midwifery models of care, and how are we going to achieve it. And again, if you see, some of these themes are very similar to the global strategic directions for nursing and midwifery, because again, this is how we feel that we want to support. So these were all the global ones. And for the region, for Southeast Asia region, we actually have a regional strategic directions for strengthening midwifery. It was initiated in 2020 with the goal to create a world in which every woman, child, and adolescent in every setting can realize their rights to physical and mental health and well-being, and has social and economic opportunities, and is able to participate fully in shaping prosperous and sustainable societies by 2030. Really, we want to make sure that every woman receives the care that they need, and that their child and their children are able to achieve, physical and mental health and well-being, and are able to participate fully into societies, into sustainable societies by 2030. The focus areas, again, this is very similar, because we're all really, trying to strengthen similar areas, right? Our governance and regulation, education and training, workforce planning and management, practice and service delivery, and research and evidence. So these are where you can see the 5 strategic direction areas with the guiding principles of how we're going to achieve. So, you know, the 5 buckets that I've mentioned, how are we going to achieve it? We think that there's, a cross theme, I guess, which is really we need to do this ethically, that it needs to be relevant. We need countries to own this project, or not just the initiative, but really strengthening health, the midwifery health workforce. And we need to increase leadership. We're going to do it through partners, and that we need to ensure quality in every aspect of the work we do. So in terms of governance and regulation, so, you know, we need to make sure that the midwifery workforce is regulated through regulatory bodies or authorities that take responsibility for developing and maintaining quality midwifery services to respond to the needs of the population. And so when we look at government chief nursing and or midwifery officers in countries of the Southeast Asia region, all countries do say that they do have a government chief nurse midwifery officer. Now, this can vary. Some GCNMOs are actually maybe they sit in a tertiary hospital and they are the government chief nurse appointed for the tertiary hospital. Some of them are actually under the Directorate of Health Services, for example, in the Ministry of Health. Some of them have their own Directorate of Nursing and Midwifery, like Bangladesh, for example. And then others can sit in the Health Workforce Department or in the Health Workforce Council, right? So that probably sounds familiar to you for those in Indonesia. So it really does vary in terms of this position or role of the government chief nurse midwifery officer. So again, some, you know, it's not, we cannot compare apples to apples here, because not all of them have the same roles. But we do know that in principle that all countries do have a GCNMO. And, you know, midwives, when we look at how many midwives are in leadership positions, you can see, let me get the mouse here. So in Southeast Asia, there's only about 29% of countries with midwives in leadership in the national ministries of health. So this is quite low, as you see, because the global average is 51%. Right, so in our region, we know that there is less numbers of midwives in the national ministries of health. And how about the regulatory authorities? Again, we are a bit lower compared to the global average of 54%. So 40% of countries in the 11 countries in the region have midwives in leadership and regulatory authorities. And when we look at health facilities, it's a bit higher. So 71% of countries have midwives in leadership and health facilities. But also, if we look at the region, we can't disregard the fact that most of our midwives are women in the region. And 70%, did you know that this globally, 70% of health and social care workforce are women, but just 25% of senior roles are held by women, right? So it's a workforce, or it's a sector that is really heavy on women health workers. So because 70% of the health and social care workforce are women globally, but only 25% of the senior roles are held by women, right? So example of what we're really trying to do for the region, I'll talk more a little bit more later on identifying the midwifery leadership in countries. Again, if you recall the 7-step action plan as well, and the global strategic directions, leadership definitely is a critical aspect of strengthening midwifery. So what we wanted to do in the regional office is identifying, well, what sort of midwifery leadership exists, and are they at the national level, subnational level? Do we have midwives in policy decision-making tables? Do we have national associations? Are they in regulatory bodies? You know, these were what we were looking at. And even in the parliament, you know, do we have midwives who hold positions in parliament? And then we do want to provide or have some sort of midwifery leadership program to strengthen capacity of midwives to influence health policy, really from all levels of midwives, not just the senior midwives, but from novice midwives as well. In terms of education and training, we know that we need a robust midwifery education and training program that produces adequate number of qualified midwives who are equipped with the ICM essential competencies for midwifery practice. And so currently, we just did a small mapping exercise. What are the types of programs available to become a professional midwife? Meaning, here, when I highlight professional, it's really those that meet the ICM competencies. So there are different programs, the direct entry model to the midwifery course. For example, so you're a student and you're thinking of going into midwifery. How are you going to go in? In some countries, you can only become a midwife after you become a nurse. But this is a direct entry model where someone can directly go into the midwifery course. So we have the diploma level, which is like a college degree, equivalent to like a college degree, say, in North America, example. So Bangladesh has a 3-year diploma, plus they do a 6 months internship. In Indonesia, it's the D3, right? So the 3-year program. In Myanmar, they also have 3 years, and in Timor-Leste, they also have the 3-year program. For bachelor's degree level or the baccalaureate level, we know that Indonesia offers it through a 5-year program, Myanmar 4 years, and Timor 4. And that currently there are no courses that offer direct entry to the combined nurse midwife program that meets the ICM standards. So again, if when we were looking at the transitioning to midwifery models of care, we saw some countries in the left with these orange or brown circles. And so we know that some programs, for example, in Bangladesh and India, they have the direct entry to combined nurse midwife course, but actually they do not meet the ICM competencies of a professional midwife. So that's why it's not listed here. Entry from nursing to midwifery. So this is like India's model, where they decided that nurses who have a GNM can take a post-basic diploma. Post-basic meaning they've graduated from nursing degree, but they can receive a post-basic diploma in nurse practitioner and midwifery, or the NPM model, which is an 18 months program. So this is quite new. And then in Nepal, they have a baccalaureate program. There's 36 months, so 3 years after nursing. Or they also offer the 4 years past, So it's a Bachelor of Midwifery. The bridging course is really for those that already have a diploma level but want to increase their level to a baccalaureate. So in Bangladesh, they recently started offering the 2-year program in bachelor's in midwifery for those who have completed the 3-year already. So the bridge course is really, the next step, right? So it's not really to become a professional midwife, but really for those that want to advance their degree. In Timor-Leste, we know that midwives who have the Diploma 1 level from pre-independence time can receive a baccalaureate level after 18 months, because in Timor, they only offer a baccalaureate level, and all their midwives have to meet the baccalaureate level. Okay, so when we look at educators and trainers, so this is comparing our region to the rest of the world, and these numbers come from the SOMI report. 49% of the countries say that all their midwife educators are midwives, and that 6% say that none of them are midwives. And then so we know that on average, 65% are midwives. Now, this is very tricky for our region because as I mentioned, that we are transitioning to midwifery models of care. And, for example, in Indonesia, you have midwifery educators who are midwives because midwifery has been part of the country for so long, for so many years. So you actually have midwives who have practiced as midwives who become midwife educators. But what about those countries who, midwifery is a newer profession, like a newer distinct occupational group, right? So because of that, our region struggles a little bit in having dedicated midwife educators for the midwifery programs. So that's why you see your numbers tend to be a bit on the lower end. So again, few countries in Southeast Asia do not comply with the ICM global standards. Sometimes the midwifery education is not being separated from nursing education. Midwifery educators are lacking in formal qualifications to become a midwifery educator and lacking pedagogical strategies to enable students' learning. This actually is a result from research that occurred in this region on what needs to be done to strengthen midwifery education. We also found out that there's inadequate admission selection system and lack of clinical hands-on experience, shortage of resources, facilities, and services. And maybe you also understand from your clinical experience and clinical studies when you had to fight for, fights, or when you had to compete really with other professions. So there might be medical students, there might be nursing students, and there might be midwifery students, right? So we're really, competing in terms of which facility we can go to, and what resources there are available for the students. And we also know that in the region, assessment strategies are not meeting the learning outcomes. So what are we doing at the region? We are trying to strengthen the capacity of faculty to deliver quality midwifery education and training. The regional office has developed a competency assessment tool for midwifery educators and midwives, really, so that they can assess the competencies of, in terms of, as an educator, are all the educators meeting all the competencies required to deliver quality education? Or what areas are there any gaps? So we want to make sure that we can identify those. So the regional office has supported in developing these assessment tool. We're also supporting some countries to develop and strengthen CPD programs, or the continuing professional development programs, and linking them to relicensing or strengthening their skills labs. The third component is the workforce planning and management. So when we think about strengthening midwifery, it's not just for education, but we need to look at the labor market. When we look at the labor market, we need to make sure that we have effective planning and management of the midwifery workforce, and that we have adequate numbers and acceptable distribution. So we need to have skill mix and interdisciplinary teams, to enable effective use of available midwifery expertise. So for example, what do we mean by this? I've been to sites where, for example, in these countries where midwifery is a new profession, right? So the team is not really fully aware of the scope of practice of the midwives, or, what they're really capable of. And because it's a new profession, maybe the midwives are not able to articulate what they can do, because again, there's also a gender difference, and there's, just a hierarchy that plays a role in real life scenarios. And so we've been to areas where we've rolled out midwifery as this dedicated profession, but because the multidisciplinary team does not know where they are best utilized, they put them in labor rooms, right? So we're not really using the full capacity of the midwife in A and C, for example, because in the outpatient departments, the midwives are able to provide antenatal care services, and really we encourage, and we want to make sure that midwives are seeing the woman from pre-labor, even pregnancy, right, if possible. So we really need to make sure that they are promoted into the skill mix in the interdisciplinary teams to enable the effective use of available midwifery expertise. So there's a wide range of providers with midwifery skills and engaged in providing midwifery services that will optimally be used to ensure services along the broad spectrum of the RMNCH and to ensure continuum of care. So another really important section of health workforce management and planning is data. So we know from the SOMI exercise SOMI was released in 2021, but the whole data gathering process started around 2019 and really a lot in 2020. Not one of the 194 countries submitted all of the requested data, and those that did often could not distinguish clearly between professionals and associates, and between nurses, midwives, and nurse midwives, right? Because again, it's for some countries where this is not two distinct profession, it's difficult for the ministries to really distinguish. Data systems don't always distinguish between the midwives in clinical practice and those in other functions, and there's no data on how much time nurses and doctors devoted to SRMNH. So this is from the SOMI report, and so what are we doing? From the region, we want to strengthen the midwifery and health workforce data, highlighting SOMI, but other data indicators too. Increasing the capacity of workforce planning and management, such as looking at the number of seats, the graduates, post-vaccine vacancies. So this is, from the health labor market framework, like again, starting from education to those in the labor workforce, like we need to ensure that we have the numbers so that we can do proper planning. Because let's say 100 students enroll into midwifery programs, we know that not all of them are going to graduate, and we know that not all of them are going to be absorbed by the health sector. So as a country, if we need to make sure that we want to achieve universal health coverage, or to ensure that SRMNH services are covered fully by midwives, we need to calculate, well, how many midwives do we need in order to meet that? And are we actually, when we look at retirement, when we look at recruitment, when we, look at how many posts there are these numbers meeting those, the optimal number that a community or a country needs? So yeah, we do have indicators that are helpful in monitoring the midwifery workforce, and then we also want to place midwives in dedicated SRHR areas. So again, this sounds like a no-brainer, but in countries that are transitioning to midwifery models of care, because in the past midwives were nurse midwives, they think that midwives who graduate from midwifery programs can also rotate around in non-SRMNH areas, for example, in cardiac care or in respiratory care or, palliative services, right? So all these other wards that really, you put a midwife, what good are they going to contribute to the service? But in reality, this really does happen. So we need to make sure that we're placing midwives in these dedicated SRH areas so that we can fully optimally use their skills and their knowledge for the service. The fourth area for the strengthening midwifery in the regional strategic direction is practice and service delivery. So again, we want to ensure midwifery-led continuity of care of two dimensions, including from pre-pregnancy through pregnancy, childbirth, and then early days and months of life. And then, so that's the period. How about the place? Well, we need to make sure that they are in homes closest to the community, but also in health facilities and then back to home. And that they're integrated into the service delivery or really into the health systems to ensure the health of women, newborns, and infants. So midwife-led models of care, again, is what I was talking about. The stage is what is at the headquarter level. We have the strategic technical advisory group of experts of maternal, neonatal, child, adolescent health and nutrition, who endorse WHO. So they actually endorse and recommend to our DG, how can WHO support countries that wish to transition to midwifery models of care with policy advice and implementation? Because we know that universal coverage of midwife-delivered interventions could avert 2/3 of maternal neonatal deaths and stillbirths, and that there are other additional benefits. So at the regional office, we are supporting this transition as much as possible to countries that want to transition. There are still countries that are using the nurse midwife model of one profession. And again, this is up to the countries. If countries don't have enough health workers, maybe this is the best model that they have in the country. That's really up to the countries to decide, and we will provide our guidance for that. And then, so we want to enhance the quality of midwifery care by developing service standards for midwives. We're also assessing working environments and conditions, because we want to make sure that nurses and midwives and nurse midwives are able to fully provide the best service, and we need to make sure to protect, right, our health workers. So we need to look at their work environment, what areas do we need to invest in order to provide better working environments for midwives. And so this picture I took in a state called Telangana in India. So this is one of the states that in India that is transitioning to midwifery models of care. And you can see in the bottom here, it used to say gents not allowed in this ward, right? So this was a labor and delivery ward, and they also had the recovery rooms, and men were not allowed previously to come in. But by promoting midwifery models of care, they've realized that it's very important for the woman to have a companion of choice. And so therefore, this hospital has changed their policy. And you can see the transitioning, really, because they've crossed out the knots. And now men are allowed because they've realized, right? They've realized that it's important for a woman to have access to their companion of choice, someone who they want beside them when they're going through this process. And so this I thought I'd put in here because I think it's a picture that really represents what we're trying to transition to. The fifth component is research and evidence. So we want to make sure that we have enough research with a focus on midwifery and women's health, and it's conducted and generating evidence through midwifery, and with continuous monitoring and documentation. We need to make sure that research and evidence is translated into policy and responds effectively to the needs of the population. So some of the examples that we're doing for this is a scoping review of the midwifery-related research in the region. And I'll talk more about that. So we have conducted a scoping review in terms of what types of research has been conducted in the region. So when we look at these 5 buckets that we've had in the strategic directions on governance and regulation, education training, workforce management, practice service delivery, and then leadership and other topics, really what has been explored in the last 10 years? And should we as a region look at what future research priorities we need for the region to strengthen midwifery? So we've looked at these 11 CRO countries with a time frame of January 2012 to September 2022. So what we did was we did do a scoping review. So you can see that how many studies have been included. In the end, we have 183 studies that were included in the review. And really documenting the existing evidence categorized into the midwifery topics based on so many areas, which is again very similar to our regional strategic corrections. And as you see, it seems, compared to the early years of 2012 and 2013, when we've had 6 to 9 publications per year in the region, now we're approaching, even during COVID, right? So you can see from pre-COVID in 2018, we've had 29 publications a year in the region. And then even during COVID time, we're averaging about 20 to 21 publications. So we know that, again, this is probably because of the transition to midwifery models of care, but we can see an increase of numbers of studies in the region. And if we look at the articles by country, it is impressive how much research has been conducted in Indonesia on midwifery. And again, it's not too surprising because Indonesia is a country where we've had midwives for a long time. And plus, there's in Indonesia, you have career ladders for midwives too. So midwives aren't just practicing. We have educators. EB is very strong as well in Indonesia. And, you can move on to getting higher degrees in Indonesia as a midwife compared to, for example, Sri Lanka. We have dedicated midwives in Sri Lanka called the public health midwives, but they get a certificate. It's like an 18-month certificate program, and they do not have any opportunities actually to move up, or if they want a baccalaureate, for example. It just currently does not exist. And so that's why I think that's where I think we see the difference in terms of the numbers. So you see in India, Bangladesh, Nepal, these are the countries that are transitioning to midwifery models of care, and we can see a little bit of a higher number, I guess, compared to other countries in the region. but very impressive. Again, 45.3% of the research studies for midwifery comes from Indonesia. Oh, sorry. And then here you see the total of numbers being 190, but that's because some of the papers included multiple countries. So in one study, it might have included 3 countries. That's why the count is different. And looking at research methodology, so we know that there are more quantitative studies compared to like mixed methods, right? So that's what we're showing here. Again, and then this one you can see by country, again, Indonesia having the most research studies in midwifery. We know that even in Indonesia, there's a higher number of quantitative studies compared to other methodologies. And when looking at by practitioner or midwife in focus, like, are we actually looking at the midwives, or are we looking at students, or are we looking at, you know, lay health workers? We can see the difference here. And so again, in Indonesia, it does seem like there was a lot more focus on the midwives, and then a little bit more on students, or not a little bit more, but a little bit less on the students, yeah, and then a little bit less on the lay health workers and stakeholders. And what areas were the countries focusing on? So this is really the core of the work that we were interested in looking at. So you can see leadership is actually only 3.2% of the papers focused on leadership areas. You know, and again, if we go back to, this is why we've included in the global strategic directions. This is why we know that in step 1 of the 7-step action framework, strengthening leadership and identifying leadership is the #1 focus, but yet, you know, we don't have much studies on it. So perhaps this is one of the areas that we need to look at in the future, but the most area was on practice service delivery or model of care, which I was actually surprised. I thought there would be a lot on education. And I mean, if we look at education, you look at the second and third column, you know, there's you know, about 35% of the papers are focusing on education. This was not too surprising, again, because when we do look at research papers, a lot tend to be on education from this region. But there isn't much on governance and regulation, right? There's only 5.6% of the papers focusing on governance and regulation. So yeah, if we look at it by country, okay, let's, for example, look at Indonesia. It does look pretty similar compared to the regional focus. So there's a whole lot of practice and service delivery of midwives, and education might be the next batch, and then a little bit on the workforce management, a little bit less on governance and regulation. And Indonesia, I see, is one of the very few countries that actually have some research on leadership and have also focused on midwives' experiences. So key findings is aspects of ANC were most commonly reported on, followed by PNC, interpartum care, and neonatal care. Topics included contraception and family planning, infant feeding and nutrition, terminations of pregnancy, patient education, documentation, PPH prevention or management, and mental health, you know, domestic and sexual violence, HIV screening and transmission, preeclampsia, and measuring progress in labor. So there were 11 studies that evaluated the aspect of service delivery in these countries of Bangladesh, Indonesia, India, and Thailand. There's also something that evaluated the effect of midwife in the village program at population level, and increases in WHO recommended birth practices of overall service capacity, maternal neonatal health outcomes, or women's satisfaction when midwives were introduced to the setting. And really exploring the partnerships between midwives and community or the village health volunteers, which is great because we want to also look at how they're integrated into the multidisciplinary team, right? And how about service delivery in hard to reach and rural settings? So when we look at the geographical distribution and looking at midwifery service in the hard to reach areas, under-resourcing and workforce shortages are consistently highlighted in these settings and practitioners are being challenged to practice beyond the scope, competence, expectations, or training, right? Really important because, again, it might be that midwifery practitioners are the only health workers available in that hard-to-reach and rural settings. And that we know that there needs to be community trust, knowledge of culture, language, living in the community, limited resources in the community were key factors of these types of researches. And there was also research that looked at strategies reported on to improve service delivery challenges, such as training the auxiliary nurse midwives or the auxiliary midwives to improve specific skills. Integration of internet technology to optimize service delivery is important when you look at telehealth or, even mHealth, mobile health, right? So there were 9 studies reported on internet-based intervention to optimize practice or service delivery. In addition, we had them, and majority of the studies reported on the design and implementation rather than evaluating these programs. mHealth applications were used to facilitate communication between midwives and women. Really helpful when the women are in the hard to reach areas or the rural areas or the isolated areas, right? Okay, let's just get to education. So in terms of education, when we look at strengthening midwifery education, there was a study on development of legislation and regulation, strengthening formal midwifery education professional value, and improving learning environments that were recommended to improve formal midwifery education. There were some barriers to strengthening midwifery education identified in such countries such as Indonesia, and a number of papers on the major gaps and bottlenecks in pre-service education to inform their scale-up, quality improvement efforts, and reform. Gaps relating to infrastructure, resources, and capacities for midwifery pre-service education. Right, and there were some strategies that were identified as you see below. How about for national accreditation? So there were some papers on the development of context-specific accreditation assessment tools and a rapid assessment tool for affirming good practice in midwifery education and programming. Benefits of accreditation process that improves communication between midwifery teaching institutions. How about for faculty and curriculum development? There were some papers that focused on faculty development initiatives, developed and evaluated initiatives to develop new curriculum. There's capacity to be building in the faculties in terms of master's programs or international midwifery placements or the mentorship program. Initiatives and processes to improve learning. Examples that improved learning included like a flipped classroom approach, case analysis activities, storytelling videos of women's childbirth experiences. This was really important because we want to make sure that that we understand what women want and what women don't want, and what was their experience and how can we improve those experiences for the women. Team-based learning, augmented reality-based media, competency tests, right? And learning experiences and practice, including learning in a continuity of care model being based in a community midwifery clinic. Number of papers discussing about improving confidence of students, such as clinical skill development with hands-on clinical practice. So these are some of the areas that we've investigated for pre-service. Well, how about in-service education? So after a midwife becomes a midwife, what type of education or CPD is available? So we know, some of the research showed that simulation showed improvements in midwife skills and knowledge. And for example, description of simulation training in the HPV program, which is the Helping Babies Breathe program in Bangladesh. And there were other specific programs related to positive pressure ventilation, abortion care, emergency care, and approaches including high realistic simulation, facilitated video guided debriefing, and facilitated teamwork activities. Some were actually targeted in-service education. So more than 20 papers have actually focused on in-service education, and it's really referring to the essential maternal and newborn health related skills. And, using paragraphs, neonatal care, use of alternative delivery positions, ANCs, HIV, family planning, mental health, as you can see. Another thing that was important was disaster preparedness and management. This probably came from Indonesia because Indonesia is one of the countries that are actually focusing on disaster preparedness and management, which is, I know, included, for example, in the midwifery program, in the curriculums, especially at the Polytechnic. And then, yeah, targeting in-service education offering for development of career pathways of professional education, academic progress, self-development, or professional recognition, or with external incentives. There were some limitations. So yes, some studies or 15 papers have focused on limitations in the knowledge and skills, and maybe it was limitations in the post-registration knowledge and skills. So really, after graduating, finding out that they didn't have enough skills or knowledge to fully be able to provide that best care that they wanted to, and reporting on low levels of knowledge of critical danger signs, including safe childbirth practices, exposure to rural communities, medical legal issues and ethics, folic acid supplementation, etc., etc. In terms of workforce management, there were some that was focusing on burnout, identifying the threat to workforce sustainability, and local cultural acceptance and social status of the midwife is critical to the effective provision of care, and then implementation of local village midwives, improving the health outcomes for whole communities. Again, not too surprising. And what I really like, for example, when I talk about culture, is that when I went to I know that in the midwifery curriculums in Indonesia, you really try to incorporate that regional, culture into your education. So I told you I was in Bali last week, and when I went to the Polytechnic, they have actually incorporated Balinese, culture into midwifery education because they realized how important that is for the community of the people that are living in Bali. So there were some, I think, rituals. There were some, oils, aromatherapy, for example, that they were incorporating into the curriculum because they realized how important that is for the women, and using specific spices, I think, that were available. So non-pharmacological aspects of it. For midwives' experiences, there were a few studies. So there were 34 papers that reported on the experiences of midwives from these countries, and really focusing on the experiences of clinical care provision. What does the midwifery model look like in that country, and the roles of midwives and their professional satisfaction as a midwife, and their well-being. And really, it was about a lack of available protocols or guidelines to support care provision, especially in countries, again, where there are transitioning to midwifery models of care. These things are still in development, and maybe midwives talked about the lack of these available protocols, lack of professional development. Again, I talked about, what if I become a midwife, and what's going to be my next step? In some countries, we're still figuring out what kind of professional development or career ladder we can provide for these midwives. Lack of community understanding, especially in those areas where we are transitioning, and these cultural barriers that they may have. And some studies have identified the importance of midwives integrated into the communities, and communities informing the benefits of midwifery care provision. Right. Let's just okay, when it comes to leadership, governance, and regulation. So on regulation, there were 10 papers. And really, the focus was on the variance and approach to legislation and midwifery regulation, especially in relation to nursing and other auxiliary roles, which is a barrier to clearly identifying and advancing the profession of midwifery. There's a lack of clarity or absence of legislation supporting the midwifery practice, particularly in community settings. And midwives being fearful of working outside the legal framework because there's not much legal framework to support their practice. And so this is important for us to figure out as we work with ministries of health and ensuring to strengthen midwifery, because we need to look at leadership and governance regulation component. For leadership, I think it was really, very clear that we need more need, or there is an urgent need for mentorship of emerging midwifery leaders across all sectors of education, clinical care, administration, regulation, research, and governance, and highlighting the need to prioritize the visibility for the identity of the midwifery profession as distinctive from nursing at the strategic levels. Again, with these countries that are transitioning, it's very difficult for countries to manage, and they need to um, there needs to be clear guidance, and it will take time. This is not just night and day that we can change things overnight, but we know that we need to make sure that we need the identity of the midwives and increasing visibility and awareness in the community. Uh, for governance, it's really prioritizing access to quality data was needed in order to improve regulation. So this is something that we are also prioritizing in the region, as you know, and it really came from these research findings. And the variation in approach to regulation influencing midwifery governance, with some settings seeking registration for midwifery distinctive of nursing. Midwifery representation on governance committees were critical to advancing midwifery and ensuring that key elements of profession are represented in regulatory and legal forums. So what were the key recommendations? The key recommendations was that in countries who choose to transition to midwifery-led models of care, and need to explore the barriers and enablers to support the transition. We need to explore different midwifery education pathways to understand how graduates compare in terms of competencies, where and how they were deployed, and identify innovations in midwifery education that can be shared. We need to articulate the variation in how midwives is defined related to education pathways to see whether a common nomenclature could be developed. We need to understand midwives' professional regulation, education, accreditation, governance models, and scope of practice between countries and regions. Undertake research on the return of investments in midwifery education, regulation, deployment, and retention to support countries in making strategic directions around investments. We need to explore the key elements of midwifery leadership across the Sierra region, including career pathways, educational development needs, and regulatory frameworks to support and embed effective midwifery leadership at all levels of the health governance, and conducting implementation research into midwifery-led models of care, midwifery-led birth centers, and midwifery continuity care services to understand what works for whom, where, and why. So these were some of the key recommendations that came from the scoping review that I just shared with you. So in the region, we also have, again, in terms of strengthening midwifery leadership, we're trying to improve the midwifery leadership by again, we were identifying what leadership exists and coming up with a program, like a leadership program, and we hope to have that soon, for hopefully by next year. This is the regional competency tool that was developed for midwifery educators and midwives that I've explained to you before. But this really is a tool that can be useful in identifying what competencies are missing, so it can be more at a bigger scale of what is missing in the educators and midwives, and what programs do we need to offer so that we know that the midwives and the educators can meet those images and competencies. So we are currently assessing work environment for midwives in Nepal and in Bangladesh. And we're trying to document midwives and nurses' organizational and psychosocial work environment by identifying preventative measures that can lead to improved working conditions. We need to improve retention and enabling midwives and nurses to practice to their full scope, to be able to be in a supportive environment. And really, this is one of my last few slides, that currently, so other than assessing the working conditions, we're also analyzing nursing and midwifery roles during COVID and what were the lessons learned, so that when the next pandemic or a health emergency arises, we know how to effectively use midwives. We're also developing a policy brief on nursing midwifery leadership for the achievement of UHC, really to support what is the current evidence, what does midwifery leadership look like currently, and what needs to be strengthened in order to achieve UHC in the future by 2030. And we want to collect some success stories from the field to policy level so that we can advocate and increase awareness of the effectiveness of midwives and some of these innovations that are happening maybe at the field level that we're not aware of, or even your policymakers are not aware of. So in conclusion, most member states in the region have ruled out midwifery as a profession dedicated to providing SRMNH. Midwives are a critical workforce for the region to achieve the unfinished MDG agenda of ending preventable maternal newborn child death, and WHO is committed to supporting countries transitioning to midwifery models of care and strengthening midwifery even beyond the regional flagship decade for health workforce strengthening 2015 to 2024 to progress toward universal health coverage and the Sustainable Development Goals. So I'm just sharing photos with you at this point, but this is really the new MOCUs that were developed. So these are the midwifery-led care units developed in India. This is also from India. You can see some of the interventions. This is photos from Nepal, from midwife-led antenatal clinic. Some midwifery students in Nepal, and it's in Bangladesh. So some of the midwives in private sector as well. Okay. So I think it's time for Q&A. I'll just ask the facilitator to, the moderator,
Okay.
Mr. Mohammed Arif, to ask some questions, I guess. But just lastly, we do have a global community of practice nurse and midwifery platform. So if you go to this QR code, actually, this is our global page that we have from WHO, where you can connect with other nurses and midwives and other supporters of nurses and midwives. And stakeholders, and this is really a forum where you will find out more information on what WHO's activities are, as well as it's a platform where you can discuss and network with other nurses and midwives globally. So please join us, and we will see you there. Let me stop sharing my screen so I can go. Okay, yes.
Yep. So that's quite informative presentation, quite a lot of data provided by Ms. Aita Nimizu. And now we've come to the Q&A session. Well, actually, we've got a bunch of questions from students, I think, and health practitioners, midwives. And I need to inform you, Ms. Ai, we're holding this, conference in a building like a hall, and I've got students with me. We've got like hundreds of students sitting in front of me, and some of the practitioners, midwives as well.
That's great. Yeah, sorry, I thought it was virtual, but
yeah, it is virtual, actually. But they would like to see physically, even though, you're just showing your presentations via Zoom, but they would like to communicate with you. Some students, according to my observation, they prefer to have their own questions on the chat. And in the previous talk, some practitioners came up with, they spoke directly with the experts, some of the experts from different countries. And as I told you, we've got some questions. I think some of the questions are quite related, and that would be great if you could address those things in one answer. And let's just begin. This is a question from, let me just scroll. Oh, by the way, somebody, oh no. Yeah, two people are raising their hands. I think the first one who raised hand was Mr. Rahman Suleiman, but I don't think Mr. Rahman Suleiman is on the room. Probably is going somewhere else. And I'll just move on to Miss Nanda. Miss Nanda is a practitioner, is a midwife, an academic from Gorontalo Health Polytechnic. Mr. Rahman, are you there? Hello, Mr. Rahman. I, I, I think I just saw you in a blink of an eye, then you just disappeared. Okay, I'll just go to Miss Nanda, and after that I'll go back to Mr. Rahman. Miss Nanda, over to you, please. You need to unmute. You muted, Miss Nanda. Yeah, okay.
Okay, thank you, Mr. Arif. Good afternoon, Miss Ai Hanimizu. I'm so interested with your presentation, but I wanna ask you some question. First, um, midwifery department in Indonesia have implemented good curriculum, but the mortality rate in Indonesia is still high, especially because hypertension in pregnancy. In your opinion, what best subject or material or midwifery skill that we can adopt and apply to our midwifery student for improve the ability of midwifery in Indonesia to reduce the maternal mortality rate? Thank you.
Okay, Miss A, would you prefer to take the questions one by one, or do you want to collect some questions then address later?
Yeah, sure. Let's collect a few more and then I
Okay,
can address it.
right. On the chat box, there's a question about initiative or programs from WHO to strengthen midwifery in Southeast Asia. I think you've highlighted quite a lot of this in your presentation. Next one from Nurul Riza. The question is, this is about, this is quite interesting one. You mentioned about the things you found in Bali when Balinese integrated, the local wisdom, let's say if you like, with, actually the medical stuff. And Nurul Riza in here actually said that Indonesian community is so attached, meaning also very upholding, the local wisdom, like the use of spices, oil that you've mentioned, and it's been like a challenge in Indonesian context to actually promote global standard, amongst the belief of local stuff. What do you think about this? And you want to have more? Okay.
I think we'll stop there. I think
Okay.
those are very
Over
interesting
to you.
questions that I can answer for now, and then we can take up more questions. So thank you very much, Ms. Nanda, for your question. I think you mentioned about how we have a robust curriculum in Indonesia, but you still are experiencing higher maternal mortality. So I think Indonesia is currently trying to increase the number of ANCs as well, from what I understand. So it used to be 4 ANCs, but now there's a new, I think, regulation or new policy that we're trying to increase to 6. So in the first trimester there's 1, in the second trimester there are 2 ANCs, and then in the third trimester there are 3. So this is what I know, that there's some changes that are happening in Indonesia. I think this will definitely be one helpful thing. And in Indonesia, from what I've seen, there's a lot of integration with the health workers. But I also know that the population of Indonesia really varies. So we need to look at where's the highest mortality right now, what geographical location, and what are the causes of MMR, and are these high mortality rates something that midwifery intervention can support? And perhaps there needs to be more policy dialogue between the interprofessional team on how to reduce the maternal mortality. Another thing that I think midwives can do specifically is, especially with hypertension or these non-communicable diseases, it's something that women are going to have to treat on their own in a way. So when it comes to hypertension, it's not a short-term illness in terms of, it's not a communicable disease where a child has diarrhea, you give them you know maybe ORS for 2 days and see how it progresses, and then maybe you can give some antibiotics and then that really cures. With hypertension, we know that it's a long-term thing, longer term, right? So maybe there are specific skills and strategies that a midwife could promote, such as one of the skills that's important as a health worker is motivational interviewing, right? So I think this past session we were talking a little bit about diet as well, like, and food. But all of us as health workers know that we should be exercising moderately for 150 minutes a week, or that we should be eating fruits and vegetables, and less meat products or less red meat products and less animal fats. But we also engage in those activities, right? As health workers, we know the benefits, we know the cons, but we still do engage in those activities. And so I often tell people, when you're the healthcare practitioner and you're telling the other person, well, you really need to, you shouldn't eat this, you shouldn't eat that. But it's part of our diet, and it's part of our cultural diet as well, right? And sometimes you can't change it that quickly. So it's not really about teaching them, what's right and wrong, but really about talking about moderation and how do we change their behavior, right? So we know that walking is very important, for example, in pregnancy, but uh, I also know when I'm going through pregnancy, I am exhausted. I am so exhausted, and the most I could do is probably prepare a meal or even sit in front of my computer to work. And then you're telling me that I need to go for a walk, or that I need to do some moderate exercise, but it's so tough for me. So what I need as a patient is not for my midwife to tell me, you really need to work. You really need to get moving. And I'm like, but I can't. I'm really trying, but I'm so exhausted. I'm now struggling. I think I need more sleep than maybe go for a walk right now. So I think we need to teach more empathy as well. How do we communicate with patients so that they would be motivated to go for a walk. So perhaps if someone told me, you don't have to think about going for a walk for the 30 minutes that's recommended. Perhaps try to, park your car somewhere a bit further when you're going grocery shopping and get a little bit more steps. Things that are a bit more doable, I think we can teach. And again, these are really small strategies that could support, but I think it can go a long way, especially with non-communicable diseases, where it's more a longer term, illness, or it's really about lifestyle changes, and it's not just about taking pills and getting better. I think this is where we need to be. We need to be able to teach our students to how do we ingrain motivational interviewing skills, so that it's not about telling the woman this is right and wrong, but how do we motivate our patients to participate in active or healthy behaviors. Yeah. So again, when we think about mortality, we definitely will have to look, first of all, to where the mortality is high and why the mortality is high, right? So there are statistics and numbers and data for Indonesia. So I think we need to look at that. And what are some interventions that midwives could do? And maybe it is the fact that, yes, there are midwives, but they're not integrated fully, or there's no continuity of care as well between the midwifery practice, maybe. So, but I think these are things that we need to look at. The second question on initiative or programs on strengthening midwifery in the region, I think I've highlighted a lot throughout my presentation. I don't know, it was like here and there, and maybe that's why it was a bit difficult to follow. I apologize for that. But basically, we are working with the countries where we work with the ministries of health in the 11 CRO countries, and what they want us to support in is where we provide the support. And that's how we're strengthening midwifery in the region, by really looking at the different pillars. It's not just strengthening education and having programs available, but really ensuring that they're integrated into the health systems. It might be advocating with your health ministers. It might be talking with your health leaders. And it might be on certain skills or improving labs. It might be, again, looking at research and how do we incorporate more, generate evidence to improve midwifery. So the third question was on, I totally agree. Sometimes there's a lot more of this cultural integration into the care that we provide versus the global standards, right? And the community finding it a bit difficult to sway away, right? And I think this is where we need to find the happy medium. I feel, this discussion I just had actually after the midwifery conference I was in Bali with some of the other, great midwifery leaders in the world, like talking about, well, there's so much global standard, but sometimes it does not, it does not equate to the cultural practices. So where do we find this happy medium? I think, one, we need data, right? We need to conduct research and we need data, and we need clinicians who can be able to communicate that to our community. We need midwives who can relay that message, that proper message of why we have global standards and what the global standard of midwifery interventions are, but also understanding the cultural practices. And this, I think, it has to be in discussions with the community. Again, what are some of the, so for example, there are different opinions on maybe turmeric, right? That during pregnancy, women should not be taking turmeric, but then a cultural practice they are. Well, what is the evidence behind that? Can we explain that to the mothers and the families of what the evidence is, and talk about perhaps understanding what evidence is saying and where we can, where they would feel better about using these products as well. And it might not just be consuming, it might be in other ways as well. But I really think that globally, we need to look more about how do we find the perfect match, and by incorporating this cultural practice. And this, I think, will have to be a discussion in each context, because each culture will have different practices and understandings and beliefs. Yeah, sorry, I know they're not straightforward answers, but this is what I can give you.
Oke, thank you Miss Ai. Terima
Yep.
kasih.
Yeah, the latest one seems a bit problematic, but that's what happens in Indonesia. Basically, it seems quite right. Research, socialization, discussions are the things that we can actually attempt to, actually find, let's say, the fine line between the cultural practice and medical practice. Right. Such a nice insight, Miss Ai. Okay, so we've got somebody's raising hand, Mr. Rahman. Mr. Rahman, over to you.
Okay, thank you. Can you hear my voice?
Yeah.
Okay. Yeah, thank you. Apologies. First, I would like to ask your apologies because of my English is not really good, but I'm trying to get my best so you can understand what I'm talking about. Directly to my questions. In Indonesia, we have some people who support midwifery, but they don't come from the college, from higher education. They just, what do you call it, learning by experience, I believe so. They call the traditional midwifery. So I would like to ask you, as the WHO ambassador, I would like to ask you, is it possible to your organization to cover these people with legal training, of course, which is proven by legal official certificate? Thank you.
Right. Miss Ayu, do you want to take more questions?
Yes, yes. Why don't we
Okay.
take two more again?
Right. In some of the questions, I think, still addressing how to improve the quality, which is the thing that you've addressed in your presentation, I think. Let's find more. This is a question from Ainun Hanapi, a student. So Ainun is highlighting the issue about skills gap of health workers in the region. If you could have some comments about this. And what else? Vidya, a student, also addressing the obstacles in strengthening midwifery in the Southeast Asia region. I think you've touched quite a lot about this, but I think that would be great and more specific if you could lead your explanation, take your explanation to Indonesian context. And I got one more interesting one, I think. Guidelines, regulations, standards. I think you've given some policies in India, Bangladesh. The last one I've noted about a question from someone questioning whether you can actually WHO, how far WHO can actually connect a collaboration between one country to another, or collaboration across nations, because well, actually in here, global standard is actually something that we're seeking for, and having more and more collaboration would be very effective to improve human resource quality. So we've got 3 so far. You want to get more?
No, that's fine. I think we've got a few questions that I can answer.
Right.
So thank you very much for all these questions. I think they're great questions. Mr. Rahman, your English is perfect. I don't know why you're saying that you can't speak English. I fully understand, and I think you have great pronunciation. So thank you very much for speaking in English, because unfortunately I can't understand Bahasa. I want to, but not yet there yet. So I think your question really is important, because you know what? When we look at the health workers in general, not just midwifery, but when we look at health workers in general in the region, we know that there are the official health workforce, right? That are regulated that are regulated. So we have the professional workforce, such as doctors, nurses, midwives, pharmacists, physiotherapists. Like these are, for example, like the core health workers that people would know that these are, trained and regulated. But we also know that in the region, we actually have these traditional health workers that may not have gone through any formal education, right? But as you say, they understand the beliefs. They've really gained their experience from being in the community, and from learning from ancestors, and the practices that have been like traditionally just brought to who they are right now. Really great question, because we feel at WHO that we cannot disregard these people. These informal, unregulated health workers are also part of the health system. We need to be able to identify them and work with them, because in reality, we want to make sure that we're trying to reach all the community, even in the farthest areas. And these farthest areas are sometimes where these informal, unregulated health workers are. And they are providing health services. So what we, I think, at WHO will work on more is, one, we need to identify them because we have more data on the formal health workers. And the trouble is, this really happened when I went to one of the villages in Bangladesh. When they see that a WHO person is coming to their village, they start closing shops. And it is very difficult for us to identify who they are, what education they've been receiving, because this really happens. When we go out in the village, because we want to talk to them, it's not to penalize, but they start closing all the shops because they think that we're there to, with a baton to say, why are you here? You know, like, why are you providing service for people? We've seen dental practices, we've seen Ayurvedic, practices. We've seen people like, a very senior person in the village just having a clinic from their home. But when we go there, they start shutting everything down. And therefore, we find it very difficult to identify who they are and what types of formal education they've received. I think this is where we need to work with communities to identify them and be able to understand, how did they learn this and who's guiding their practice. And then also have some sort of formal education as much as we can to provide what is safe practice. I think the number one thing we need to look at is what harmful practices, are they, doing? Like, are they having any harmful intervention? If there are, I think that's really where we need to change. And we need to make sure that a community, we know that the community is actually listening to these people because they are, I think, well respected, right? And some people actually prefer to go to these traditional healers, for example, compared to a medical doctor who can give medical advice. And so, we need to work more with also the faith leaders, because we also know that religious leaders are giving out health advices, for example, advice or comments or recommendations that affect someone's health. We want to work with this community. We need to work with more the community to ensure that the messages that are going out are the most appropriate and that it's not harmful. So we do actually work with religious faith leaders. WHO does work with them to, especially during COVID, it was very important to make sure that the proper messaging went out. We know at WHO there were, some religious leaders that were saying the opposite, right? The opposite recommendations of what WHO's guidance would be. But that's why we needed to work with them. And so we need to come up with better strategies to discuss how we can ensure that they are delivering the right message and not something not harmful. And again, this goes to those traditional healers or the unregulated health workforce that you were discussing about. I think, again, we need to work with the community, perhaps the NGO or the community, that where we can build a bit of a trust as well. Because, again, as I said, when we go out to the community, sometimes they see the sign WHO and they just close everything. And we're not able to make any progress. So we need to build their trust somehow. And yes, I think we do need to provide some, it might not be, I think we may need to call it something else other than training, because they might think, oh, are you trying to instill something that we don't believe in? And that's not what we're trying to do. I think we really need to be creative and understanding these communities, the differences in the communities, to make sure that the right message is being said. And again, it might not be training, and maybe, some people actually want the training, I find. So for those, it will be a bit, because they're keen to learn, we are able to provide that service. But for others, it may be a bit more challenging. Yeah, but it's a great question. The next question I received, I think, was the skills gap in the region. What are we doing? Very importantly, when, some of you who are clinicians right now, or some of you who have finished your education, what we've learned from our 3 years or 4 years or 5 years of education, we don't know all of them, right? There's no way you have absorbed 100% of what you've learned. So what I feel is important, or what we feel at WHO is important, is that we instill lifelong learning behaviors to health workers. Because health sector is something that is ever evolving, we need to make sure that our practitioners are engaged in lifelong learning activities. So we need to make sure that that behavior is instilled, and therefore that's how we are going to work on the skills gap or the knowledge gap. Because of course there are going to be gaps, because after I graduated, there's no way I remember all the lines from the textbook or all the skills that I've learned in school. There's no way one person has absorbed everything. But what is important is that I engage, or me as a health professional, engage in lifelong learning activities. And that's why we have continuing professional development, like CPD opportunities, or it might be like going to these conferences, for example, as an activity to learn what is the newest skill, the newest, knowledge, the newest evidence. In terms of obstacles to strengthening, okay, yeah, and one thing that we need to do is we need to work with partners, such as, WHO alone cannot do everything. We work with our UN organizations, we work with the community, we work with the NGOs, and we work with the ministries of health and maybe other stakeholders in order to strengthen. So there's no way that us as WHO can do all of it at once. And I think this also connects really well to the next question on connecting and collaborating across countries. So we feel that we are we sometimes convene meetings. It might be global meetings, it might be regional meetings. At Southeast Asia region, we actually had a regional meeting in September 2022, where the 11 delegations from the 11 countries came together, and we actually discussed, how have you strengthened midwifery in your country in terms of education, workforce planning management, leadership, service delivery. What were some of the things that you've done in your country to improve these? And that's how we promote cross-country learning. And of course, we have webinars as well now that we can meet online. But even in the ICM Congress that I was at last week, we had country-to-country discussions. We had a small group. We convened small group within the region, and we also asked our neighboring country, like the Philippines, to join our discussion, so that we can promote cross-country learning. So I hope I've answered your question.
Okay, thank you very much for your replies, Ms. Ai. We've got two last questions, actually. This is a question from Wendy, a student. Wendy is asking, are there any other Southeast Asian regions where people still believe in cultural factors? What are the examples like? That's the first one. And the second one, this is the last one. Well, actually, this is a question from Midwifery Department of Gorontalo Health Polytechnic. Well, we've seen that the 7 steps you've shown us, the 7 steps, if I'm not mistaken, to improve the quality of human resource, and one of which is to facilitate actually, the human resource development. And the department is actually wondering if WHO can actually facilitate that sort of development through course training, you know, short course, things like that. Because actually the Polytechnic is seeking for collaboration development, including, you know, from stakeholders, international stakeholders. Yeah.
Yes, thank you, thank you. Thank you for the question. So the first one on the cultural practices, I do think that, again, it's not like a national culture, but usually it's like geographically, there are some tribal, tribes or some certain groups that believe in certain practices. Do I have any examples? Now I'm trying to think. I can't think anything off the bat.
Maybe India. You've highlighted a bit in India.
Yeah, well, India.
You
Yeah,
can
because
think of.
in India there are just so many communities. It's like a continent, right? So
Okay.
it's like so that's why I'm just trying to think. Yeah, but all I could say is it does, you know, definitely it's been a challenge to integrate midwifery or even again, global standards to certain population because of the different beliefs that they have, you know. And I think we are trying to, again, it's really working with the communities that we need to be better at, rather than working for the communities. So we need to listen to the communities and understand why they believe in that, you know, in order to change the behavior, rather than education and training and thinking that that would support. So I know it's not a really straightforward answer, but I think it's really transitioning from working for to working with, and not this top down, but it's really going to be a bottom up approach. So that's what we encourage when we're working with the communities and our stakeholders, that they really need to integrate and have the voice of the person. So for example, when we're doing something on strengthening midwifery education, a lot of times the students are not included in the conversations, but these are the people that we're really trying to work with. So ensuring that their voices are heard. So if it's about education that we're talking about, that we incorporate the students' voices, and it's not just people that have power, you know, for example, the principals and the deans that have all the say, that we need to include the community, meaning the students, into these conversations. And this is really how we're going to work together. For the 7-step action framework, we are working with various countries. We have had some pilot programs on strengthening this area, and I know that Polytechnic in Indonesia is really looking at international collaboration, and we are happy to work with Polytechnic to enhance that communication or collaboration with other countries. So yes, we do have those, and we are trying to promote. And if there's a request from the DG Health Workforce, then we can definitely work to integrate the 7-step action framework in Indonesia, and we would be happy to convene that.
Yeah. Okay. I think the committee and the department seem quite happy with the last one about the possibility for collaboration, and they said they would love it very much to contact you after this conference for the follow-up, if you don't mind to.
Oh, definitely. Yes, yes, definitely. We have, for the committee, I think it is important to talk to the director of the Polytechnic, and to talk with the Ministry of Health, the Health Workforce Department, run by Ibu Arianti Anaya, because we are actually in discussions currently about how we can engage, what WHO can support for the next biennium, meaning from 2024 to 2025. So it's actually a good timing to discuss all these activities that you want for Indonesia.
Right, that sounds really great, Miss Ai. Thank you very much. So, Miss Ai, I've told you that we've got plenty of students in here and health workers, and they would like to extend their gratitude to you. So the camera should shoot them. So these are our
I've been
students.
seeing, yes,
They would like to wave at
seen
you.
some of these students in the video. It's been great.
Yeah, they're having a lot of takeaways from your presentations.
It's wonderful to see the students.
Yeah,
Thank you for the love.
thank you. Right. And also we've got, so students in the middle and some health workers, midwives on both sides, left and right sides.
That's amazing. Thank you very much. I didn't know that it was a hybrid meeting, and I think I'm always amazed with how Indonesia organizes these meetings and conferences. There's always such a high turnout, even if it's just virtual. So I'm very impressed, and thank you very much for this occasion. I really appreciate that you've had me and you were able to squeeze me into your heavy, schedule of this 3-day conference. Thank you.
Yeah, we should
Sorry,
instead
Pakistan.
thank you, Miss Ai, for being able to attend this conference and contribute with your very informative presentation. And Miss Ai, the last one, we would like to present certificate of appreciation to you, and that should appear on the screen. Yep.
Wow, thank you so much.
We'll
This is so
send you the
much.
certificate after this conference. Thank you very much, Miss Ai.
Thank you. It was great to meet everyone.
Yeah. all the best. Hope we can see you again. We can have you again in the forthcoming conference. Thank you very much. Bye. All the best.
Thank you, Mrs. Aitani Mizu, for the knowledge and presentation material presented. Hopeful it can provide a reference for future scientific developments in midwifery. Thanks to the moderator, Mr. Arif, and I hope we can meet on another session and always be in good health. Okay, to all participants conference today, seeing that it's already 12 o'clock, it's time to rest. So to all seminar participants, both at the Zoom meeting and present at the activity seat, I invite you to rest, eat, and for those who are Muslim to pray, and then we will meet again at 13 o'clock with a great resource, great speakers. So please cooperate to join before 13 o'clock. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo yang pertama menyelenggarakan pendidikan dan pembelajaran yang profesional. Yang kedua, menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan. Yang ketiga, menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia, melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah yang kondusif, adanya laboratorium yang lengkap dan terpadu yang diperuntukkan sebagai laboratorium keperawatan, laboratorium kebidanan, laboratorium gizi, laboratorium farmasi, laboratorium sanitasi lingkungan, dan laboratorium bahasa, serta laboratorium informasi teknologi. Ini membuktikan bahwa Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap menjadi pendidikan tinggi vokasional kesehatan yang terdepan dan unggul dalam menghasilkan tenaga kesehatan. Politeknik Kesehatan Kementerian Kesehatan Gorontalo akan terus berkarya dan senantiasa berusaha menjadi institusi pendidikan tinggi vokasi kesehatan yang kompetitif, unggul, dan berkarakter. Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap mencetak calon-calon tenaga kesehatan yang kompeten dan unggul, yaitu memiliki ilmu pengetahuan, sikap dan keterampilan yang bermutu sesuai perkembangan ilmu pengetahuan dan teknologi. Kami, Sivitas Akademika Politeknik Kesehatan Kementerian Kesehatan Gorontalo, siap memberikan yang terbaik dalam melaksanakan pendidikan, penelitian, dan pengabdian kepada masyarakat sesuai dengan Tridharma Perguruan Tinggi. Ayo, satukan tekad dan wujudkan cita-cita. Mari bergabung bersama kami, Politeknik Kesehatan Kementerian Kesehatan Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo yang pertama menyelenggarakan pendidikan dan pembelajaran yang profesional. Yang kedua, menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan. Yang ketiga, menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan Keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia. Melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah yang kondusif, adanya laboratorium yang lengkap dan terpadu yang diperuntukkan sebagai laboratorium keperawatan, laboratorium kebidanan, laboratorium gizi, laboratorium farmasi, laboratorium sanitasi lingkungan, dan laboratorium bahasa serta laboratorium informasi teknologi. Ini membuktikan bahwa Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap menjadi pendidikan tinggi vokasional kesehatan yang terdepan dan unggul dalam menghasilkan tenaga kesehatan. Politeknik Kesehatan Kementerian Kesehatan Gorontalo akan terus berkarya dan senantiasa berusaha menjadi institusi pendidikan tinggi vokasi kesehatan yang kompetitif, unggul, dan berkarakter. Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap mencetak calon-calon tenaga kesehatan yang kompeten dan unggul, yaitu memiliki ilmu pengetahuan, sikap dan keterampilan yang bermutu sesuai perkembangan ilmu pengetahuan dan teknologi. Kami, Sivitas Akademika Politeknik Kesehatan Kementerian Kesehatan Gorontalo, siap memberikan yang terbaik dalam melaksanakan pendidikan, penelitian, dan pengabdian kepada masyarakat sesuai dengan Tridharma Perguruan Tinggi. Ayo, satukan tekad dan wujudkan cita-cita. Mari bergabung bersama kami, Politeknik Kesehatan Kementerian Kesehatan Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo yang pertama menyelenggarakan pendidikan dan pembelajaran yang profesional. Yang kedua, menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan. Yang ketiga, menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan Diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan Keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia, melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan Farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah yang kondusif, adanya laboratorium yang lengkap dan terpadu yang diperuntukkan sebagai laboratorium keperawatan, laboratorium kebidanan, laboratorium gizi, laboratorium farmasi, laboratorium sanitasi lingkungan, dan laboratorium bahasa serta laboratorium informasi teknologi. Ini membuktikan bahwa Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap menjadi pendidikan tinggi vokasional kesehatan yang terdepan dan unggul dalam menghasilkan tenaga kesehatan. Politeknik Kesehatan Kementerian Kesehatan Gorontalo akan terus berkarya dan senantiasa berusaha menjadi institusi pendidikan tinggi vokasi kesehatan yang kompetitif, unggul, dan berkarakter. Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap mencetak calon-calon tenaga kesehatan yang kompeten dan unggul, yaitu memiliki ilmu pengetahuan, sikap dan keterampilan yang bermutu sesuai perkembangan ilmu pengetahuan dan teknologi. Kami, Sivitas Akademika Politeknik Kesehatan Kementerian Kesehatan Gorontalo, siap memberikan yang terbaik dalam melaksanakan pendidikan, penelitian, dan pengabdian kepada masyarakat sesuai dengan Tridharma Perguruan Tinggi. Ayo, satukan tekad dan wujudkan cita-cita. Mari bergabung bersama kami, Politeknik Kesehatan Kementerian Kesehatan Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo yang pertama menyelenggarakan pendidikan dan pembelajaran yang profesional, yang kedua menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan, yang ketiga menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan Keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia, melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan Tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah yang kondusif, adanya laboratorium yang lengkap dan terpadu yang diperuntukkan sebagai laboratorium keperawatan, laboratorium kebidanan, laboratorium gizi, laboratorium farmasi, laboratorium sanitasi lingkungan, dan laboratorium bahasa serta laboratorium informasi teknologi. Ini membuktikan bahwa Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap menjadi pendidikan tinggi vokasional kesehatan yang terdepan dan unggul dalam menghasilkan tenaga kesehatan. Politeknik Kesehatan Kementerian Kesehatan Gorontalo akan terus berkarya dan senantiasa berusaha menjadi institusi pendidikan tinggi vokasi kesehatan yang kompetitif, unggul, dan berkarakter. Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap mencetak calon-calon tenaga kesehatan yang kompeten dan unggul, yaitu memiliki ilmu pengetahuan, sikap dan keterampilan yang bermutu sesuai perkembangan ilmu pengetahuan dan teknologi. Kami, Sivitas Akademika Politeknik Kesehatan Kementerian Kesehatan Gorontalo, siap memberikan yang terbaik dalam melaksanakan pendidikan, penelitian, dan pengabdian kepada masyarakat sesuai dengan Tridharma perguruan tinggi. teguhkan tekad dan wujudkan cita-cita. Mari bergabung bersama kami, Politeknik Kesehatan Kementerian Kesehatan Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo yang pertama menyelenggarakan pendidikan dan pembelajaran yang profesional. Yang kedua, menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan. Yang ketiga, menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia, melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah yang kondusif, adanya laboratorium yang lengkap dan terpadu yang diperuntukkan sebagai laboratorium keperawatan, laboratorium kebidanan, laboratorium gizi, laboratorium farmasi, laboratorium sanitasi lingkungan, dan laboratorium bahasa serta laboratorium informasi teknologi. Ini membuktikan bahwa Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap menjadi pendidikan tinggi vokasional kesehatan yang terdepan dan unggul dalam menghasilkan tenaga kesehatan. Politeknik Kesehatan Kementerian Kesehatan Gorontalo akan terus berkarya dan senantiasa berusaha menjadi institusi pendidikan tinggi vokasi kesehatan yang kompetitif, unggul, dan berkarakter. Politeknik Kesehatan Kementerian Kesehatan Gorontalo siap mencetak calon-calon tenaga kesehatan yang kompeten dan unggul, yaitu memiliki ilmu pengetahuan, sikap dan keterampilan yang bermutu sesuai perkembangan ilmu pengetahuan dan teknologi. Kami, Sivitas Akademika Politeknik Kesehatan Kementerian Kesehatan Gorontalo, siap memberikan yang terbaik dalam melaksanakan pendidikan, penelitian, dan pengabdian kepada masyarakat sesuai dengan Tridharma Perguruan Tinggi. Ayo, satukan tekad dan wujudkan cita-cita. Mari bergabung bersama kami, Politeknik Kesehatan Kementerian Kesehatan Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi sarjana terapan keperawatan, program studi sarjana terapan kebidanan, program studi sarjana terapan gizi, program studi sarjana terapan sanitasi lingkungan, program studi diploma 3 keperawatan, program studi diploma 3 kebidanan, dan program studi diploma 3 farmasi. Visi Politeknik Kesehatan Kementerian Kesehatan Gorontalo yaitu menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter di tahun 2045.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, sehat negeriku, tumbuh Indonesiaku. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki visi menjadi institusi pendidikan tinggi kesehatan terdepan dalam menghasilkan lulusan yang kompetitif dan berkarakter tahun 2045. Misi Politeknik Kesehatan Kemenkes Gorontalo yang pertama menyelenggarakan pendidikan dan pembelajaran yang profesional. Yang kedua, menyelenggarakan penelitian kesehatan sesuai pedoman riset Kemenkes dan pengembangan keilmuan. Yang ketiga, menyelenggarakan pengabdian kepada masyarakat, bidang kesehatan berbasis pelayanan dan pembinaan wilayah, serta implementasi hasil-hasil riset. Yang keempat, mengembangkan kemitraan di dalam negeri dan luar negeri yang menunjang pelaksanaan kegiatan Tridharma. Dan yang kelima, menerapkan sistem tata pamong yang baik atau good governance, pengembangan kelembagaan, dan penerapan sistem penjaminan mutu yang berkelanjutan.
Sejalan visi dan misinya tersebut, Politeknik Kesehatan Kementerian Kesehatan Gorontalo bertujuan menghasilkan tenaga vokasional kesehatan pada jenjang sarjana terapan dan diploma 3 yang diharapkan menjadi tenaga profesional yang unggul, berkarakter, kompeten, dan kompetitif di bidangnya, sehingga mampu melaksanakan peran dan fungsi sebagai tenaga kesehatan yang handal dan mumpuni. Jurusan keperawatan mengemban tugas melaksanakan program pendidikan Diploma 3 Keperawatan untuk menghasilkan lulusan perawat profesional pemula yang diberi gelar ahli madya keperawatan dan melaksanakan program pendidikan Diploma 4 Keperawatan yang menghasilkan lulusan sarjana terapan di bidang keperawatan. Jurusan kebidanan berupaya menjadi jurusan yang unggul dalam menghasilkan tenaga kebidanan yang kompeten dan kompetitif. Jurusan kebidanan menyelenggarakan pendidikan kebidanan unggul dengan kurikulum mengacu pada standar nasional, dikti, dan kerangka kualifikasi nasional Indonesia. Melaksanakan riset unggulan di bidang kebidanan sesuai dengan perkembangan ilmu pengetahuan dan teknologi. Jurusan gizi bertujuan untuk menghasilkan tenaga gizi profesional. Dalam mewujudkannya, jurusan gizi menyelenggarakan pendidikan berbasis standar nasional pendidikan tinggi dan kerangka kualifikasi nasional Indonesia, melakukan peningkatan dan pengembangan sumber daya pangan lokal, mengembangkan manajemen pengelolaan dan penataan eliminasi stunting, mendukung penyelenggaraan pendidikan, dan melaksanakan penelitian terapan dengan mengembangkan pengetahuan dan teknologi di bidang gizi. Jurusan farmasi melakukan kegiatan pendidikan dan pengajaran melalui program Diploma 3 Farmasi dengan tujuan untuk memenuhi kebutuhan tenaga kesehatan bidang farmasi yang mampu memberikan pelayanan bidang farmasi secara profesional. Jurusan Kesehatan Lingkungan menjalankan kegiatan pendidikan dan pengajaran yang bertujuan menghasilkan tenaga kesehatan yang handal, kompetitif, dan berkarakter di bidang sanitasi lingkungan. Kualifikasi tenaga pendidikan di Politeknik Kesehatan Kementerian Kesehatan Gorontalo terdiri dari dosen tetap maupun dosen tidak tetap. Sebagian besar dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan tenaga pendidik dengan strata pendidikan pasca sarjana atau strata 2 dan sebagian lainnya dengan strata pendidikan doktoral atau S3. Tenaga dosen di Politeknik Kesehatan Kementerian Kesehatan Gorontalo sebagian besar sudah memiliki sertifikasi pendidik, sehingga kompetensi dosen dalam melaksanakan tridharma perguruan tinggi sudah tidak diragukan lagi keunggulannya. Politeknik Kesehatan Kementerian Kesehatan Gorontalo memiliki fasilitas yang representatif dalam menunjang proses pembelajaran, seperti ruang kuliah.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all participants in conference today. Because the time is showing at 13:33, so we will continue today's conference with great speakers. The speakers for this session is Mrs. Sri Sujawati, Magister of Midwifery. The speaker who is a lecturer at the Midwifery Department of the Gorontalo Health Polytechnic. And the topic is Humanity Approach for Preventing Hypertension. Before the conference session begins, a reminder to all conference participants, please cooperate to attend the conference regularly and keep the camera activated at the Zoom meeting. Then if there is anything you want to discuss, later there will be a question and answer session, so please use it as best as possible. And now, then I will submit it the moderator, Mrs. Nancy Oli, Magister of Public Health. So, Mrs. Nancy, it's your time.
Thank you, Mr. Fahmi, SMC. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome back to the third session of ICMHS. This is the International Conference on Midwifery and Health Science, held by Midwifery Department of Health Polytechnic of Gorontalo with the theme Health Transformation to Prevent Hypertension in Pregnancy. Okay, my name is Oh, sorry. Tidak aktif. Tes 1. Sorry, the Wi-Fi is unstable. Okay, my name is Nancy Oli from Midwifery Department of Health Polytechnic of Gorontalo, and right now I'm going to be the moderator today, and I really appreciated to this opportunity. Pregnancy problems can result in a risk of maternal mortality, one result of high risk levels of mortality due to hypertension in pregnancy or preeclampsia or eclampsia in addition to bleeding and infection. So, Health Polytechnic of Gorontalo wants to give contribution So Health Polytechnic of Gorontalo wants to give a positive contribution through this conference, and for that we have a great speaker for this time who is already with us. Okay, she is Mrs. Sujawati Sarjana Sains Terapan, Magister Kebidanan. Mrs. Sri, have you joined? Okay, before we continue our session, maybe a few information. Start from now until next 2 hours. Mrs. Sri will come around 100 minutes, and after she has presented her topics, we will have discussion for about 20 minutes. And for your information, our audience are faculties, researchers, practices, midwives, and also students. Mrs. Sri, have you joined?
Yes, ma'am.
Okay. For all the audience, can ask a question, and if you have a question, you can ask your question during the session by raising your hand, and you can type your question in the chat box, and I'm going to read them for you. Okay, ladies and gentlemen, I'm going to invite Mrs. Sri Sujawati, and I will read her profile. Could you comment, share her profile? Okay, our speaker today is Mrs. Sri Sujawati, Sarjana Sains Terapan, Magister Kebidanan, and she is a lecturer in Midwifery Department of Health Polytechnic of Gorontalo, and she can celebrate her birthday on 27 April in she can celebrate her birthday on 27 on April. Okay, for education background, she graduated Diploma 3 in Midwifery at Poltekkes Manado from 2003 until 2006. And then she graduated from Diploma 4 in Midwifery Education at Poltekkes Makassar from 2007 until 2008. And she graduated Master of Midwifery at University Hasanuddin from 2012 until 2015. And for work experience, in 2006 until 2007, as executive midwife in the midwifery room of Dunda Limboto Hospital, and then since 2008 until current, as a lecturer staff at the Department of Midwifery, Poltekkes Kemenkes Gorontalo. Okay, about training. a few training she has trained since 2009 until 2019. She got trained basic life support training at Rumah Sakit Ibu dan Anak Harapan Kita Jakarta, and then 2016 normal maternity care training in Bogor, and 2019 ICA mom and baby message training in Surakarta. Okay, for publication, she has published a lot of articles about research and community service. And then membership. She is a member of the Indonesian Midwives Association of Poltekkes branch of the Ministry of Health Gorontalo. And for activities experience, 2007 as participant of comparative study benchmarking at Women's and Children's Hospital in Singapore, and then 2007 as participants of a comparative study or branch making at the National University Health Center Malaysia, and then 2016 as participant of study or branch marking at Mahkota Medical Center Malacca in Malaysia. Okay, next. Okay, this session Mrs. Sri will deliver her material about humanity's approach to prevent gestational hypertension. And Mrs. Sri, you have 100 minutes to present your material, and time is yours.
Thank you very much for Mrs. Nancy Olii for giving me the time for presentation today. Can you hear me, my voice? Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, good afternoon, everyone, and I would like to say thank you Okay, I'm sorry. I would like to say thank you very much for all of the participants for coming to my presentation. And now I want to share about my PowerPoint. Let me share the PowerPoint. Okay, the topic is today is humanity's approach to prevent gestational hypertension. Okay, and the first, maternal mortality rate based on WHO data. The maternal mortality rate reached 295,000 deaths on 2020. So as we know, the maternal mortality rate is a very globally problem. So we need more effort to decrease the rate. So the highest maternal mortality rate in Southeast Asia occur in Myanmar at 282 per 100,000 live births on 2020. And then data from the Indonesia Ministry of Health, the number of maternal deaths amount 7,389 maternal deaths on 2021. So it's about the Gorontalo province health profile shows a maternal mortality rate of 252 per 100,000 live births, and it's a very high if we compare to the national target in the Ministry Health Strategic Plan, which is in 102 per 100,000 live births. So we have to hard work to give the efforts to decrease the big rate. Maternal mortality rate in Gorontalo City reported at 139 per 100,000 live birth. From Gorontalo province, the most regency is with high MMR is Gorontalo Utara. She has 13 maternal deaths, the absolute. It showed the Gorontalo Utara is one of regency problem about maternal mortality rate. So the cause of maternal mortality rate is the first is hypertension. From the data on 2021, in Gorontalo reported there is 10 women is dead because hypertension, and second one is because the maternity mortality rate is severe bleeding, and then third infection for circulation system disorder and others. The others cause of maternal mortality rate is about confirmed infection COVID-19, and then the report cardiac arrest, embolism, and other. So, talking about hypertension, I picked one publication from Mr. Weni Ino Ishak, Suwarli Mobiliu, Indra Bromili, and Herman Luawo. The title is about edukasi kesehatan sebagai upaya pencegahan hipertensi. From the article, it shows this disease, hypertension, causes death and kills more than 35 million people annually. Around 60% all of deaths globally, and 18% prevalence in developing countries. The next, prevention of non-communicable disease can be done by increasing awareness factors. So awareness raising can be done with health education or counseling, but directly and through technology. So health education requires strategies such as prevent obesity with health education can be given on how to regulate diet. Second one, physical activity can be recommended by doing like exercise such as walking. And third, control blood pressure. It can be recommended to routinely carry out health check-ins as an effort to monitor the sufferer's blood pressure. And the second one, I picked the one publication journal from Mrs. Luciana Adam and Mr. Ahmad Aswad. The title is The Provision of Papaya Charicha on Blood Pressure Reduction in Hypertension Patients. Uncontrolled hypertension can have complications, including in the brain, which includes stroke, and dementia, in the eyes, namely blindness, in the heart and blood vessels, namely arteriosclerosis, aneurysm, disease of the coronary arteries, hypertrophy of the left ventricle of the heart failure, and kidney failure. The discussion from the article, there are two treatments that can be given to reduce the impact of hypertension, namely pharmacological and non-pharmacological therapy. Pharmacological therapy only has the effect of lowering blood pressure, while non-pharmacology therapy aims to reduce blood pressure, control risk factors, and other diseases. And then non-pharmacology therapy consists of stopping smoking, losing excess body weight, reducing alcohol consumption, physical exercise, reducing salt intake, increasing fruit and vegetable consumption, and reducing fat intake. And the next, the results show is there is a reference difference in the average value of systolic and diastolic blood pressure before and after giving papaya juice, which is between 150 until 142 mmHg and 95 until 80 mmHg. There's an effect of papaya juice on reducing blood pressure in hypertensive patients. And then therapy non-pharmacological treatment. I mean the other therapy on pharmacological treatment is cupping. We know it's about bekam. One of the trends on non-pharmacological treatment to treat the hypertension today is cupping or bekam. Cupping is an alternative treatment that is quite popular since ancient times. Cupping is the one way of healing. Cupping is a treatment technique using glass, tube, or bamboo. Means that the process begins by shoveling, making negative pressure in the glass, tube, or bamboo. At the point of cupping, this causes local damage on the surface of the skin. Cupping is also often offered to as a therapy that serves to bleed dirty. Some studies that support cupping therapy are recommended for people with hypertension, namely Andika et al. Research on 2019 on phenomenology studies of quality of life hypertensive patients to continue to undergo cupping therapy as an alternative to complementary therapies. Effect of cupping therapy in blood pressure of people with hypertension in the working area of Central City Health Center Gorontalo City on 2020 is research from Mrs. Luciana Adam and Mr. Ahmad Aswad. The result is blood pressure before cupping therapy is hypertension. 30%, hypertension degree 1, 40%, and hypertension degree 2 is 30%. And there is an effect of cupping therapy on blood pressure reduction in people with hypertension in the working area of Central Health Center. And then I take one journal from Jurnal Kebidanan with the title is The Effect to Giving Tomato Juice on Blood Pressure on Menopause. It's the result of research from Mrs. Yusni Padungge, Vira Puwili, and Dahyulyaningsih, and Ms. Rusjawati, and Mrs. Puspita Sukmawati Rasid. Before treatment to consume tomato juice, most had mild hypertension, 21 people or 95.9%. After the administration of tomato juice, most respondents had mild hypertension until 14 people or 63.6%. And after consuming tomato juice, there is still one respondent who did not experience a decrease in blood pressure. So first, to reduce the maternal mortality rate, consists two efforts. One is direct effort, consists promotive and preventive. So second one is indirect effort. It's about improve antenatal care and improving the role and function of midwives. For today's presentation, I take the topic is about the humanistic approach. I mean the humanistic approach is the midwife. Midwife has a humanistic approach to help decrease the rate of maternal mortality rate about caused by hypertension. The humanistic approach is an approach that believes that humans are free subjects to determine the direction of their own lives over the lives of others, so that this is in line with the philosophy of midwifery care, which believes that humans are biopsychosociocultural beings, so that it is necessary for midwives to believe that pregnancy and childbirth, beliefs about women, beliefs about professional function and benefits, beliefs about empowering women and decision makers, belief about the purpose of care, and beliefs about collaboration and partnership. I take one journal from Mrs. Eka Rati Asuti, Ms. Fitri Hussain, and me, and Srisjawati. It's about hypertension is blood pressure over 140 per 90 mmHg. Hypertension is one of the world problems that plague the world. As per WHO information, pregnancy hypertension is one of the causes of maternal and infant morbidity and mortality worldwide. The dominant factors associated with hypertension in pregnancy are age, history of hypertension, parity, obesity, and stress, while the most dominant factor is age. So then I take one journal from Citra Puspita Putri, Fitra Hayu Rifai, Ismi Wahyuni Latif, Nanda Afrianti, Rahmawati Yansi Ali, and all. The title is Increased Maternal Mortality Rate Due to Preeclampsia. The article shows that preeclampsia and eclampsia are one of the complication of pregnancy that are caused directly by pregnancy itself. Preeclampsia is the onset of hypertension accompanied by proteinuria due to pregnancy after 20 weeks of gestation or immediately after delivery. The results show from 40 respondents, there were 35 who had preeclampsia and 5 who had severe preeclampsia. There is a significant relationship between incidence of preeclampsia with the incidence of cesarean section at RSUP Wahidin Sudirohusodo, Makassar in 2018. I repeat again about humanity approach. The humanist approach is an approach that believes that humans are subjects to determine the direction of their own lives over the lives of others. So I picked one journal from Mrs. Maisuri Tajuddin Halid. The title is Upaya Menurunkan Angka Kematian Ibu. Based on the triad of cause maternal mortality, according Mrs. Maisuri Tajuddin Halid, the key intervention that can be carried out by the role of health workers is 1. Promotion of focused antenatal care. As we know, the antenatal care consists until 10 steps. We know is 10T. Second one, management of the preeclampsia with emergency management. It's about kids. They suggest to kid between bleeding kid and preeclampsia kid. And then preparedness for the eclampsia, emergency management in eclampsia is A, B, C, 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 D. And fourth, presenting the family planning program. And the last, empowering all parties, innovating best practice in the community. The best practice, I take a journal from Putri Azahro and Lina Oktriani. The title is Hubungan Pengetahuan Ibu Hamil, Peran Bidan, dan Peran Suami Terhadap Perilaku Pencegahan Hipertensi pada Kehamilan di Puskesmas Pancoran Mas, Depok, Jawa Barat. It's about the role of midwife towards behavior of preventing hypertension in pregnancy. There is a relationship between knowledge, the role of the midwife, and the role of the husband on hypertension prevention behavior. The results show respondents who had a good assessment of the midwife's role in preventing hypertension also had good hypertension prevention behaviors. According to the research's assumption, that midwives play a role in providing support and moral support for clients in dealing with physical change and physiological adaptation. This is in line with the result of Elmianis research on 2014, where the result of bivariate analysis found that there was a relationship between family support and adherence to a hypertension diet with the value of family support. And then I take the journal from Mrs. Nurwahida Karim and Yusriani with Fairuz Prihatin Idris. The title is Knowledge of Pregnant Women in Preventing Hypertension based on the SMCR communication model of midwives in the village. The results show that there were 22 respondents, or 29.7% of pregnant women who had insufficient knowledge, and those who had sufficient knowledge were 52 or 70.3%. So there was no relationship between the SMCR communication model of the village midwife and the knowledge of pregnant woman with a p-value is 0.412. From the article, its suggestion is it is hoped that the next researchers should examine the relationship between the SMCR communication model of village midwives and then knowledge of pregnant women in preventing hypertension. And then I take journal. I just to read the title. The title is Level of Knowledge of Midwife about early screening hypertension in their work area. This study shows that the level of knowledge of midwives regarding hypertension is mostly in the good category. Good knowledge adjusts to the level of education and work experience of midwives. The majority of the education is diploma 3 or diploma 3 graduates with a length of work of 4 to 5 years. So I take the one journal publication from Septi Eka Novela with the title The Effect of Using Preeclampsia Booklet on Pregnant Women's Knowledge About Preeclampsia at PMB, Praktek Bidan Mandiri. The effect of using preeclampsia booklet on pregnant women's knowledge about preeclampsia at PMB is associated. And then I take one journal publication from Danur Aziza RS and Dwi Wulandari with the title Factors Associated with the Role of Midwives in Monitoring and Early Detection of High-Risk Pregnancies. Between age, knowledge, attitude, and motivation with the role of midwives in monitoring and early detection of high-risk pregnancy in the work area of Puskesmas. I take one journal publication from Sylvia Mawarti Perdana and Hardiansyah with Evi Damayanti. The title is Alternative Balanced Nutrition Index for Nutritional Quality Assessment of Food Consumption of Indonesia Adult Women. The most consuming food group was carbohydrate food with a consumption rate of 99.9%, while the least consumed groups were fruit, add sugar, and milk. The IGS alternative developed are based on food or nutrients groups and quantity and score levels. The IGS 3 until 60 score in adult women is still classified as very deficient. So in the last article, I take from Mahdalena Tompunu and Ekarati Astuti. The title is Prevention of Non-Communicable Disease Through Formation of Cadres Caring for a Hypertensive Pregnant Woman. From this article, the results that have been achieved are that cadres are able to do food massage and blood pressure in pregnant women is reduced after food massage by 100% who previously could not massage feet. After training, 10 cadres can do foot massage in hypertensive pregnant women. This is the picture about the foot massage. Okay, I think it's enough for me to show my presentation, and then I want to permit from Mrs. Nasi Olii or the committee.
Ya, tidak bisa. Tidak bisa juga. Mrs. Ri? Oh. Could you repeat your question or what? Is finished?
Yes,
Yes,
I
I
understand his
understand.
question.
Okay, that's the last slide. Okay, I think we have more time for next session. And now we move to next session, question and answer session. Oh, I see a few questions in chat box. And I will start from, okay. Could you accommodate to share the questions from the audience? Okay, the first question, I will start from Wahyuni Mohune from the Gorontalo Health Polytechnic campus. And the question is, what can a person do to avoid contractive hypertension, and what actions will be taken so that people with hypertension? Please, Mrs. Sri, you can answer. Time is answer.
Okay.
Okay. Contracting itu apa?
Kasih. Okay, thank you for Wahyudi Mohune for the question. You asked about what can a person do to avoid contracting hypertension, and what action will be taken so that people with hypertension. What the meaning contracting? Can you repeat your ask, Wahyuni? Oh, okay. I try to answer. According me, we can ask the person to avoid contracting hypertension is we have to healthy. We have to keep the healthy of our body. Consist is no smoking, activity daily with activity physical. So always to consume about fruits and vegetables more than the junk food. I think that for the something you can do avoid the contracting the hypertension. I think it is enough for me to answer this question. Maybe I'm sorry if it's not clear or what.
Okay, thank you, Mrs. Sri. And I think we have to move to next question. Please, Chef. Okay, the second question from Anissa Putri Lasulika from Gorontalo Health Polytechnic. And the question is, what are the most underlying cases of maternal mortality in Indonesia? Do not experience complications, and that's all I want to ask. Okay. Mrs. Ri, time is yours to answer the question.
Okay, thank you for the second question from Anissa Putrila Sulika. It's about what are the most underlying causes of maternal mortality in Indonesia. From the data, is the most underlying causes of maternal mortality in Indonesia is hypertension. I will have experience. Maybe it's the data in Indonesia and the Gorontalo province is same, because from the data 2021, it show hypertension is cause most of some causes other. There are 10 people deaths about hypertension is reported from the profile health in Gorontalo province. And then I have experience when I
Ada lebih lagi.
go visit to hospital in Gorontalo. I see the kit too big to kit, the bleeding kit and preeclampsia kit. Bleeding kit is locked and preeclampsia kit is open. So it describes how the reality in our case of maternal mortality is real, because the kit of preeclampsia is open up. This open. Not same with the bleeding kit. Bleeding kit is locked. It's locked. It's maybe I can sharing a little story about my experience when I go to the visit to one hospital in Gorontalo. I think it's enough from me to answer this question, Miss.
Okay, thank you, Mrs. Ri. Maybe we move to the next question. I think this is an interesting topic, so many questions come to the committee. I try to read the next question from Regita Yuniar Aris from Poltekkes Gorontalo. The question is, I've read in an article that combination birth control pills and combination injection can also increase blood pressure and cause hypertension. And the question is whether there are sufferers of hypertension who work as prostitutes who do not know this and have used combination birth control pills or combination injection. Will it have an impact in the future if she Okay, will it have an impact in the future if she wants to stop using birth control and have a family until she gets pregnant? And how do we as health workers overcome this? Please answer, Mrs. Sri.
Okay, thank you very much for the question. Okay, I try to answer one by one. From the question about have used combination birth control pills or combination injection. Will it have an impact in the future if she wants to stop using birth control and have a family until she gets pregnant? I think you have to go to consult to midwife if you want to consume the control pills or combination injection. Over there, you have to you will get physical examine, yeah, and then they can give the recommend what you what the combination what the birth control metode, ya, the combination injection or combination birth control pills, because both of them is consist the hormonal, and as we know the hormonal, if we get for the long time, it can be effect for our body. Somebody have feel about this combination birth control pills or combination injection, and then they get the increase from the blood pressure or the other unwell they have. And then and how do we as health workers overcome this? I think you can tell all of your condition to the health workers, and you can say what you need for your planning family. I mean your family planning to the future. What do you want to need? I think that I think it's enough, Ms. Nancy.
Okay. Thank you. I think we still have 6 questions. We move to next question from Cindy Badran. And the question is, what impact can be experienced by pregnant women and the fetus if preeclampsia occurs? Is it clear? Please, Mrs. Sri. Okay, I repeat.
Okay,
What impact can be experienced by pregnant women and the fetus if preeclampsia occurs? Or maybe we can move to other question. Or you can try answer that question. Or we move to next question.
Okay, Mrs. Nancy, I will try to answer question from
Okay.
Cindy Baderan. What impact can be experienced by pregnant woman and the fetus is if preeclampsia occurs? If preeclampsia occurs, give impact for the woman pregnant and her baby. I mean the fetus. For her baby, maybe the baby getting have the baby is get the IUGR or oligohydramnion until IUFD. If for the impact for the baby or the impact for the fetus, the impact for the pregnant woman is severe condition is convulsion, the chronic convulsion, and dangerous for herself because it can be dead, so it's harmful. Okay, Miss Nancy, I think it's enough for answer to Cindy Baderan's question.
Okay. We still have 5 questions in the chat box. So we move to next question from Adelia Septianda from Gorontalo Health Polytechnic. The question is, what can increase the risk of pregnant women experiencing hypertension? Okay, what can increase the risk of pregnant women experiencing hypertension?
Miss Nancy, I can raise the question.
Could you repeat?
Or can you repeat again what the question?
Okay, I try to read. The question from Adelia Septianda. The question is, what can increase the risk of pregnant women experiencing hypertension?
What can increase
the risk of pregnant women experiencing hypertension?
I'm sorry, I can read the question, Mrs. Nancy. Can you change the question other?
Oh, maybe we move to other question, to next question. From Rahmawatiansi Ali. And the question is, one approach to preventing hypertension is reducing excessive salt consumption. Some of the articles that I got had several supporting journals and do not support salt consumption, causing hypertension. According to him, what is the response to the causes of hypertension from consuming the salt? It's about consuming salt, I think.
Hello? I'm
Is it clear?
sorry. Once again, I
Okay,
can't get it the
okay.
question.
I try. One approach to preventing hypertension is reducing excessive salt consumption. Some of the articles that I got had several supporting journals and do not supporting salt consumption, causing hypertension. According to it, what is the response of the causes of hypertension from consuming the salt? Maybe she has two articles, and the result of of research is different. One of the result supporting that uh, consuming salt, and the other not supporting. Okay. We move to next question from Sagita Bilatula. Pregnant women who have hypertension, what complications will occur to the mother and fetus? Okay, I read again. What pregnant women who have hypertension, what complications will occur to the mother and fetus? Or maybe, please answer, or maybe next, we still have the last question. Okay, we move to the last question from, oh, still more questions. 5 questions. Sorry. Or maybe Mrs. Wee can choose the question in the chat box. Or, okay, I try to choose the question in the chat box. Okay, from Istiara Mantali, the question is how to find out if you have preeclampsia or not. What kind of laboratory data is required for a backup check? Okay, how to find out if you have preeclampsia or not, and what kind of lab maybe result of laboratorium is required for a backup check. Okay, I try to next question from Priscilia Suleman. What efforts will be made so that people with hypertension do not experience complications? What efforts? Chat ke sana Pak Ibu itu upaya-upaya. Okay. We still have a few questions. Maybe Mrs. Sri can choose. You can choose in the chat box. Okay, maybe the question from Farida, how to handle postpartum SJ mothers who of SJ1s. Patients are usually advised to eat high protein foods, but for hypertension women, is it not recommended to consume high protein foods? What upbringing should we give? Okay, I think time is over, and we still have 1 minute, and I think this session is finished. So to our speaker this time, Mrs. Sri Sujawati, Mrs. Sri Sujawati, thank you so much for your dedicated to this conference. And for this time, I would like to give you a certificate of your participation as a speaker in this conference. The committee, please. Oh.
Thank you.
Okay, thank you. And to all participants who actively engaged in this session, I want to say thank you so much for your attention, and thank you all. Assalamualaikum warahmatullahi wabarakatuh. Unmute, unmute. Bilang apa?
Mari kita sukseskan transformasi kesehatan, layanan primer, layanan rujukan, sistem ketahanan kesehatan, pembiayaan kesehatan, sumber daya manusia, teknologi kesehatan. Mari kita tingkatkan kerjasama lintas sektoral, budaya Kementerian Kesehatan. Kemenkes berakhlak, inovatif, profesional. Kemenkes yang hebat, integritas, anti korupsi, urusan masyarakat, sehat sejahtera, produktif, berkeadilan. Mari kita sukseskan transformasi kesehatan, layanan primer, layanan rujukan, sistem ketahanan kesehatan, pembiayaan kesehatan, sumber daya manusia, teknologi kesehatan. Mari kita tingkatkan kerjasama lintas sektoral, dukungan stakeholder dan masyarakat, infrastruktur memadai, bekerja profesional, kerja keras dan cerdas, budaya Kementerian Kesehatan.
Politeknik Kesehatan Kementerian Kesehatan Gorontalo merupakan sebuah institusi pendidikan tinggi vokasional bidang kesehatan di bawah naungan Kementerian Kesehatan Republik Indonesia dan di bawah pembinaan langsung oleh Kementerian Pendidikan Kebudayaan Riset dan Teknologi. Kampus Politeknik Kesehatan Gorontalo berlokasi tepat di Kota Gorontalo, Jalan Taman Pendidikan nomor 36, Kelurahan Moodu, Kecamatan Kota Timur, Kota Gorontalo. Politeknik Kesehatan Kementerian Kesehatan Gorontalo saat ini terdiri dari 5 jurusan dan 8 program studi. 5 jurusan tersebut yaitu jurusan keperawatan, jurusan kebidanan, jurusan gizi, jurusan farmasi, dan jurusan kesehatan lingkungan. 8 program studi yaitu program studi Sarjana Terapan Keperawatan, program studi Sarjana Terapan Kebidanan, program studi Sarjana Terapan Gizi, program studi Sarjana Terapan Sanitasi Lingkungan, program studi Diploma 3 Keperawatan, program studi Diploma 3 Kebidanan, dan program studi Diploma 3 Farmasi.
Thank you, Mrs. Sri Sujawati, for your extraordinary knowledge presentation. I hope this can add more reference for all midwife in Gorontalo and Indonesia in general. Thank you, Mrs. Nancy Oli, for the opportunity to be a moderator. All right, then we will go to the last speaker on the second day of the conference. But beforehand, I represent the committee, thanking for those parties who have supported this activity, such as the Gorontalo Health Polytechnic, the Gorontalo Province Indonesia Midwife Association, Gorontalo City Indonesia Midwife Association, and the Gorontalo Health Polytechnic Branch Indonesia Midwife Association. And then as well as various sponsors who have helped in the success of this conference, such as BSI Gorontalo, Radix Dental Care, Nayumi Parfum Gorontalo, Geprek Uyat Gorontalo, Kosmis Fala Gorontalo, Warung Makan Bakso Mas Agus, and many more. So, ladies and gentlemen, to all participants, because the speaker is already in the Zoom meeting, then we enter the last session at the conference. The speaker is Medical Dr. Andreas Winarno, specialist obstetrician and gynecologist from Otana Hospital, Indonesia, with the topic Emergency in Obstetrics, and moderated by Mr. Rahman Suleiman MKes. So, Mr. Rahman, it's your time.
Hello. Yes. Thank you very much. Hello, my name is Rahman Suleiman, and today I'm going to be the moderator who managed our discussion. And I would like to welcome you at the 3rd International Conference on Midwifery and Health Science 2023, with the topic is Health Transformation to Prevent Hypertension in Pregnancy. And we are entering the last session in this second day. So before we start our session today, allow me to announce the profile of our main speaker in this session. I need... Okay, as you may see in your display, this is medical doctor Andreas Winarno, SPOG, B-Med Science. Educational background in 2023, graduated abroad in Otanaha Hospital, Gorontalo, which is he's currently working. In 2021 to 2022, Oberreist, and had entered the gynecology, oncology, and subspecialty program. In 2021, diploma in microinvasive chirurgy, apologies for the mispronunciation, OMIC, laparoscopy, endoscopy, and at the same year's degree in medical doctor with magna cum laude in University of Düsseldorf, North Rhine-Westphalia, German. Feto-maternal subspecialty in German at the same university, Düsseldorf University Hospital. In 2012 to 2018, obstetrics and gynecology specialist in Germany. Düsseldorf University Hospital, Hell University Hospital, UKJM Standard Marburg University Hospital. In 2008, biomedical Bachelor Medical Science degree from University of Melbourne, Australia. And in 2004 to 2011, Medicine Faculty in Indonesia University. Ladies and gentlemen, I would like to say hello to Dr. Andreas Winarno. Hello, doctor. Could you hear my voice? Hello. It's still mute. Yeah. Yeah. Okay. So for the next maximum 100 minutes, you will be able to deliver your presentation, sir. And then after that, we will be entering the next session, the Q&A session. So to Dr. Andreas Winarno, please to put your presentation on display. Thank you.
I think I need the help of the host to share my screen because still low. Maybe the host can help me to open because it's still in disable mode.
Yeah, it has been opened, sir. Please.
Okay, can you see now? So good afternoon, everybody, sir and madam. I would like to present about emergency in obstetrics for this third international conferences in midwifery and health sciences 2023. So maybe I would like to share about the background in Germany. So this is the map of Germany. It colonized by four countries in between 1945 until 1991. So the eastern part with the Russia, and the southern part USA, southwest part with French, and also the northern part by England. So the medical system, I think, is supposed to be about the same like in America and also in England nowadays. So emergency in obstetrics, what is it? The health problems that are life-threatening for pregnant women or their babies. The condition may arise at any time during pregnancy, such as first trimester, second trimester, third trimester, labor, and birth. The woman may need specialist care and extended hospital care. So this is the picture that I worked before in Düsseldorf Hospital. I show you here, there's a monitor. This is a monitoring for the CTG, and it's connected through all of the delivery room and also the central monitor. Because it's very important during the delivery process to monitor whether the fetal heart rate still in the good condition, or maybe possibility of deceleration or maybe bradycardia. And then the second part for the diagnostic and kind of problem in obstetrics, also important to have ultrasonography. So in the first trimester of pregnancy, which is up to 14 weeks of gestation, this problem may arise. The first one is, the most common one is hyperemesis gravidarum. The patient complains nausea and vomiting, but it could also have severe vomiting that can lead to electrolyte imbalances and also dehydration. Of course, if this happens, it can lead to the death of the mother. And then the second one is miscarriage. It's quite often. The first one is threatened. We call it in Latin language as imminence. That means the cervical canal still closed. And then the second one is inevitable, or we call it incipience. That means that the cervical canal is already open. And then the third one is incomplete. That means that only just the fetus or part of the placenta already been born. Yeah, and the last one is complete. That means the whole of the placenta is already delivered. But there is also some other miscarriage, but I would not discuss any further. And then the most common emergency in first trimester also about the ectopic pregnancy, where the fertilized egg implants in one of the fallopian tubes. This one is the most common one, and then the next one may be in ovary, or maybe other places such as mesenterium, or maybe in intracervical, or maybe in myoma cavity is also possible, rather than in uterus womb, which is the uterine cavity. here is the uterine cavity, as you know. It's supposed to be here, the seats of the fetus. What are the most common signs and symptoms? The first one, the most common, is lower abdominal pain. With the urine beta HCG test or plano test positive, but unidentified where is the pregnancy location. But if the ultrasound examinations performs carefully, usually we can find, because the most common one, maybe more than 95% is in these fallopian tubes. And what is the other sign and symptoms? Profuse intra-abdominal bleeding. So what happens if this rupture, then it bleeds, and the blood fill the abdominal cavity. This is the example of the free fluid in intra-abdominal cavity. This is the case from last Saturday that I have, and she had ectopic pregnancy with the rupture of the ovarian artery. And this is the cases in February that the ectopic pregnancy occurs in the fallopian tubes. This one is the most common one. And then the next one, before that, so the first trimester ultrasonography is very important, especially in between 6 to 8 weeks, to know where the fetus implants, where the pregnancy implanted or nidated, because it's very important to differentiate whether is it intracavity or outside. That's why ultrasonography is very, very critical in the first pregnancy, first trimester of pregnancy. And then the next one is hyperstimulation syndrome. The most common one due to in vitro fertilization, because some patients are prone, only just small difference of dose can lead to hyperstimulation syndrome. If this happens, the patient may suffer from dehydration, and then the next one, if severe dehydration happen, can lead to thromboembolism and death of the patient. So we move to the second trimester of pregnancy. That means the pregnancy up to 28 weeks of gestational age. We call it still miscarriage if the abortion happened before 23 or 24th gestational age at this time. And the next one is placenta previa bleeding. Usually the placenta previa bleeding in the second trimester not yet severe, but it could, the repetition of the bleeding usually getting more severe on the third episode or fourth episode, maybe already reaching the third trimester of pregnancy. So what do we know about placenta previa? There are several types of placenta previa. The low-lying placenta, that means only reaching, not yet into the cervical canal, only just reaching almost the cervical canal. And the marginal reach only the small part and the marginal side of the cervical canal. And then the partial one is it covers about half or maybe more than a half of the cervical canal, or complete or total placenta previa. It's cover the placenta covers the whole part of the cervical canal for the delivery. And then the next part is uterine cervical insufficiency. So this uterine cervical canal is supposed to be more than 2.5 centimeters through all of the pregnancy gestational age. But it can also happen due to infection or maybe many other risk factors like diabetes, obesity, and then maybe collagen tissue problem. It could be shortened, or maybe twin pregnancy or triplet pregnancy. It could happen, of course. So the diagnosis using ultrasonography. And then the next one is a prolapse of the membrane. That means the membrane is already seen by the specular examination from the vagina. So this one, of course, can lead to the miscarriage or maybe the delivery of the baby in the extremely preterm birth. But there are certain kind of methods to prevent this kind of problem, such as suturing the cervix using Marcelin band or using the cerclage. But I'm not sure this Marcelin band whether available in Indonesia. And then the next problem, the last one, usually is the P-prong. What is it? Is it a preterm premature rupture of the fetal membrane? So if the fetal membrane is already open, most common one, they won't be closed anymore. But only in certain cases, possible maybe cause maybe the rupture of the hole at the upper part. But the classical one, at this cervical canal one, usually won't close anymore. What could happen for the fetus? Because the amniotic fluids contain many kind of nutrition, so the bacteria from the vagina can grow up easier to the upward and then make a chorioamnionitis. And this, of course, lead to the fetal infection, and also mother suffer from the chorioamnionitis and maybe sepsis. Okay, and there are some other also problems like chromosomal abnormalities, placental problems, thrombophilia, infection, congenital birth defects, cervical abdominal trauma, or maybe abuse of the drug and alcohol lead to certain kind of related pregnancy problems, and then poor control chronic condition like chronic hypertension or diabetes mellitus, and moreover. And the next one is the third trimester of the pregnancy. That means the pregnancy beyond 28 weeks of gestational age. What is the most common one? Is preeclampsia. Of course, there are certain criteria for the preeclampsia. The first one, the hypertension occurs in pregnancy, not before pregnancy. That means chronic hypertension. And then there is a possible, there is also a sign of proteinuria. So in Indonesia, the criteria also same like internationally, but the diagnosis may be different. How to diagnose? Usually we use only just these two, but there are actually one predictor. In the developed country, they use already this marker as split and PLGF ratio. This one with the value is when the value below 38, that means the possibility of the pregnancy is very, very low, almost none. But actually, in my experience, in between 38 to 85 is still also low risk, and more than 85 usually prone to develop preeclampsia. So this pregnancy test with SFLIP-SGF can be done from the 12th week of pregnancy until the delivery time. And if the patient, having the value above 85, usually below the 17 weeks of gestational age, we prescribe the aspirin. Aspirin is very important to prevent this placentation problem. So preeclampsia can also occur after the delivery, usually in the first 2 weeks, but is very seldom, can happen until up to 6 weeks after the delivery. What kind of organs that could be affected? So actually, the whole part of the body, like kidney, the eyes, retina problem, and then the liver, and also the brain. And if this uncontrolled preeclampsia happens and seizures occurs, or convulsion, that we call it eclampsia. So how come this eclampsia happens? Because there is a hypoxia condition of the brain. The oxygen, because of the high blood pressure, actually at the beginning to compensate the perfusion of the blood to the fetus, but this compensation, of course, having a side effect consequences, and the blood perfusion to the brain is getting lower and lower, and this can lead to the hypoxia, and of course, in the chronic hypoxia and cerebral edema because of the proteinuria, that can lead to the convulsion. And then what happens in these other prodromal symptoms of the HELLP syndrome? The next one is the liver edema or the capsule getting distended. So if you measure the SGOT, SGPT in preeclampsia cases with the HELLP syndrome, of course, that can exponentially increase, and also can have a kidney injury. So the HELLP syndrome stands for hemolysis, DHE, hemolysis, and then elevated liver enzyme. I mean the EL, the H is hemolysis, EL is elevated liver enzyme, and ELP is the low platelets. And I'm not sure whether maybe only in certain part of Indonesia can use haptoglobin to measure this hemolysis process. The haptoglobin, if the value lower than 30, that indicates sign of hemolysis. And then the elevated liver enzyme examination are SGOT, SGPT, and the low platelets, of course, thrombocytopenia. But it's not the normal value thrombocytopenia. Usually we call it HELLP syndrome, and we have to be careful, especially when lower than 100,000, because it can easily to have profuse bleeding. And then the next one is bleeding of placenta previa, like I said before, in the second trimester. And then the last one is placenta invasion. Placenta invasion, there are 3 types. The first one is accreta, only just the endometrium and the decidua part invaded. And then the increta, that means is already invaded the myometrium line, and pracreta is already passing through the serosa of the uterine cavity. If the placenta accreta, we can deliver the placenta, maybe can increase the chance of the bleeding, but if they handled properly, it can stop without problem. But increta and pracreta, it can lead to severe bleeding, and maybe in the last consequences, we need to perform the hysterectomy because it depends actually on the invasion, whether the big blood vessel invaded or not. And usually this placenta invasion happens after the cesarean section cases, the most common one. And in the scar of the cesarean, previous cesarean section, invaded by the placenta. So there are certain stage of the preeclampsia. The first one, if impaired of the placentation and pseudovasculogenesis. So in normal pregnancy, usually the blood vessel develop until the myometrium, and this one to give enough supply for the babies. But in preeclampsia cases, the blood vessel in patient is not really enough until the suitable one. So this one, of course, as a compensation of the blood vessel, they produce angiotensin to increase the blood circulation to the fetus. Yeah, and there are, of course, some factors like oxidative stress, genetic factors, and other factors like diabetes, hypertension, and and so on. And then after this, in the early stage of the pregnancy happens, and then it can lead to the clinical manifestation, and usually happens in the second or third trimester. The preeclampsia, it happens already beyond the third weeks of pregnancy, usually not as severe as before 33rd weeks of pregnancy. So again, this HELLP syndrome, proteinuria, and hypertension, we have to be careful. And what happens if this occurs in the long period of time? The baby will be too small for the gestational age, that we call it IUGR. IUGR, that means intrauterine growth retardation. So the criteria of the hypertension is the same like outside of the pregnancy, like the normal, human, not the pregnant one. The first one is the the first stage of the hypertension in between systolic blood pressure 140 to 159, and the diastolic in between 90 to below than 110. And for the severe type, that means the systolic blood pressure above 160, and the diastolic blood pressure is above 110. And the proteinuria more than 300 milligrams per day, or more than 30 milligrams per nanomole in 24 hours. So the target therapy using the antihypertension drugs, we have to maintain that the blood pressure is in between 130 to 150 for the systolic, and the diastolic in between 80 to 100. Why this is important? To prevent cerebrovascular complication. And this is also the possible risk factor for the preeclampsia to develop previous hypertension, diabetes, chronic kidney disease, obesity, and then age of the patient above 35, of course, increase of the age, or maybe teenager pregnancy also, and also race. And certain race also have more prevalence for developing preeclampsia compared to the others. And then multi-gestational, multifetal gestation, assisted reproductive therapy, not yet having a baby, genetic, and many others like immune and biological. So this is the molecular what happened in the placentation. And then why the liver enzyme is increased? Because there is impaired liver function, and also hepatic cells of infection, and also infarction, and also edema. And then hypertension led to the thrombocytopenia and DIC, and then for the brain, cerebral edema, headache, visual changes, or maybe eclampsia with the seizure, convulsion. And then usually if the eclampsia happen, if we perform MRI, there is a sign of the PRES. PRES, that means posterior reversible encephalopathy syndrome. In Germany, if the patient had eclampsia, we perform regularly for the MRI examination. And then maybe because the uncontrollable blood pressure above 200, it can lead to the hemorrhagic stroke. And it's very dangerous, of course, can lead to the death of the mother. And also myocardial problem. And then problem also long-term for the kidney organs. And then infection of the placenta or placental abruption, solution placenta, and lead to the fetal death. So the preeclampsia, of course, we divide it into two kind of therapy. The first one is for the maintenance therapy. That means we want to prolong the pregnancy because the pregnancy is still in the preterm period. And also the definitive therapy. Definitive therapy actually deliver the baby as soon as possible, and then we remove all of the placenta material from the uterine cavity. Why we have to do that? Because it resolves when the placenta is already removed, clean. If there is a certain part of the placenta still inside or left behind, of course, this placenta can still lead into the next episode of the high blood pressure. So if the pregnancy already reaching the mature stage above 37 gestational age, of course, termination of the pregnancy is indicated. But maybe in certain type of preterm, we have to terminate the pregnancy because maybe uncontrollable blood pressure, or maybe the sign of severe thrombocytopenia, or maybe elevated liver enzyme more than 10 times, or maybe as like eclampsia, we have to deliver anytime, regardless of the gestational age. But if possible, of course, we would like to prolong the pregnancy as long as possible, nearly the term gestational weeks. What kind of possible drug that we can use? The first one is calcium channel blocker, such as nifedipine. Nifedipine, the retard one, the prepared, can work longer and stable compared to the acute one. Because the acute one, the peak of work is about 2 to 3 hours, but the nifedipine retard is about 4 or 5 hours. And then methyl-dopa, this is the first line therapy in Germany using methyl-dopa. And then the next drug of choice is beta blocker, such as labetalol, metoprolol. And then if the blood pressure is too high, usually we use IV preparates such as urapidil or dehydralazine. So these are the dose. Usually like nifedipine, we can use 10 to 20 milligrams 3 times a daily, but actually it can be used until 100 milligram per day. Methyl-dopa such as 2.5 grams per day, the maximal dose. But usually we start from the low dose, and then we need to titrate until reaching a stable blood pressure. But there are some contraindicated medicine in pregnancy for to reduce the blood pressure, such as ACE inhibitor, AT1 receptor blocker, because can lead to teratogenicity after 20 weeks of gestational age, such as renal dysplasia of the fetus, IUGR, and intrauterine fetal death. Or it can lead to oligohydramnion, and of course can lead to renal failure also. So what are the consequences of the preeclampsia and cardiovascular risk later in life? If we see this curve, the population with the preeclampsia, of course, having an increased risk in lifetime of having cardiovascular diseases. But if the patient during the pregnancy doesn't have any complication, healthy, with normal blood pressure, the survival rate, of course, better, and also having better in terms of cardiovascular problems in the old age. So, important risk factor of the cardiovascular diseases. First one of the risk factor is preeclampsia, and then the next one is gestational diabetes, and then preterm delivery and low birth weight. This kind of problems, if it happen during pregnancy, can achieve 2 times higher risk of death later in life. So the facts is more than 80% of the women bears one child, and then 25 to 35% of women having one complication in pregnancy from this. And then more than 20% of women having one risk factor of cardiovascular disease, such as preeclampsia, diabetes, preterm birth, low birth weight. So we want to speak about eclampsia in detail. If the convulsion happen, we have to secure the airway to prevent aspiration. This is very important because the person who suffered from convulsion, they lost, or maybe they have a reduction of the awareness. And then left side body position is also important to prevent aspiration. And then if we have any possible suction of the oral secretion, we can perform it, but after the convulsion already finished. Before that, we have to prevent the teeth biting the tongue. Usually we use something like rubber material. And then airway adjuncts should also be readily available if patient deteriorates and requires intubation. And then the most important drugs that we have to administer is magnesium sulfate. This is the first line treatment for eclamptic seizures, and also for the prevention of the eclamptic. If the patient already having preeclampsia and severe, worse blood pressure, uncontrollable, magnesium sulfate is indicated. Usually we give in loading dose 4 to 6 grams IV over 15 to 20 minutes. You have to give it slowly because it burns the vein. And then for the maintenance dose, usually give 1 gram hourly for at least 24 hours. It will be best if we perform at least 48 hours. And then we have to be careful because this magnesium sulfate can also lead into toxicity. Actually, the easier part, we have to control the reflex of the patella. But if this monitoring not performed properly, of course, it can lead to respiratory depression, CNS, central nervous system depression, and also cardiac arrest. Of course, it can lead to the patient death. And we have to monitor, of course, the kidney function and also the urine output. That means the balance of the fluid input and output we have to monitor tightly. If this toxicity the toxicity we recognize it early, we can give the antidote. The antidote that this is one of the emergency medication should be available in hospital, in delivery room is calcium gluconase. And then there are some other possible anti-epileptic medication like diazepam, phenytoin, benzodiazepine if the unresponsive to magnesium sulfate, and also barbiturates. But please be careful with myasthenia gravis patient. We cannot give those medication before. We have to give levetiracetam or valproic acid as an alternative. So we move into the labor and birth. So there are 3 types of deceleration of the CTG. Early deceleration, that means the fetal going down or getting slower during the contraction occurs of the uterine muscle. Late one, that means the fetal heart rate happens after the contraction of the uterine muscle. The variable, that means is not dependent or independent from the uterine contraction. The deceleration occurs. If this happens in repetition, of course, this can lead to fetal asphyxia. And then the next one is fetal bradycardia. Is one of the emergency situation that we need to decide as soon as possible whether this is still possible, maybe with the help of the vacuum extraction or forceps, or we have to change into the cesarean section. So that's why this CTG and also the monitoring, this one is connected and connected through all of the room. It's actually very important to monitor this kind of signs. And in Germany, they have criteria if from the decision until the delivery should be less than 20 minutes. If such as fetal bradycardia happens or severe deceleration happens, because at this time it can reduce the late fatal consequences of fetal asphyxia, or maybe in the long term the baby can lead to mental retardation if prolonged hypoxia happen. And then the next one is shoulder dystocia. That means the head of the baby already been born, but the shoulder is still stuck inside of the delivery passage. So actually there are certain kind of maneuver that we can perform. The first one, the most popular one, is macrobot maneuver. And then the second one, if it's not possible with the macrobot, it's not delivered yet, we have possibility to do wood maneuver, Rubin maneuver, or maybe Gaskin maneuver. Maybe let me show you about the video. A minute. Why is not open?
So I'm going to talk to you about shoulder dystocia. Shoulder dystocia. So first of all, the problem. Most commonly, it's the anterior shoulder that impacts on the symphysis pubis, and you can see that in the diagram there, where it just catches. So nothing is going. You're going to have to do something and maneuver as such to remove that and release that anterior shoulder that's stuck on the symphysis pubis. It affects between 0.1% and 3% of all births, and it needs to be managed efficiently to reduce neonatal hypoxia and effectively to reduce neonatal injury. There's a wide variation in the reported incidence of shoulder dystocia. Studies published between 1985 to 2016 reported shoulder dystocia incidence ranging from 0.1% to 3% of all births. Okay, so risk factors. Previous shoulder dystocia is the most significant risk factor, increasing the baseline risk by 10 times. Antenatally, risk factors include fetal macrosomia, being a big baby. Mums who have diabetes often produce babies that are really quite chunky and muscular and broad around their shoulders. Maternal obesity. And then going into labour, the risk factors are with a prolonged first stage of labour, a prolonged second stage of labour, augmentation of labour, and an operative vaginal birth. Having said that, most cases of shoulder dystocia occur in women without any risk factors at all. Therefore, it's something that is unpredictable and unpreventable. Clinicians should be aware of existing risk factors, however, and make appropriate recommendations for the best place of birth for the mum and her baby. Clinicians should be alert to the possibility of shoulder dystocia with any birth. As it can't be accurately predicted, everybody needs to know how to manage shoulder dystocia. And shoulder dystocia could actually occur at a home birth, in a birth centre, or in an obstetric unit, so it's something that everybody needs to be aware of. Okay, so complications. Brachial plexus injury occurs in between 2.3 and 16% of births with shoulder dystocia. The incidence of injury is 1 in 2,300 live births in the UK, with less than 10% of injuries causing permanent neurological damage. There are also neonatal fractures to be considered of the humerus and the clavicle, hypoxia and stillbirth, and maternal trauma, for example, postpartum hemorrhage and third-degree tears. Talking about recognition, the warning signs, that classic slow and difficult delivery of the baby's face and chin. When the fetal head is born, that it remains tightly applied to the vulva. Chin retraction, known as turtle head, when the head sort of comes out, goes back, comes back, goes out again. And the anterior shoulder fails to deliver with routine traction, which is we refer to as diagnostic traction. So the actual diagnosis is a vaginal cephalic birth that requires additional manoeuvres to assist the birth of the baby's shoulders after the head has been born and gentle routine traction has failed, and that's the RCOG definition. Beware of diagnosing shoulder dystocia too early and performing manoeuvres before attempting to deliver the shoulders with the next contraction after the head has been born. A diagnosis of shoulder dystocia in a previous pregnancy will affect future pregnancies. For example, it may limit their mode and place of birth. This is our management of shoulder dystocia algorithm as recommended by the RCOG. We can use these, laminate them and use them in the scenarios, in the workshops, and also on delivery suite as well. And I'm just going to show you a short video, which is on our Prompt YouTube channel, all about shoulder dystocia.
Delighted to be here today to talk about the prompt shoulder dystocia training. Kathy, one of our research midwives, and I are going to go through the manoeuvres today. So to try and illustrate for you how best to manage shoulder dystocia condition we all know is unpreventable, therefore we just need to be able to manage it as best we can. So Kathy, I wonder if we could get straight on with the manoeuvres. One of the things about shoulder dystocia I always think is it's a bony problem, and I always use the analogy of it's like a truck going through a low bridge. So can you imagine the cab of the truck gets through the bridge, but the back of the truck bangs up against the bridge. So can you see the cab is like the baby's head, and can you see the shoulder is stuck behind the pubic symphysis? So it's a bony problem. Just pulling the cab through the bridge is going to damage either the truck or the bridge. So the first thing, Kathy, I wonder if we could try is diagnostic traction. So the key issue here is you need to know there's an impaction. And it's really important, just as Kathy's doing, to pull in the direction of the spine, axial traction. Now, I think when we were young, people definitely used to pull right down, used to crouch down to try and pull the truck underneath the bridge. But we know now that that's more damaging. So just see, is it coming, yes or no? Okay. The first thing then to do is call for help. You need the team around you. You're going to need a person for each leg from Roberts, and we're definitely going to need someone to do superior pressure as well as the person looking after the baby's head. Now, first thing, call for help. Second thing, let's do McRoberts. So McRoberts, if you can imagine the bridge is tilted slightly forward, then making the bridge vertical makes the arch higher. The woman's the same size, but it just helps you get the shoulders, the truck through the bridge. So Kathy.
So I'll pull Mum down the bed,
Yep.
okay, and then I'm going to make her flat, and then I'm going to take her legs right back so her thighs are against her abdomen, and that lifts the bottom of the bed, okay, and I'll need somebody both sides so that we're both supporting the legs.
So once the bottom's off the bed, just as Kathy you said, then I think that shows you've got McRoberts in the right position. The second thing is, if you do suprapubic pressure, that presses down on the anterior shoulder. That's it, perfectly. And I think like a CPR position. And can you imagine, you need to push down on the truck, not the bridge. So Kathy's now pushing down and across to get the shoulders slightly in the oblique, so down in the oblique if you can. So if that is unsuccessful, we need to move to internal maneuvers. Just to give you an illustration again using the truck and bridge analogy, can you imagine the bridge is like a heart shape. If you could rotate the shoulders into the 2 o'clock or 10 o'clock, you've got more space to run through the bridge. However, if you can deliver the posterior arm, that's like taking the wheels off the truck, drops it down 10%, and you can run it through the bridge. So Kathy, I wonder if we could kind of attempt those two things.
So if I'm going to do an internal manoeuvre, I need to put my hand scrunched up. We call it the Pringle manoeuvre. So that's as if you were getting the last Pringle out of the carton. And I'm putting my whole hand in at the base, so at 6 o'clock, not leaving my thumb out. I'm putting the whole hand in with the aim that I'm going to find the posterior arm. Babies often come down the birth canal like pharaohs, and so you can grasp that posterior arm and just deliver it straight up, just like you were putting your big cards. The idea of that is that the baby's now one arm's width narrower, and so that anterior shoulder should drop underneath the pubic arch and you can deliver the baby. Any traction I do would be in an axial direction. So never downwards, but axial as if you're pulling along. And in this instance, we would deliver the baby.
Right. So let's say that delivers the baby for this one, but some babies, the arm is straight, and you can't deliver the posterior arm very easily. I always think, going back to the analogy, imagine the bridge is like a heart shape, then can you imagine if you could rotate the back of the truck to either 10 o'clock or 2 o'clock, there's more room than there is at 12 o'clock.
Okay, so this time I'm putting my whole hand in again, and I put my hand in at the bottom, and this time I can't feel the posterior arm, and therefore all I can feel is the shoulders. So I'm going to aim to rotate the shoulders. So I will push on the front of the bottom shoulder, and I'll ask an assistant to do suprapubic pressure towards that wall. So as we do that, we're rotating those shoulders into the oblique, and the shoulder is released and comes under the pubic arch.
And it still may be worth trying some diagnostic traction to make sure that's released. Now, those maneuvers in themselves seem to be effective. Certainly in the last series we published, 17,500 consecutive vaginal births, no further maneuvers were required. And I think it's important we do the maneuvers that we know as well as we can do.
This is the RCOG algorithm, which lists all of the maneuvers that we've just demonstrated here now. You can see that you take step-by-step approach to the maneuvers. If you get to the bottom and you've found that they haven't worked, it recommends you go back to the start and start with the McRoberts manoeuvre again. So take the legs out and put them back in. It may be appropriate if the mother's mobile to put her onto all fours position, because just the movement into all fours may be helpful at releasing the shoulders. We also have documentation, and this is the RCOG pro forma for documenting each manoeuvre, so that it's very clear after the event what actions were taken.
If you'd like to learn more about how prompt training can improve care on your labour ward, or to sign up for our courses, please visit www.promptmaternity.org or email us on info@promptmaternity.org.
And I'm just going to recap on a few of the points to make sure that they're quite important. So I want to make sure they're quite clear. Routine axial traction. Routine traction in an axial direction. Traction applied in line with the axis of the fetal spine. Routine axial traction is only applied to assess whether each manoeuvre has been successful. This re-emphasises that the only traction that should be performed is axial traction. Also, there's no need to wait 30 seconds between each manoeuvre. If a manoeuvre is unsuccessful, move on to the next step in the algorithm. There's a short video here on the right-hand side demonstrates that McRoberts position requires the mother's legs to be flexed sufficiently that her buttocks are lifted off the bed, moving her pelvis into an upright position. Suprapubic pressure. This demonstrates suprapubic pressure, which is carried out ideally from the side of the fetal back. Internal manoeuvres with the Pringle hand. This demonstrates how the accoucheur uses a Pringle hand in the sacral hollow of the mother's pelvis to perform internal manoeuvres, to either deliver the posterior arm or internally rotate the fetal shoulders into the oblique, the wider diameter of the pelvis. So, documentation. This is the performer that the RCOG recommend that we use. It could be that yours is slightly different, so familiarise yourself with yours. It's really important to highlight the importance of documenting which way the baby is facing at birth. For example, if a subsequent injury is noted to the baby's right side, and yet the position of the baby at the birth was facing to the left, then this injury is likely to have been caused by maternal propulsion against the sacral promontory rather than excessive and inappropriate traction. This detail and documentation could make a difference to subsequent litigation. So, what not to do? Nothing more than routine axial traction. Don't pull hard, don't pull downwards, and don't pull quickly or with a jerk. Do not use fundal pressure because that will increase impaction. Traction, if it is applied strongly, downwards or quickly, is associated with brachial plexus injury. Only routine diagnostic axial traction should be applied. If a manoeuvre has been performed and the baby has not been delivered with routine axial traction, then traction should be stopped and another manoeuvre attempted. Traction will not resolve a shoulder dystocia. Fundal pressure is associated with brachial plexus injury and uterine rupture and should not be used. Also, the mother should be discouraged from pushing unless it is specifically requested by the accoucheur to see if a particular manoeuvre has been effective. So, just want to talk a little bit about brachial plexus injury post-training. This publication here demonstrates how the incidence of permanent brachial plexus injuries were reduced to 0 after sustained local prompt training. This video, which is available on the Prompt YouTube channel, emphasizes the impact of a brachial plexus injury on an individual's quality of life. Using the RCOG algorithm and the Limbs and Things Prompt mannequin, it explains how cost-effective and clinically efficient YouTube channel. You'll see these in our supplementary booklet.
So we move to the next subjects. And then the most important also about placental abruption. If this placental abruption is not detected, it can lead to two possibilities. The first one is uterus scapulae. That means the blood accumulates in between uterine cavity and the placenta. And if you see this one, and the uterus getting blue-black, and this is very dangerous, prone to uterine atony. And then, or the next one, the next consequences, of course, the fetal death. So we have to be careful also about this kind of signs. If the delivery, usually we have a certain time cut off of the delivery time. For the gravida, 2 hours after the fully open of the cervical canal is already the cut off. We have to we have to perform the next action, whether is it possible to deliver the baby vaginally, and the other possibility, if not, of course, we have to perform cesarean section. If this, and then for this multipara, of course, the tolerance for the fully open cervix only 1 hour. The baby have to be born. But if the longer period, this happens maybe about 1 month ago. This one from the referral from primary care center, and then with the protected start labor, and the patient come 4 hours after the fully open of the cervical canal, and the baby didn't come out from the vaginally. So we have to evaluate whether there is any obstruction, maybe because the bony pelvis, some kind of disformation or disproportion, and then maybe the head of the baby or so. If you see this one, yeah, this one we call it bundle his side, yeah, and this one is very we have to be very careful, because it can lead to uterine rupture, and in long term also can lead to vulva edema. And this patient after delivery having a problem because incontinentia, retention urine, because of the obstructed labor, and of course this can lead also in a long-term problem with the urinary tract. Yeah. So we move forward to the postpartum period, and the most common one is bleeding postpartum. There are 4 T's that we need to prove. The most common one is the tonus. So we can prevent the atonia uterine using some contraction medicine like oxytocin, and we have to be careful if the patient already have not eaten for longer time. That means can be also hypoglycemia, which uterine muscle need glucose for the muscle contraction. And then the next one, we have to prove whether the urinary bladder, is it empty or not. If this urinary bladder full with the urine, of course the uterine muscle cannot contract properly. Therefore, we need to perform catheterization. And then this medication actually is one of the gold standard for uterine atonia in Germany. We use it Nalador. The metabolite is sulprostone, but I'm not sure whether this is available in Indonesia. Usually we use metergin, but the metergin, there is a disadvantage, having a side effect, with higher blood pressure. So we have to be careful if the mother already having hypertension. And then the next one, misoprostol, there is a drug of choice, but unfortunately this misoprostol work later on after 30 minutes. and takes time. Therefore, it's not as fast as the other IV medication. And then if atonia happens, in developed country, they commonly using Bakri balloon. This is a Bakri balloon. So we put the catheter inside, and then after that we fill with the fluid. It can deflate until about 400, 500 cc. And from the IV, we give some kind of contraction medication. And then from the below, we put this one to make a pressure to stop the bleeding. And there is, of course, an opening. And if there is still blood here accumulation, they will come out through this opening into this urine bag. I mean, the bag for the balloon. But if this kind of procedure the bleeding still on, there is no condom alternative for this procedure, we can perform, we use of course sterile gloves, and then we put one hand inside and the other hand from the upper part, and then we perform adequate pressure for a couple minutes, maybe possible 5, 10 or 20 minutes. It depends whether the bleeding stop or not. It's actually very simple, but it's very useful. And then the next, second T, most important, is the tissue. If there is any kind of placenta rest inside or adherent, it can lead also to the profuse bleeding. Therefore, ultrasonography is very important. If there is any increasing of hemorrhagic postpartum, we need to prove whether there is still placenta tissue. If there is, of course, we have to perform curettage. And then the third one is tear of the tissue. Maybe like I told you before, the bundle sign or dehiscence, and then uterine or cervical laceration. We need to perform speculo, of course, or maybe deep vaginal tear, or maybe fourth degree of the perineal tear. And then the last one is thrombin. Thrombin, that means we need to prove whether the thrombocyte is in normal level, but there are certain kind of problems with the coagulation, such as factor VIII problems. Of course, we can give the substitution with fibrogamin or any other factors like minirin, PPSB, or fresh frozen plasma. But this preparat, I'm not sure whether available in Gorontalo. So we move forward into the breastfeeding time. Because this tema, I mean, for the third conference about the hypertension in focus, there are still, we have to discuss about this antihypertensive in breastfeeding or postpartum period. It's the same like before, but there is a bit tolerable for the other kind of drugs. Such as ACE inhibitor is possible during the breastfeeding time. In pregnancy, of course, we should avoid it because a problem for the kidney for the babies. But after breastfeeding is no problem anymore because the secretion of the blood into the milk of the breast in the breastfeeding period is not significant. It's very, very low. So it's not the baby will be not affected. But please do not use diuretics. Diuretics only used in strong indication. Why? Because diuretics can lead to the stop of the milk production. So actually this is, I mean, additional fourth trimester, not really fourth, I mean in trauma. I mean later in life. Because of those kind of problems, it can lead to fatal consequences later in life, such as cerebrovascular disease, due to adverse pregnancy outcomes like heart failure, stroke, and then cardiomyopathy, valvular problems of the heart, and then coronary artery disease. Therefore, healthy pregnancy is very important, and close monitoring during the pregnancy can reduce the later diseases in life, maybe above 45 years old. So I had a prank case maybe about a week ago. The patient came about 2 o'clock early morning, and then she told to our midwife that she is pregnant about 30 to 31st gestational age, and then she had abdominal cramping, but after the CTG examination, they cannot found any fetal heartbeat. And of course, ultrasonography in this case is very important. And what I found out, actually the urinary retention, what is happening. And then this one is the uterus, and this one is the vagina. And because of this findings, I ordered the midwife to perform pregnancy test. And of course, this one is actually negative. So be careful. This patient do not willing to have ultrasonography throughout the pregnancy. She just believes that she is pregnant, but actually, unfortunately, not. That's why ultrasonography nowadays is very important. Okay, thank you very much for your kind of attention. I hope give some more information and will improve your skills and knowledge for the obstetric in emergency. Thank you very much.
Hello. Thank you very much indeed for the interesting presentation. And now we are moving to the next part of this session, which is Q&A, question and answer. So to all participants who have any question, you can raise your hand, or maybe you can chat, you can type it on the chat box. How to? Oh. Okay, so we have our first question from Miss Nanda Wahyudi. Please. Miss Nanda Wahyudi, you can announce your question.
Okay, thank you, Mr. Rahman. Good afternoon, Mr. Andreas.
Yes, good afternoon.
Yes, Mr. Andreas, I want to ask you some question. Based from my midwifery student patients, we found some PROM patient, premature rupture membrane, to term immediately cesarean section. But based on theory I have read, patients with PROM do not be immediately cesarean section. We must give oxytocin first. Mr. Andreas, in your opinion, what the reason patient with PROM must be immediately cesarean section? In this case, mother and fetus have a good condition. Thank you.
Okay, thank you very much for the question. Actually, there are certain criteria. Yeah, the PPROM can happen in any.
No, I'm sorry, Mr. Andreas. KPD ateram.
Oh, KPD ateram. Okay.
Yes.
So in ateram cases, actually the PPROM premature rupture of the membrane doesn't necessarily to perform cesarean section. Why? It depends on the size of the baby, of course, in the first place. The second one, it depends on the CTG. And then the third one, of course, maternal factors, whether the pelvis bone is it possible or not. And then the fourth one, is there any sign of chorioamnionitis? So this factor we need to be evaluated. Chorioamnionitis, that means there is a beginning sign of the fetal tachycardia, maternal tachycardia, or higher body and also maybe liquid already fully dilated. Also, of course, we can give maybe some oxytocin to accelerate the cervix is still not open and not rough enough. Of course, as happen. Yeah. So there are many factors. I cannot tell you why. Maybe in those patients that you see why they perform cesarean section, but maybe those kind of sign happens. And then I'm not sure your question. The second one, you have the repeated cesarean section. Why you have to be performed? As you know, in Indonesia, the doctor usually having different places to work, not only just one places. There is increased sign of the uterine rupture after one. If you try to perform vaginal birth after the cesarean section, this VBAC. VBAC about the uterine rupture about 4%, and to call all the doctors in one time in short period of time, I'm not sure is can be done in very fast. In less than 20 minutes. Because experience here, we can maybe wait until 2 hours, 3 hours, personal, until everything gather in this operating theater. The setting is very different, because this medical system in Indonesia is also different compared to the other countries.
Okay, Mr. Andreas, if as a midwife, if we find a PROM patient, do we immediately refer the patient to the hospital, or we can deliver the patient at home with oxytocin induction?
Yeah. In my experience in Germany, a midwife can deliver the baby less than 18 hours at home, because after 18 hours, we have in the PROM cases, we have to give antibiotics injection. So this antibiotic injection do not allow to administer outside the hospital. We know that antibiotics, there is low potentiality of allergic to develop, but if happens during home setting, I'm not sure whether the midwife bring any emergency medication for the anti-allergic. And also, if the severe allergic reaction happen, it's very short time and can lead to death. That's why they have certain criteria in Germany. And the next one, I'm not sure also about the monitoring of the heartbeat of the baby. Here in Indonesia, it's very common using Doppler only for certain period. But as I learned before, they perform CTG during delivery process almost throughout, especially in the active phase and also labor phase.
Okay, for the antibiotic, we must take injection antibiotic or we can make pakai apa?
Oral.
Uh,
Use oral medication.
oral, yes, oral antibiotic.
In my opinion, actually, IV injection is better compared to oral. Why? Because there is bioavailability in the blood. Oral usually we give less dose, the first one, and the second one, there is a passage through the intestine and liver, and not a whole of the antibiotics go to the blood of the mother. And then there is also placenta barrier from mother to the fetus. Actually, there is reduction quite significant if we give injection maybe 2 grams of cefazolin, only maybe go to the fetus only about 10%. The oral one supposed to be lesser than that. So there is not really adequate protective effect from any kind of infection. In the long term, if we neglected with these antibiotics, can lead to baby infection, neonatal infection. The severe form is from infection from beta streptococcus, usually late infection after 14 days. And if the mother uneducated and then the baby having fever and then high body temperature, and can lead to long-term consequences like cerebral palsy. That's why antibiotics in developed country, they use standardly using IV injection.
Okay, Mr. Andreas, what kind of antibiotic we can use? Like antibiotic broad spectrum or what kind of antibiotic?
So in Germany, we use commonly using cephalosporin first generation. Yeah, and then the alternative using ampicillin.
And amoxicillin? What?
Yeah, beta-lactam group. Ampicillin, not amoxicillin. The injection form is ampicillin.
Ampicillin, okay.
But if the patients suffer from allergy from the beta-lactam group, using cephalosporin is quite safe. Actually, cephalosporin having allergic reaction is quite low.
Okay. Okay, thank you, Mr. Andres, for the answer. Terima kasih. Kamsahamnida.
Ya, kamsahamnida.
Hello. Okay, thank you to Ms. Nanda Wahyudi for the questions. And before we move to the next questions, I would like to ask Mr. Andreas Winarno, could you please keep your video on, sir? Because we lost your video.
I didn't turn off. I'm not sure what happened.
Yeah.
Sorry.
Thank you. And the next question, we still have the next question from Miss Nancy Olii. So Miss Nancy, please announce your question.
Is it clear my voice?
Yes,
Okay.
please.
Can hear you. Okay, doctor. I have read.
Oh, ini pakai ini juga ini. Ini.
Hypertension. If
we not treat it properly, that condition can cause complications like such as loss of vision or even death. And my question is, could you please explain why the condition can be such as loss of vision? Thank you.
So, hypertension crisis, the most common one is not a vision problem. And the most common one can lead to cerebral hemorrhage. Now, this could also happen in retina. Yeah, that's why the patient may suffer from loss of the vision. It's not only that, is hypertension of the blood pressure, I mean the vasoconstriction of the blood pressure, have happened through all of the blood vessel, not only just the brain or the eyes, but also in the heart, in the kidney, and also in the liver. If the patient do not take any proper medication to reduce the blood pressure, of course this will injure of the organs due to hypoxia, and also if you can imagine, if there is any increase of the pressure inside of the water sewage, it can it's very dangerous because it can damage the cells. The cell is very, very sensitive of the body. If one damage it, it lead to the death of the cells, and it won't be regenerated anymore. Yeah. Why can lead to the death? Yeah, it depends. For example, for the cerebral hemorrhage, whether is it severe cerebral hemorrhage or cerebral infarction due to hypoxia, the area affected getting bigger or maybe compressed to the long-term kidney problem, kidney failure, and they need to have dialysis. Is it answering your question?
Yes. Thank you, Doctor.
Okay, thank you very much to Ms. Nancy Oli for the questions. And we move to the next question, which comes from me, the moderator. So I would like to ask you a question, Dr. Andreas. Based on my experience, I have seen some people who is pregnant, and they have visited the doctor to control the pregnancy. But when it comes to 7 months, some people lost their baby. I would like to ask what is the cause of this a problem, and how to avoid this problem so it will not be repeated in the middle of our community. Thank you.
There are factors that lead to intrauterine fetal death. Can be from the umbilical problem, umbilical cord maybe tangled, and then maybe there are possible of genetic problem, or maybe some more others and so on. If you would like to prevent, in some cases, of course, we can prevent it, but in some others, we cannot really prevent the fatal death, because so many factors that play into a role. For example, the compliance of the patient, and then the ability to perform advanced diagnostic, and then ability to measure the blood perfusion of in the umbilical cord, and if the patient already having complication before, like hypertension, diabetes, whether they take the medication regularly or not. In some others, maybe genetic problem. If like genetic problem, we cannot really prevent it. If the genetic problem already happened, we cannot change anymore.
No. Okay, thank you, sir, for the answer. So, to the next question, to all participants, if you want to ask directly to Dr. Andreas, you can raise your hand on the chat room, on the Zoom meeting, of course. And if you find English as your obstacle, you can write your questions on the chat box, and then we will read it to Dr. Andreas. Do we have any questions on the chat room? Okay, so we have 6 questions. The first is from Fitriani, from Health Polytechnic of Gorontalo. Her question is, what if hospital institutions don't have adequate equipment for emergencies, for example, in neonatal care?
Actually, there are certain criteria for the first center, secondary center, or tertiary center. Of course, there are certain, the manpower play an important role, and also the equipment. And like in Germany, there are certain after requirement, if they're already labeled like no perinatal center, that means there is no possibility to deliver the baby less than 36 gestational age. For the perinatal level, the third perinatal level, that means the hospital can deliver the baby above 33rd gestational age. For the second perinatal center, they can deliver the baby above 29th gestational age. Or the first perinatal center, they can deliver the baby throughout the pregnancy, regardless of the gestational age, usually after 23rd gestational age. But in Indonesia, I'm not really sure whether this criteria also already developed well. For sure, for the tertiary center in English, but first perinatal center in Germany, that means we have to have this neonatologist. This is one of the most important criteria, because neonatal problem is quite vary, especially in the extremely preterm birth. Like surfactant here in Gorontalo are not available. Actually, this surfactant is very important in the baby who delivered before 32. Usually, they have to have it. It's not enough using only just lung maturation with dexamethasone or betamethasone. If the baby have to be born unfortunately, if there is any sign of acute respiratory distress syndrome, surfactant is very essential uh, to to be administered.
Hello. Okay, thank you. We move to the next question. Okay, next from Sri Yayan Makjun from Health Polytechnic of Gorontalo. She asks about the causes of maternal mortality include postpartum hemorrhage, eclampsia, and ectopic pregnancy. Those are also included in emergency cases. What efforts can be made to reduce maternal and infant mortality in these cases?
Like I told you before, regular screening and checkup is very important. For the ectopic pregnancy, the ultrasonography examination should be performed in between 6 to 8 gestational age. But many of patients, they didn't perform it. Just thought that pregnancy will be normal, everything will be normal, and then wait until later on, maybe after 15 weeks of gestational age, or maybe no screening until almost delivered the baby. Yeah. But unfortunately, the reality is like that. So education of the patient is very important, and also the awareness and also compliance of the patient.
No. We move to the last question. And it comes from Regina Fatriansah Jafar, a midwifery student at Gorontalo Health Polytechnic. Here she asks about how to prevent the severity of emergencies that continue to occur in pregnant women, and how to know the emergency signs that often occur and are not recognized, so that they can be fatal for pregnant women and their fetuses.
So I think you have to learn quite well for it. Nowadays, social media and also can be very helpful if you use it properly, like YouTube. But many people nowadays like to do for other things like playing games, and also for TikTok or maybe Instagram. But actually, if you would like to learn quite well, you can find nowadays quite well in YouTube. Many things you can find it there. And also you can read a lot, like Google, seek some form information, and then this conference using English is very useful also to improve your English language capability. That's why you can play, of course, you can do it for social media, but please also learn well for this one, for obstetric cases. And also exposure for the cases also important. I mean, like when you have a rotation or you become a midwife one day, and please try to do to try to examine the patient carefully and properly. So early detection is very important to prevent any kinds of fatal consequences.
Okay, thank you for all the answers. And we actually still have some questions, but we found the similarity between those questions. So for the efficiency of time reason, we decided to not announce those questions. And in previous slide, during your presentation, so we found internet connection problem. Therefore, we didn't observe your video, which is your attached the link from YouTube in your PowerPoint slide. Therefore, we would like to ask you to be able to send the link of the YouTube video, which is your attached in your slide.
Oh, sorry, really? No one give me the notification. Wait a minute. I try to find it. I thought this worked well.
Yeah, yeah. We just hear the voice, not the video. We thought it was from YouTube.
Oh, okay. Sorry, wait a minute.
Yeah.
Give you the link.
Yeah, it's okay, sir. And
So here we go.
Shoulder dystocia. So first of all, the problem. Most commonly, it's
okay.
Also,
Okay, we
message I should everyone.
okay, we have seen it on the chat box. Thank you. And okay, and we move to the last part of this session in the second day of the International Conference on Midwifery and Health Science 2023. And this part is we would like to announce your certificate as the main speaker in this session, of course. And we would like to represent our Director of Health Polytechnic of Gorontalo, and also we would like to represent our Head of Midwifery Department, Health Polytechnic of Gorontalo. We would like to say thank you very much indeed to attend our invitation in this seminar, and hopefully this is not the last of our meeting. Maybe next time in the fourth edition of the ICMHS in 2024, we will be able to keep in touch. Okay.
Thank you also for the invitation.
Yeah. Thank you, Doctor. Okay. After all of the part of the session, now I will officially close this session, and I would like to give this the next section to the Master of Ceremony. Thank you very much indeed.
Thank you. Bye. Take care. All the best for all.
Thank you, Doctor.
Okay, thank you, Mr. Dr. Dr. Andreas Winarno. And then thank you for the moderator, Mr. Rahman Suleiman, for his time as moderator. So, to the all participants, ladies and gentlemen who attended the conference, with the end of all the speakers at today's conference, allow me to summary the speakers who have provided extraordinary knowledge. On the first day, we have listened to presentation from Dr. Dev Listiono with the topic, the impact of assisted reproductive technology on the risk of preeclampsia during pregnancy. And then Mrs. Dr. Runjati from Pokja, Indonesia, with the topic, detection and management of hypertensive pregnancy with ANC service. And the last speakers for first day, Dr. Sarena, PhD, RMRN from University of Brunei Darussalam, with the topic Understanding the Healthcare Seeking Behavior of Pregnant Women with Hypertensive Disorders of Pregnancy in Preventive Pregnancy-Related Complications due to HDP. So then today we have listened to material presentation from Mrs. Patricia Lynch, PhD, from Virginia State University, with the topic Nutrition Status and Diet Management in the Prevention of Hypertension in Pregnancy. And then Mrs. Aitani Miju from World Health Organization Regional Office for Southeast Asia CRO, with the topic World Health Organization Support to Strengthening Midwifery in the Southeast Asia region. And then the speakers 3 to second day, Mrs. Sri Sujawati, SSTM CAP from the Midwifery Department of the Gorontalo Health Polytechnic, with the topic Humanity Approach for Preventing Hypertension. And the last speakers, Medical Dr. Andreas Winarno, Specialist Obstetrician and Gynecologist, with the topic Emergency in the Obstetrics. Thank you also to all the moderators who have had the opportunity to help becomes moderator. Hope to see you another session. Ladies and gentlemen, to all participants, we need to inform to all participants that tomorrow is the last day of the 3rd International Conference on Midwifery and Health Science 2023. Tomorrow there will be a poster and oral presentation session. So for all poster and oral presentation participants, please join at the time determined by the committee. Before we close today's events, representing the committee, apologize if there are still errors in the today implementation. That's all. I am Ahmad Fahmi Soiba, Master of Ceremony. I am leaving today. I will see you tomorrow. Wassalamualaikum warahmatullahi wabarakatuh.